quickly. Honorable delegates, distinguished scholars, luminaries, respected speakers, eminent sponsors, and faculty members, welcome to this year's SODC conference. It is only because of the common effort of each one of you that we have been able to gather today. Our previous conference was a major success, evident from huge participation across the globe. The participants gained exposure of theoretical knowledge through practical experience involving hands-on workshop and live demo sessions. It is an honor for me to stand here today in an independent nation. We are proud to be Indian citizens. Let us pay tribute to our country. May I request you all to stand up and sing together the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Jay. Thank you. We will have our auspicious lamp lighting ceremony as a tribute to Mother Knowledge. May the darkness of ignorance be removed by the dawn of wisdom. I request Dr. Vijay Bakaya, Dr. Sukesh MS, Dr. Viral Desai, Dr. Neeraj Pandey, Dr. Maya Vedamuti, Dr. Madhuri Agarwal, Dr. Akhilesh Jain, Dr. Sejal Shah, Dr. Gurinder Jeet Singh, Dr. Vikram Mahajan, and Dr. Sahil Metpuri for lighting the lamp. Place that sheet also. I have the opportunity to introduce Dr. Akhilesh Jain today. Dr. Akhilesh Jain is Chief Consultant and Hair Transplant Surgeon at Outblooms Clinic, which is one of its kind for dermatology learning. Dr. Akhilesh completed post-graduation training in dermatology from PGI Chandigarh, a premier institute of India. His interest in dermatosurgery led him to successfully complete dermatosurgery fellowship at Nanavati Hospital, Mumbai. He is a pioneer in the field of hair transplant in India. Dr. Akhilesh specializes as aesthetic dermatologist, hair transplant surgeon, trichologist, and dermatologist. He holds tight command in his area of specialty. May I now request Dr. Akhilesh Jain for his welcome note.
Good morning, all respected dignitaries and valued guests. I heartily welcome you all to be a part of this conference. I'm sure that the takeaway from these 2 days will give you an enriching experience that you can utilize it forever in your professional life. We are certain that your active participation and presence in the conference will significantly contribute to the success of this event. Thank you.
Thank you, Dr. Akhilesh. We are fortunate to have the presence of Dr. Madhuri Agarwal amongst us. Dr. Madhuri Agarwal is a learned professional, having done her MD Dermatology from LTMMC Mumbai. Dr. Madhuri is one of the leading dermatologists and aesthetic physician. Her skills and expertise are a result of her extensive grooming in the fields of cosmetology and dermatology. Dr. Madhuri is the founder and CEO of Yavana Aesthetics Clinic. She always ensures that her patients always look and feel their best. She's a one-stop destination for all aesthetic treatments in the country and abroad. We welcome you, Dr. Madhuri.
Good morning, friends. And yes, I'm going to call everybody because they are your dear friends, teachers, colleagues, delegates, and I'm really looking forward to today's session. So we had a wonderful year when we did the first SODC. We had live sessions, workshop, and we got such a response that we didn't expect. So I personally feel there's a lot of need to see what are the latest innovations, what are we all doing in our practice, what are we learning from each other. So I welcome you all on this joyous experience for the next 2 days to know what is the latest advancements with mind-blowing experts which we have got from all across India. They are world renowned and we bring them to you today. So please take the opportunity to learn, ask your questions, get your doubts solved, and look forward to meeting all of you personally. Thank you.
Thank you, Dr. Madhuri. I'm extremely elated to introduce our organizing secretary of SODC, His Excellency, Dr. Sahil Mrikpuri Sir, completed his MD Dermatology from PGI Chandigarh. His key area of interest is lasers and hair transplant. Leaders are born to lead the way to success. A leader knows his way very well. When there is no path, they leave a trail. Dr. Sahil envisioned to pave a path towards the creation of one of its kind dermatological conferences. SODC aims to create an unparalleled impact in the dermatology field by providing a platform for professionals to equip their skills and upgrade their skill sets. We are proud of all your achievements. We request Dr. Sahil to come on the stage and address the opening speech.
Good morning, everyone. It is a true pleasure to welcome you all, valued dignitaries, and honorable guests today. We envisioned and achieved to build a common ground for all experts to share and learn their area of expertise in dermatology. Four strong pillars of SODC are international faculty, interactive sessions, workshops by Stalwarts, and dermatology practice management. These strong pillars of SODC built in high elevation in the dermatological world. We are confident today that today's program will deliver high quality of presentation and hand-on sessions by distinguished and renowned faculties across the country. It's all about challenging yourself to the best. Be the leader of your own. Let us all strive the best and create an impeccable impact on our chosen fields. We are certain that your active participation and your all involvement in the presence of this conference will significantly add to the learning process. So on the behalf of organizing committee, it gives me immense joyfulness to extend a wholehearted welcome to each one of you to preside over this event.
Thank you, Dr. Sahil, for your inspiring words. Now I invite Mr. Puneet from BTL for the launch of BTL Lounge.
Good morning, everybody. Senior doctors. I would like to take this opportunity. I'm Puneet from BTL India. That 10 years back in 2011, BTL started its Indian journey in the month of October, November. And thanks to Dr. Sahil when he discussed about after COVID, this physical meeting, I was so much excited that I'm getting this platform to also celebrate decade of BTL in India. So to launch BTL Lounge, the specific reason for BTL India is to showcase in body shaping devices. We are globally #1. In India, we are trying to serve our esteemed doctors with the same technologies. And we have launched a state-of-art technology, HiFem, 2 years back. We could show HiFem through online media, through webinars, but the first time it is available at lounge area, which is a special lounge area for BTL. You all are invited to book a slot for 30 minutes, just experience M-Sculpt and be the experience holder for the state-of-art innovative technology. Thank you, Dr. Sahil.
Think of how annoying it is to do 200 crunches at the gym every day. Now do that 99 more times. That is what a half hour under the M-Sculpt Neo gets you. 4 treatments is like an entire year of training in less than 2 weeks. We're talking more muscle and less fat. Hey Shaq, I challenge you and your friends to the M-Sculpt Neo Challenge. Can you do 20,000 sit-ups in half an hour? You probably have a better chance of making 2 free throws. Why do sit-ups when you can do M-Sculpt Neo? Talk about Shaq's in a fool.
So thank you so much.
Thank you, Mr. Puneet. Now for the first session on fundamental nuts and bolts of botulinum toxin. It's an honor to welcome the chairperson, Dr. Vijay Bakaya, Dr. Vikram Mahajan, and Dr. Gurinderjeet Singh. I request the chairpersons to take it forward from here.
Good morning, everyone. It's a pleasure to start a physical meeting after a gap of 2 years. I feel honored to have been invited to chair this session. As a teenager, एक गाना होता था चेहरे पे से जरा आंचल जब आपने सर काया दुनिया पुकार उठी दो चांद उतर आया. So we are in an endeavor to make face like moon for each and every one human being. I invite Dr. Neeraj Pandey, who is a moderator of his session. Dr. Viral Desai to start his lecture on. He'll be speaking on botulism. Thank you. I think we have forgotten our habit. Thank you. Sorry for the hiccup, Dr. Viral.
No, not at all.
Dr. Viral, to continue.
Thank you, chairpersons, for the introduction. A good place, good people, good food, good wine. We must never forget the wine. Great speakers, a great scientific program that we are looking forward to for the next 2 days. Enthusiastic, hardworking, very hospitable organizers, and of course, a physical meeting after very, very long. I'm sure a big cheer to that, and we all are looking so much forward to this. Humbled and honored to be a plastic surgeon amongst the stalwarts of dermatology, the best in the country. Thank you, Madhuri. Thank you, Sahil. Thank you, Akhilesh, for inviting me. And of course, what we've learned from the last 2 years' experience is live in the moment. And this is the moment that we must live in. This is the only moment that matters. And before we enter into the world of Botox through the eyes of a plastic surgeon. So my talk today is going to be about botulinum and the basics about it. Now, the history of botulinum. 1992, botulinum was used for a long time for therapeutic reasons. And in 1992 was the time when carothers used it first for treating of glabellar lines. And after that, there was no looking back. This was the revolution that changed the field of non-surgical work in aesthetics. With the introduction of botulinum into for the non-surgical reasons, and there have been many indications, some offline indications which are not which are not FDA approved, but we're still using it routinely. And of course, I'm going to be talking about my indications are going to be about the upper face, the forehead lines, the frown lines, the horizontal lines, and of course the crow's feet. These indications are all approved. Now, before you start injecting, you must inspect and palpate and observe. Ask the patient to contract the muscles, of course, a detailed anatomy, observe the patient's functional anatomy, note the pattern, the bulk of the muscle, even by palpation and by looking at it. Pre-existing asymmetries, these have to be documented and discussed with the patient in detail. Discuss the desired outcomes, expectations with the patients, very important. Decide the patient's treatment plan, and of course, customize the treatment accordingly. Informed consent, photo documentation, and strict aseptic precautions are very important to prevent any complications. Remember that injection points and dosages, what I'm going to discuss, are not standard for every patient. Do not, when you're learning, especially in the beginning, and you're told you have to inject only 2 units here or 4 units here or 6 units or whatever, it's not going to be absolutely true for every single patient. You have to individualize according to the patient, the muscle mass and the anatomy and what you desire. Now, of course, when you talk about frontalis, this is responsible for the forehead, horizontal forehead lines. Typical dosages are between 8 to 18 to 8 to 20 units. Then you're talking about the corrugator complex. The corrugators mainly made of the glabellar lines, which are going to be the corrugators, the depressor supercilli, and of course, procerus. And the medial fibers of the orbicularis oculi. You typically inject between 14 to 24 to 26 units in this area. Then you're talking about the crow's feet. When you're talking about the crow's feet, you're mainly talking about the lateral part of the orbicularis oculi muscle. And here it's going to be roughly 12 to 20 units per side. Now, if we notice here carefully, we have 4 muscles that we're going to discuss, and of course, a small little muscle called the depressor supercilii. The frontalis is a brow elevator. It causes the horizontal lines on the forehead. The corrugatus pulls the eye medially, causing the frown lines. The procerus and depressor supercilii, they cause the horizontal nasal lines and the frown lines, and they are brow depressors, strong brow depressors. And orbicularis oculi laterally causes the crow's feet, and of course is a strong brow depressor laterally. Now, if you notice, there's only one brow elevator, which is the frontalis. Hence, always undertreat this muscle because this is the least forgiving muscle of all of these. The eyebrow is the key to a good result because every single muscle that you treat in the upper face will affect the position of the eyebrow. So you have to look at the eyebrow carefully, and that is finally the key to a good result. So here we'll be talking about the glabular lines. So here we're talking about, you're going to discuss mainly the corrugators, the procerus, and of course the depressor supercilii, which is a small muscle. Talking about the corrugators are a deep muscle medially. They originate from the frontal bone, from a ridge on the medial side of the frontal bone, and they go laterally, insert on the skin out there. So here you can see when I'm reflecting the frontalis muscle. Here is where the origin of the corrugators come in, and the corrugators from the bony insertion go into the skin. They insert into the skin out there laterally. So the injections should be deep medially and superficial laterally. There is a space there. If you inject on the bone, So, sorry, this is going to play again. There's a space there. If you inject directly on the bone, there is a chance that the toxin will go into the orbit and it will go to the levators. In that case, it will cause ptosis, which is the most dreaded complication when you're treating the corrugators. So be very, very careful when you're injecting. When you're injecting directly on the bone or injecting lower down, you may hit the levators, and that's something which we must all avoid. So again, just repeating, that you reflect the frontalis, the corrugators is deep medially, goes in superficial laterally, inserts into the dermis out there. So that is where the muscle insertion is laterally, and of course the bony insertion medially. This is the space I was talking about. We should avoid this injecting into the space so that no migration of the toxin. Then, of course, the next muscle is the procerus, which is like a fan-shaped muscle. The procerus is right in the center, responsible for the horizontal lines, originates from the nasal bones and inserts into the skin right above at the root of the nose. Vessels, not so important for botulin, except for the fact that you may end up causing a lot of bruising and swelling in case you inject into one of the vessels. So, and of course, this is where the depressor supercilii, the forceps point out towards the small muscle at the superior medial corner of the orbit, which is the depressor supercilii, strong brow depressor. You may need to inject it if you want medial brow elevation. So do not ignore this muscle. Now you get various kind of patterns. In the first picture, you can see like a 11 pattern. In the second picture, a 1 pattern. And in the third picture, a scrunch. So accordingly, customize your treatment. What I'm doing now is marking. You ask the patient to frown. You see the medial end of the corrugators where you see the frown lines. You see the dimpling on the lateral end. So notice the dimpling on the lateral end. Mark it carefully. That is the lateral extent of your muscle. And where the dimpling is fading away, that is the main bulk of the muscle. So that is the main bulk, and that is the lateral end of the muscle where it becomes superficial. So that's very typically how you mark the muscle. The muscle can be short or it can be a broad, long muscle extending right up to the lateral 2/3 of the eyebrow, or it could be a very short muscle. So individualize the treatments accordingly. And the procerus, you can see from the root of the nose, superiorly and inferiorly. Those are the supratrochlear vessels at the medial end of the orbit, which run up. You feel for the supraorbital notch, and then the supraorbital vessels are marked there. So these are the 2 vessels you must avoid in order to prevent any kind of bruising. These vessels typically become superficial around 2 centimeters above the supraorbital rim. So remember this is more significant when you're injecting fillers, not so much for botulin. So this is the extent of the muscle. Individualize, see the dimpling and mark it. Accordingly, this person has a strong and a broad muscle. So I would choose 3 injection points in him. 1 point medially, 1 point in the center. Sorry, the video just plays again. Just 5 seconds. Again, the 2 vessels, supraorbital and supratrochlear. Yeah, the medial point, the middle point, and then the lateralmost point, which is going to be a superficial injection. Sometimes it could be 2 points, sometimes 3 points. So individualized depending upon how big or how strong the muscle or how wide the muscle is. Now injection. So I'm steadying the forehead, I'm steadying the head with my fingers. I'm keeping the thumb there so I do not go down into the orbit. I'm injecting deep. This is a deep injection at the medial end because the muscle is deep out here. Then again, it's half needle depth, a little, not too deep, not on the bone. It should not go down to the levators. Inject around 4 to 6 units at this point. And of course, a superficial injection laterally where the muscle actually inserts into the dermis, which becomes superficial. And just 1 or 2, couple of units at this point is enough. So of course, then let's talk about the proceres. We already discussed this. It starts at the nasal bone and nasal septum, and it goes up and inserts into the dermis of the skin at that region. It causes a strong horizontal lines and strong medial brow depressor. You inject 2 to 4 units above and below, or you can inject a single 4 to 6 units on right in the bulk of the muscle on top. So this is how you inject the proceres. Complications, of course, the most important thing is lid ptosis. I've already discussed this. Do not inject right on the bone. Do not inject lower down. If there's migration into the levators, of course, you cannot do anything but hand holding. There's no treatment for this. So be very careful. So of course, take home, inject deep medially, superficial laterally, and do not forget to look for depressor supercilli if you want brow elevation. Now the frontalis. The frontalis is a broad, thin muscle, and it is the only brow elevator. It's the only brow elevator that we're going to treat in the upper face. It typically originates from the galea superiorly and then goes down and inserts into the muscle complex and skin at the supraorbital ridge. Okay. So this is the extent of the muscle. It's a very thin and flat muscle. So try to give small doses throughout the muscle rather than giving large boluses. Of course, there is an M technique. We'll be discussing that later, but do not try that. Of course, avoid vessels, not much of significance when you're talking in botulinum toxin, but mainly in terms of look for the vessels, avoid them so that you do not have too much of bruising and swelling. So this is how, that's where the frontalis originates. It inserts into the supraorbital rim out there. It merges with all the muscles like the orbicularis oculi, the corrugators out there. So this is a center. I just mark around 5 millimeters from the center because that is where the aponeurosis is. You do not need to inject here because there is practically no muscle here in most of the cases. Then at the junction of the peak of the eyebrow or the medial 2/3, lateral 1/3 is the lateral extent. Now ask the patient to look up, look for the lowest lines and stay above these lines. You do not want to inject lower down, otherwise you will cause the brow to drop. So inject above these lines. If you get the Spock effect, then that's the point where you need to inject in order to reverse it. If you get the lateral muscle pulling up the eyebrows too much, that's where you need to inject. So now this is where your muscle lies. This is the entire extent of the muscle. Mark out 3 to 4 points, 5 points, whatever you're comfortable with. You make sure that total dosage is more important. Diffusion of the drug is more important. When you're injecting initially, don't give large doses at one point. Try to distribute the drug. You'll have less side effects, definitely. So of course, generally leave the muscle below the last line, leave it 1.5 centimeters above the supraorbital rim, and the typical dosage, undertreat this muscle. You can always call the patient back. Give 6 units, 8 units and call the patient back if you want to give it. Do not try to overtreat. Pinch the skin with a very thin needle, pinch the skin, go inside, raise a papule. This is how you inject for the frontalis. So we can see carefully now. like it's a superficial muscle, there's hardly any fat. You can see the needle, gradually inject. You must see a papule. If you see a papule, you are the right plane. If you don't see a papule, you're probably a little too deep. So that's the right plane to inject the front. Of course, improper technique and improper dosage is responsible for the complications. Brow ptosis, if you overtreat this muscle or you treat it too low, and of course the Spock effect of the brow elevation, which occurs. Now, of course, take-home points is undertreat, inject high up, and remember, anatomy not the same in all patients. The depressor supercilii is a small muscle at the superior medial corner, just under the eye. 1 or 2 units is all what you need to inject it. Now, of course, you're talking about the orbicularis oculi muscle. It is basically got a palpebral part and an orbital part. The palpebral part is in the palpebral fissure. It has a pretarsal and a preseptal part. Now, we do not inject this portion. We inject only the orbital part, which is outside the palpebral palpebra. So as we're reflecting the skin, we can see that it is a very superficial muscle. There is very, very less fat here. It is, so all the injections have to be subdermal, and you have to stay away from the orbit, at least 5 millimeters to 1 centimeter away from the lateral orbit. It is a strong brow depressor laterally. So only 2 points you remember marking here. The lateral orbit, you feel the bone, you feel that, stay around 5 millimeters to 1 centimeter away from that. And of course, the zygoma. And you stay above the zygoma. All your zygomatic is major and zygomatic is minor. They start from the zygoma. Injecting into these muscles will cause a lot of issues with smile. So stay well above the inferior border of the zygoma. Now, of course, to prevent complications, it has to be low volume injections, subdermal, 2 to 4 units per injection site, very superficial. Look at the needle, how superficial it is. If you are this superficial, well away from the orbit, you will not get any complications. Raise a papule and you may even see blanching. So that's your first point, just lateral to the orbit around 1.5 centimeters or 1 centimeter. And then 30 degrees lower down above the zygomatic arch. Stay well above the zygomatic arch. And the third injection is superiorly, just superior to that, just below the tail of the eyebrow. And pressure. Pressure is very important. So of course, possible complications, only one complication that we must dread is upper lip asymmetry and change in the smile dynamics. If you do inject too low, the drug will go into the zygomaticus major and minor muscle, and that will cause a lot of problems with the smile dynamics. So definitely do not cross the zygomatic arch. And definitely do not go too close to the orbit. If the muscle goes into the orbit, into the lateral recti, the patient will have diplopia as he's looking on the sides. Okay, so avoid this complication completely. Now take home, of course, don't go too low, inject superficial, check snap test before you inject. Now this is a very rare complication that you may get herniation of the fat pads. I think it's spoken a lot about, but we don't really see this unless the tone is really, really loose. In that case, at very old age, you may get it. Otherwise, it's just this very rarely seen complication. Now, what do you do after this? Do not rub or massage the area. Do not bend your head for 24 hours. Definitely don't wash your face with tap water for 8 hours. Tap water may contain atypical mycobacteria or it may cause some infections. So do not wash your face. Makeup can be used lightly. Any kind of lasers, energy devices, etc. should be used after 2 weeks so that avoid exposure to sunlight for a couple of days. Don't scare the patient by giving too many instructions. Give what is relevant. I think the most relevant is don't massage the area. If you inject it in the right place, don't massage the area. And of course, do not wash with tap water because you don't want infections. And don't touch the area with dirty hands. That is the most important indications. Now, of course, extremely rare complications we've seen are allergies and blocking antibodies. I think I had one patient who had some blocking antibodies. We rarely see this. How much ever I kept on injecting her, but she was a frequent, she used to take Botox every 2 to 3 months, and probably that led to the antibody formation. So do not give it at short durations. Try to not give it too often, and of course don't keep changing it. Now, of course, we've seen that you get excellent results with glabellar frown lines, crow's feet, forehead lines. All the indications in the upper face have great great results. Popley chin, bunny lines, good results with platysmal bands. Masseters would be good, very good results. Mental crease, perioral lines. Average results with nasolabial. I don't think anybody uses it for nasolabial anymore. Horizontal necklines. So, of course, be very careful. Don't just think of Botox just like an injection. Think it's a knife, and do not be trigger happy. Don't go and inject it in every single indication that you think of or read of, because it works in very well in very few places, not everywhere. So it's a very safe, highly effective, reversible, easy to perform cosmetic procedure. It is very close to what we so call as a perfect cosmetic procedure. And everybody talks and gets Botox done. It's just that people are now getting open and to talk about it. Thank you so much. Thank you.
Thank you, Dr. Viral. It was nice and informative talk. Thank you. And now we proceed to panel discussion on botulinum toxin complication and tips and tricks to avoid them.
First of all, I will welcome Dr. Neeraj Pandey, who is the moderator. Dr. Neeraj Pandey is Director and Chief Consultant at Derma Clinic, Skin, Laser, Hair and Research Clinics. He is Founder Director of Mediscal Clinic, Senior Consultant De Novo Hair Transplant at Lucknow. He is Vice President IADVL, President UPI IADVL 2019. He is President ADVL Lucknow 2017 and 18. And he is Principal Investigator in multiple Phase 3 clinical trials. So I invite him for moderating the session.
The panel for the session is Dr. Anuj Paul. Dr. Anuj Paul, please come on the stage. Dr. Sejal Shah, Dr. Devjit Kaur, Dr. Anju Mehtil, and on my personal request, I think I can call Dr. Viral because he has delivered a talk, and so there may be some questions from the audience, and that he can answer them. Dr. Viral, please. Thank you very much. Dr. Pandey, please start the session. Thank you. Okay, thank you. Thank you very much.
Thanks, Chairperson, for such an enlightening introduction of the panelists and the moderator. And before we start, let me congratulate the organizing committee for such a wonderful physical, I'll say one of the first physical conference. And Dr. Viral Desai has said the pretext, and it was such an enlightening, crisp talk. After that, there is nothing left to discuss, but we have 20 minutes to discuss the cardinal points of this basic Botox indication. We'll be talking only about the upper face complications of Botox. So our panelist does not require any introduction. Right from the left, Dr. Viral Desai, Dr. Anuj Pal, Dr. Sejal, Dr. Devjit Kaur, and Dr. Anju Mehtil. So they are all masters in this injectables, and I hope by the time I'll set the pretext, this system will be on. So let me start with the first question. I'll start with Dr. Anju, because this all has been dealt by Dr. Viral very well. But this first slide, definitely I'll share with. Upper mid face is the aesthetic center of the face, where we look to estimate age, and we used to judge a personal emotional state. First signs of aging are seen in an area which can be best tackled by botulinum toxin. Not this. This has been all. This one slide, which is important, wrinkles form perpendicular to the axon of muscle. So relaxing the overactive facial muscle is an effective strategy for wrinkle prevention and reduction. So now prerequisite for Botox procedure. How will it minimize the complication? What are they? Can you just enumerate one by one, Dr. Anju?
One of the main prerequisite for Botox procedure is absolutely realistic expectations from the patient. That is utmost importance because many a times patients come to us with a lot of expectations. They want the lines completely gone and they expect wonders. So we definitely need to tell them that you're going to get results which are going to be making them look natural and not too rigid, basically. Secondly is have a proper counseling with the patient. Photographic evidence, informed consent, definitely. While examining the patient, we need to know the origin and insertion so that we are injecting in the right place. And of course, we need to know how to handle the complications as and when they occur.
And Anuj, do you want to add anything in this?
I think like she has said everything. The only thing is about the expectation which she told, I think personally believe that you should be eyeing on not complete paralysis. It should be the partial inactivation. And the treatment should be according to the age of the patient. So don't try to, erase lines from a 40 years old or 42 years old. The grace is in lines. So it has to be movement and it should be under treating.
Two important points: when not to inject and when not to inject. These are the things which we all should know before starting Botox. So now, how
another point, sir?
Yeah, please.
As Dr. Viral rightly pointed out, since he's a surgeon, surgical marking. So they have this habit which sometimes dermats lack. So however old, however senior, young, whatever, marking is very important.
See, complications do happen with experts also. So don't worry about this. It has a long learning curve. So how to avoid complications? I'll start with Dr. Shejil. Any cardinal points, a take-home message to the audience?
So one is, yes, you have to always keep in mind that any procedure, any aesthetic procedure that you do, because complications are a part and parcel of any procedure. So rather than getting scared, I think it's always important to know what are the potential complications that can happen. So first is that you always have to keep in mind that, yes, this is what can go wrong. And then obviously, how do you avoid them? You need to know your anatomy well. You need to know where exactly are you placing the toxin? How much of toxin are you placing? Are you placing it in the correct plane? If at all something goes wrong, I think subsequently how to manage them is also just as important.
Okay.
Rightly pointed out, anatomy. No two persons are same. So we can't have if my corrugator is, the thicker muscle, I need, 16 to 20 units. I'm injecting the same on the person B also. So it depends on the thickness of the muscle and, the activation of muscle. So always look for the point of maximum contraction before injecting and then hit the, nail there.
Again, the message is first point is to learn where not to inject.
I think training is very important. Before you start injecting, of course, anatomy is most crucial, but how do you know about the anatomy is through training. So attend a lot of cadaver workshops, learn about the anatomy, revise it. And what I've seen over the years is the dosages getting, injection points getting less and the dosage per injection point getting more. This is what I've seen with the new M technique and what all we see. I have a slightly different view. If there is a broad muscle, why don't you distribute the drug evenly into it rather than trying to inject one point? I think this giving small doses, big doses at one point came through the fact that we want to give less pain to the patient. But anyways, with the 32G needle, the pain is practically not there. So why not distribute the drug more evenly? In that case, even if there is migration or drug, the component will be very, very small and definitely you'll reduce the chances of complications. As you evolve with time, you keep injecting more and more, then you can give this, you can follow these patterns of giving large doses at one spot. So that's what I feel is a little different from what is being taught nowadays.
Okay. Excellent point, sir, Dr. Viral. The other slide, which is important, which I always say, be thorough with the 5 Ds of botulinum toxin: dose, dilution, diffusion, duration, and dogma. Dogma is follow the rules, set protocol, set belief. So these are not to inject. So now the common complications you experience. I'll start with Dr. Devijit. Which complications have you seen commonly in your practice?
I won't call it a complication, but the most common thing which patient complain is pain. Pain during injection, or bruising. These are the two most commonly we see, because if we respect the planes and anatomy, other things, as Dr. Viral said, are relatively rare.
Okay, Dr. Sejal.
I think commonly, yes, it's mainly just pain and bruising. I mean, in most cases, pain, yes, which you can avoid with a numbing cream, but other complications, some of which I haven't personally encountered, but yes, which I have come across. Browtosis, that is a little fall in the brow. Litosis, I've seen one case of litosis. I've seen, so I have had a complaint of dryness of the eyes in one of my patients and excessive watering from the eyes. So these are the few which I have encountered. There are, I'm sure, a lot
Have
more.
any of the panelists encountered fever post Botox injections?
Couple of patients, but transient. They complained for a very short time.
Very short time.
But I think one complication we all are missing out here, it's rare now, but we've seen it earlier when strict aseptic precautions are not followed, was infections, atypical mycobacterial infections. We've seen cases between 2004 and 2008 or 9. In that period, a lot of these cases, and it was found out that the sterility wasn't maintained, was the same injection points, the saline was repeatedly being used to reconstitute many vials. So it was not a fresh saline which was being used. Even when you are using the saline, you're not wiping the surface with alcohol. It may be stored inappropriately. So when you do that and then you puncture through this thing, of course, maybe the gloves were not worn properly. Or the saline was a main cause. What was found that the same saline which was stored and kept was used even after 1 week, 10 days, 15 days to reconstitute, and atypical mycobacterial infections were seen. So that's of course very rare, but a very dreadful complication.
Injection hygiene is important, and how long you can open? How long you can keep open this after dilution? Open Botox vial. This we all know, but a message to the audience.
Well, of course, it's been said to be used as fast as possible in 24 to 48 hours, but practically we keep it for around 4 to 6 weeks. You keep it properly stored at 4 to 8 degrees in the chiller tray for around 4 weeks to 6 weeks. Beyond that, you need to throw it off. So that's what it.
Thank you. And my next question, Anu.
Can I add?
Anuj, we have 20 minutes.
Quickly, 30 seconds.
Yeah, please.
Pain, yes, icing, bruising, like, I mean, not much these days, but if you know very well. The other thing is, earlier, like in 2004, we used to give 30 units in the forehead, 30 units. So now most of the patients, when they come, they complain of heaviness in that area. So be very less in the forehead, because they, start feeling little tiredness and heaviness and not able to move their brow. So less number of units in the forehead.
Agree. So, Dr. Anju, approach to a case of litosis once it happens.
Definitely
how we can
a lot.
Avoid that and how to treat that. Just short and
A lot of hand holding. I mean, literally, like for lactosis, it obviously goes off after a couple of weeks, maybe around 3 to 4 weeks. But a lot of hand holding, and there is a Muller muscle relaxant which we can use. The ophthalms use it, so definitely refer to a patient to the ophthalmologist in case you do develop something like that. It's an alpha adrenergic blocker, which helps basically in taking care of the Muller muscle, which helps in lifting up the lid.
But the action lasts for a very short time.
So you have to use it repeatedly every 3 hours.
Okay.
Before pictures are very
important. If you don't do anything, it's a transient. It goes off in, say, 30 to 45 days maximum.
Yeah.
Before pictures are very important. Many patients will click pictures and say, like, my eyes are not looking good. So when you compare it, it's the same as before.
Injection technique is also very important when you are doing this. This way you can avoid this complication. Anything else you want to add, Dr. Sejal?
Yeah, just that, the injection technique. I mean, initially, I generally suggest that don't keep chasing the tail of the corrugator. It's fine if you leave that one muscle alone, the last bit of the corrugator. When you start injecting initially, just focus on the procerus and the, up to the main body of the corrugator. And if at all you are going that close to the levator muscle, then inject superficially. Don't go too deep down into the bone, as Viral had mentioned earlier. The other way you could get a litosis, which I don't think we're covering right now, but when you're doing a brow lift, so if again you are chasing the arch of the brow, you might be very close to the levator, and that could be another reason why you have a drop in the lid. And I think it's very important to have those pre-pictures, like has Dr. Anuj mentioned. Sometimes the patient just, when they do a procedure, they start noticing a lot of things on their face which they hadn't noticed earlier. So they might just have this little difference, asymmetry in the position of the brow or the position of the lid, which then they connect to your injections. So compare, take a post picture, compare the two, and you can show it to them.
I hope all the points are clear. We have to move to next question. Approach to a case of brotosis. And Devajit, how to avoid, how to treat? Just click short answer.
This brotosis, again, respecting the anatomy and not going too low for forehead lines when you are treating the glabella. You should not go, as Dr. Viral pointed out in his presentation, below the last line. So that will prevent diffusion. That is the basic thing. Give some support with the non-injecting hand and hold it for some time to reduce the diffusion, and right dilution and right dose should not be causing any problem.
Avoid injecting too high when injecting the phone line. This is what Dr. Viral has mentioned in the presentation. So now the approach to a case of post-Botox spocking, Dr. Anuj. How to avoid, how to treat?
Well, spocking is not something you see in every patient. Frontalis muscle, if you see Dr. Viral's anatomy, the frontalis I have seen in 2 patients. So first is like the fibers there right over here, and in few patients they go a little lateral also. So when you tell patient to raise their brow, you'll see lines coming over here. So when you treat the medial part, the lateral fibers actually they become hyperactive, and that's how the spocking effect comes. So you have to inject in the frontalis. So brow frontalis is the only elevator. It has got 4 muscles which are depressing it down. So when you inject the frontalis right over there, the effect of the frontalis muscle, it gets weakened and the brow comes down. So, but it is something which you have to inject later. But with experience, you start seeing the lines there, then you inject that time also only.
Okay. This is what how we can correct this. Injecting 1 to 2 unit of Botox treatment into frontalis 2 centimeter above the lateral brow. This is,
sometimes we don't see patients like that coming to us. The lines they extend in lateral to the temple. So in that case, you have to go a little more lateral in the forehead.
We have already covered this, where not to inject, crow field, what to avoid. Dr. Viral has already done this. We have next 34 minutes. This is one question which I'll give to Dr. Devajit, just in 30 seconds, what to avoid in crow field when you are injecting.
Yeah, as all the answers were there in Dr. Viral's presentation. So just staying 1 centimeter away from the orbital rim, that is the first thing, and not going below the zygomatic arc. These are the 2 things which one should be very careful. And third thing is injecting superficially to create a bleb. So preventing ecchymosis and not going to the other zones.
And Dr. Anuj, glabellar lines, what to avoid? Just one line. Where not to inject?
Where not to inject?
That's it.
Glabellar lines. We have to be a little deeper in the muscle here whenever we're injecting glabella. And second, again, not going to the orbicularis oculi. Always give support to the muscle and then inject over there. I usually hold the belly of the muscle and then go inside. So tell patient to contract the muscle, hold the belly, and then go inside.
Okay. Avoid injecting literally past the mid.
And one thing more.
Yeah, please.
So corrugator is of 2 types. One is the horizontal and the V type. So always we have been told 1.5 there and there. It never applies on every patient. So you have to see the patient contraction of the muscle and then hit it.
Oblique and transverse. Okay. The horizontal forehead lines, what to avoid, Dr. Sejal? That's where not to inject. That's very one.
Yeah, don't inject the fibers. I think that's the only. Yeah, and beyond the mid-pupillary line. So basically the lowest, the first line that you see, the first wrinkle that you see, mark that area out, lateral to the mid-pupil line, and then inject higher up.
Okay,
Not below the lower line, not beside the mid-pupillary line.
Good. And then coming on to the complication handling, these are the last slides, Dr. Sukesh. Few tips from each of the panelists. What to do, what not to do. Really, I'll start with Dr. Viral. Once the complication happens, how to handle it? How should we counsel it? Then how to buy the time? Because we all know that Botox is temporary and all the side effects are transient most of the times. The counseling plays a very, very important role.
So of course, rightfully they are transient. So hand holding, a lot of speaking to the patient, a lot of hand holding, counseling is all what you require. Try to calm the patient down. They're most hyper in the first 2 weeks, couple of weeks. Once they realize the effects are going to go away, they will relax because nothing is irreversible except for, of course, infections when it comes to Botox. So be very careful. I think that's the only thing that is to be done.
I think
to the youngsters, there's nothing to be afraid of, like complication of botulinum toxin. It's a pretty safe molecule if you know your things well. The only thing is we are not same left and right side of the face. Patient has never seen them before, like getting that procedure done. Always take the pre-pictures, show them this is the asymmetry, which is before my injection. You have to tell them. They'll put everything on you later. And second, as you know, Dr. Viral has said all. After the complication, that patient should be VIP from that day onwards for you. The call should be from your side, never from his or her side.
Great. And Dr. Sejal, to be very specific, using the right language, how important it is?
It's absolutely important.
When we are counseling.
Being honest, yes. Being honest with the patient that, yes. So a lot of times it happens that doctors deny any complication. They say that this hasn't happened. It hasn't happened because of me. You haven't followed these precautions and which is why it's happened. But I think owning up to certain complications makes sense. So you have to reassure that, yes, it's happened, but it will be taken care of. It's a transient thing. It's going to wear off in the next couple of weeks and I'm there. I'm going to be monitoring and making sure that you come out of this correctly. And so one small thing, which is not a routine thing and which actually doesn't do anything, but if say you do happen to have some complication related to the toxin, if you have any machine which has a radio frequency or an electric stimulation machine, you could probably start the patient on that. It's not going to help too much, but at least the patient feels that I am doing something. The doctor's taking care, trying to make sure that I come out of this easily.
Something like placebo treatment also works?
It does. So that's what it is. But there's nothing you can really do. Once a Botox is in, you can't really, the toxin is in, you can't really take it out. So
I think otherwise, what happens after complication, the patient reads a lot. So this placebo becomes nocebo. They think everything about that. So that's why we should be very cautious when we are giving anything after complication. Counseling is the major role and the hand holding, what we say. And using the right muscle, frozen, use softening the lines, botulinum toxin, because Botox is, see why I say I'm not propagating any idea of allergen or any product, but Botox is, the patient is well aware about this, and toxins use protein. And it's like, so post-procedure precautions, avoid strenuous activity for 1 to 2 days and the massaging, everything. And this is one important slide which we do in our clinic, 2-week review, as Dr. Anuj right said. Call should be always from the clinic, not by the patient. Following up the patient is important to ensure what patient satisfaction and retention. Take-home messages. This treatment is an important part of any aesthetic practice. It can be learned fairly easily with reasonable knowledge of facial anatomy. So anatomy is very important. Start with basic indication and then move to the advanced ones. First, attend courses, do hands-on on in-house patients, and have a mentor to guide you before getting into full form. And avoid complications. See, most of the complications are arise with droplet size and the depth of infection. Botox will diffuse in the thickness of the underlying muscle, creating total paralysis if it injects more than the diluted one. So take-home messages, it can lead to paralysis of muscle due to improper depth, dose, or due to dispersion from messaging. To be thorough with the 5 Ds of botulinum toxin: doses, dilution, diffusion, duration, and dogma. So before we end, this is last slide for Dr. Anuj Pal. Expectation alignment is a must when we start. See, this is my pug and this is my lab. So this is what should be the counseling when we are. I want something in Punjabi when we are in Chandigarh. A message to the audience.
ਸਾਡੇ ਕੁੱਤੇ ਬੜੇ ਸੋਹਣੇ
Huh? Can you come again? Sorry.
ਤੁਹਾਡੇ ਕੁੱਤੇ ਬਹੁਤ ਸੋਹਣੇ
ਅੱਛਾ ਜੀ।
ਇਟਸ ਰਿਗਾਰਡਿੰਗ ਕਿ ਪੇਸ਼ੈਂਟ ਸਾਡੇ ਕੋਲ ਆਣਗੇ ਕਿ ਸਾਨੂੰ ਐਦਾਂ ਦਾ ਬਣਾ ਦਿਓ ਐਂਡ ਤੁਹਾਨੂੰ ਦੱਸਣਾ ਹੈ ਕਿ ਆਪਾਂ ਇਹ ਕਰ ਸਕਦੇ ਹਾਂ ਇਹ ਨਹੀਂ ਕਰ ਸਕਦੇ ਸੋ ਟੈਲ them this is possible ਇਹ possible ਨਹੀਂ ਹੈਗਾ ਜੋ ਨਹੀਂ ਹੈਗਾ ਉਹ ਨਹੀਂ ਹੈਗਾ ਸੋ ਲਾਈਕ ਇਹੀ ਕਹਿਣਾ ਚਾਹੂੰਗਾ ਮੈਂ
A pug can't be lab. This is what you mean to say. With this. So thank you very much, panelists.
Thank you.
Before I end, this is if you want to know more about Botox, the anatomy and how to inject and the fillers, lasers, this is an academy dais for the dermatologist, by the dermatologist. And we have 14 centers across 16 cities. If you all are interested, these are the numbers you can call and inquire. Thank you very much. Thanks.
Thank you, Dr. Pandey. And on the behalf of my co-chairs, I thank all the panelists for giving probably all the answers to all the queries. Okay. Thank you very much. Any questions from the audience can be taken up in the after this. They can ask any questions to the panelist or the moderator after completion of this, finishing this session. Okay. Thank you very much.
Well, now is the time upon Dr. Sahil Ripuri on the stage.
So, hello everyone. This is one of the most special moments of my life. I have been through all my phases of life. I have seen various things, been through all ups and downs, but there are only few moments when you can bestow to your teachers. So, Dermatologist of the Year Award for 2021. Any guesses? The award goes to Dr. Sunil Dogra. A big round of applause. precise. Now, may I please call Dr. Neeraj Pandey, Dr. Anurag Tiwari to please come on stage for the ceremony. Dr. Neeraj Pandey, Dr. Swapnil Shah, and Dr. Anurag Tiwari.
I think we are too young to felicitate somebody like Sir Stature. It's an emotional moment for all of us, and we know what the name Sunil Dogra stands for. So we all should be. So we need a big round of applause for Sir and a standing ovation, please. This kind of a lifetime achievement award, I think that he deserves this. Thank you very much.
A huge round of applause, please. Just one second. Now I please invite Sir to say a few words for us.
Good morning, dear friends and colleagues. It is a great honor and pleasure to receive this award today morning in SODC. And Dr. Sahil, Dr. Vikram Mahajan sir, Dr. Madhuri Agarwal, and all organizers of SODC for considering me worthy of this award. I am happy to see SODC doing so well each conference, and I wish it all the best in this conference and in the years to come. SODC is a unique conference where the new young brigade who are very passionate in the field and also in the practice, they are taking the lead with the blessings and support of all the stalwarts as we have in this conference. So I wish a great success to this conference and for the future conferences as well. Once again, thanks organizers for giving me this award. And thank you all for joining today morning with me in this good occasion. And happy conferencing. I wish you all the best and pleasant stay at Chandigarh. Thank you so much.
Congratulations, sir. Now I would request the chairpersons, the faculty, and the panelists of this session to please move to the selfie booth to receive their tokens of appreciation. And simultaneously, we will have the hands-on session on basic botulinum toxin now.
So all the registered delegates for hands-on workshop for Botox, we request you to move to the stations which are just adjacent to this hall. The booth for Botox, we request them all to assemble. Also, to those delegates who have not registered for hands-on, we have a live preview which will start on the screen. So you can be seated here. This is for those who have not registered for the Botox hands-on workshop.
ऑफिस में है क्या? नहीं ये क्या?
लगा तो दो।
Hello, 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 hello. Mic testing. Hello.
We'll show it first. We'll show it first. Yeah. Hello everyone. I'm Dr. Paul. All of you are from Punjab? No, from different parts of the country. Actually, मैं थोड़ा पंजाबी च बोलने लगा सी कैसे कर गए last time. So I'm Dr. Paul, and I'm in Gurgaon. So we'll be talking about toxin today. Dr. Kavita, उठ जाओ. सुन रहे हो तुसी? Are you a dermatologist?
Yeah.
हाँ जी. Okay. So botulinum toxin जो है वो basically it's something it's a toxin which was used for as you have all know that it was for strabismus and all. When they were treating, they came to know कि ये जो है वो muscle को relax कर देता है. The lines they disappeared. That's how it came into the picture. That's the history of it. And the science is an ever evolving thing. The best person to tell you what is the best for you is you yourself. So no single rule apply on every patient. Every patient is different. It's unique. We all are physically different from others. We have different muscles, and we have different expressions. So you have to treat every individual patient differently. I want you to just visualize that this is her face. So there is nothing should be between your eyes and her muscles. So this is botulinum toxin. So you are seeing only and only muscles on the face. So this is botulinum toxin. First, we'll have a look on that. Botulinum toxin, there are many trade brands which are available in the market, and they have got different dilutions also. Now, this is like Dysport. So we have other brands in the market also. So it comes as 100 units, 300 units, and 50 units also. Based on your practice, you have to choose the vial. So you cannot have a 300 unit vial with you, invest so much into that, and your patient not coming to very frequently. So in that case, you have to be very cautious because you waste a lot of money and amount on that. So this is 300 unit vial. So we are going to dilute it. So dilution is different from different vials. So some in there is 2.6 ml, and some vials have 3 ml. So you have to go according to the choice of the product you're going to use. So in this is going to use 3 ml.
Yes.
So yeah, Dr. Anisha will be doing it for 3 ml. Can I have the insulin syringe, please, in the meantime? Okay, this is 1 ml.
Yes.
1 ml. So how many? You don't have the 40 units one?
Yeah. No, we have the 100 one.
No, not the 41. $40 नहीं हमारे पास 100. Okay, so this is 100 unit. So many of the other brands are available. So they have got 40 units. It's been this is 1 equal to 1 unit, right? So in that case, the 40 is 40 titration. So you have to the one line is equal to 1 unit. So in this one line is 1 unit. So we will be injecting it. 1 unit would be how many lines now? 1. So 0.1 ml is equal to? It's 10 here, but it'll be 4. 4 of other. Yeah. So we'll be injecting that way only. So you inject muscle right in the belly of the muscle. So this is a little about the product, and then we come to the patient counseling, which is very important. See, all of you go and see yourself, take a selfie of yourself and see very closely. You'll see that your eyes are not same, your brow they're not same, even your nasolabial fold are not same, and your half of the face is not same as the other. But we sleep, we talk, we have got different expressions and all. Very important in aesthetic practice. It's not confined only to botulinum toxin. Any aesthetic practice, always take pre-pictures.
I'll start.
If you notice anything, okay, this is a little unusual, you have to address and tell patient that this is not something which is usual for you. It is unusual.
We need to shut this one.
Don't give them over expectation. Tell them, okay, this
the
is
voice is
different.
coming now.
It is before the treatment will start,
We'll have to shut
and
this off.
you have to be very, very careful in choosing your patients also. So many of the
इसको
patients will
बंद कर
say
सकते हो
they'll take out the pictures कि मुझे ऐसा बना दो.
इसको
So
बंद कर
something which is
सकते हो?
not possible for us to do. So we have to tell them, address them. So after doing that, now you see
somebody
patient will
won't
come to
tell
you
ना,
कि मेरे
you
में
need
आपको
to
क्या
speak
खराब
only.
लगता है. You ask patient कि आपको आपके अंदर जो है वो क्या चीज bother कर रही है. Can we have the mirror? Do we have mirror here? No, okay. So,
I have cell mirror. No?
इसको उतार लें. Can I have the gloves, please? Pair of gloves. Think about the anatomy. Have you read something, or like it's your first take on first workshop? So we all are naive here. Okay. You hold it. Thank you.
I have a question, sir.
Yeah, yeah.
Till what age we can continue with Botox, or after some age it will not work, depending on the degree of.
There are few things which are important is the resistance of the molecule. When you keep on using one, molecule, there are on-a-bottom toxin, ide-bottom toxin, the different types of toxin available. So I have seen like many patients who keep on using one brand for a very long time. So patients, they start developing antibodies. So it starts showing it's in the effect doesn't last for so long. It wanes off fast. So in that case, you have to change the brand. So this is one option. And the second option is that when not to use toxin. If you ask her, like, I mean, she's happy with the result, till the time she's happy, no problem. Now, when she's going to grow age and age, static lines and motion lines difference. So this is one other thing. Whenever patient is doing for the first time, show them their relaxing picture and picture in motion also in the contraction. In that case, back the muscle, you'll see those lines. They are more, more visible. But when they're relaxed, they're very, very less visible on the face. So in that case, you have to show them this is something called static lines. So when I'm talking to you, my brow is moving. So I'm getting lines. So if you don't want these lines, you have to, preserve all the facial expression except for that part of the muscle which is causing those lines. So this is about the toxin treatment. So static lines, we can't do anything. So you have to tell them this is something which will be there after the toxin. Otherwise, you get a call after 5 days, my lines are still visible. So in that case, you have to tell them before. These are those practical points which, like, when you practice, you come across patient and they with each patient, you see something or the different and you learn from every patient. एक मिनट ऊपर कर लीजिए. Okay, so which muscle is this? Frontalis. अपने eyebrow ऊपर कीजिए. Now, frontalis muscle जो है, this is like the V over here, the fibers over here. There is no muscle here. करिए ऊपर कीजिए. So you will see when you put your finger here, the finger will not move. It means the muscle is not moving. So there is no point in injecting toxin here. One. Second, point of maximum contraction. If we have same frontalis, why don't we get same type of lines?
But
all of us.
anatomy and training
Why
is
don't
most
we get
important. I'm
same
sure you
lines
all
the
were
same
there
age?
during the talk.
Why we are different
So
from
the
each
knowledge
other?
of anatomy
Why
and
it is so?
training is most
Because
important.
of our facial
most people
expression, our
injecting the
genes
toxin
are like,
or,
other factors which are
pressures,
responsible
right?
for it.
Okay.
And in this
So
patient,
we're
you
going
can
to try
see
to keep it very
she's
basic,
getting lines.
and
And this is what I was talking about in
completely to avoid complications, mainly to avoid
the
if you
panel
get
also.
little less result, it's okay. But
Can you see the lines are
complication, and that is
reaching
more
all
important.
over there?
Actually, if it
Relax,
falls from this
कीजिए.
side, no,
Relax,
you'll not be able to
please.
see otherwise.
Now do it again. So
Now,
she has got frontalis.
he's a very good
full hair
candidate
also.
for doing
It's not
this
only
kind of a
confined
procedure.
up till here only. So in that case, if you leave this area here now and inject this, so what would happen? If you relax this part of the muscle, what would happen to the fibers over there?
So
they'll
first thing is
So
assessment,
they'll become
inspection
hyperactive, and
of the
she'll come
patient.
back to me after 5-7 days with this. Whenever I
Inspection
raise my
in the
brow,
standing
सब लोग
position,
कहते हैं कि
okay?
आप बड़े
You
वो
see
लगते हो.
him standing or
So in
like
that
in the
case,
erect position.
you have
Chin
to
down.
do
Can you
what?
see static lines? Yes. So
Eyebrow
that
is
you
like
have
this.
to warn him
So
regarding this.
orbicularis
The
oculi
static lines
is
will
pulling it down.
reduce, but they will not go. So
Your
after
frontalis is
doing,
pulling it up.
just frown
So
over
we relax the frontalis muscle.
Can you see him
so that orbitals oculi bring
the static line get deeper?
So this is exactly what we're going to do here.
To
This
the
is the
patient.
point which happened. So I'm just telling you the anatomy of the frontalis. This muscle is here. The V you have to spread. And at her age, would you like when she's talking to you, her brow is not moving? My eye catches something which is unusual, like this. Spot it. If you're talking to somebody, you see the lips, oh, say filler karaya hua. When you're talking to somebody, the brow is not moving. Like, how could you expect at this age the brow is not moving? The lines, they're not there. So I tell my patient, the grace is in lines. The grace is in lines at a certain age. Don't run after lines, erasing them. Make them subtle. I want you to look graceful. I don't want to erase and look plastic to you. So that's why less number of units. Each patient is different. So I have been told in that workshop that 10 to 12 units आपने forehead पे लगाने हैं. अब forehead पे लगे ना लगे हमें 12 लगाने हैं. फिर 12 बोला हुआ है. It's not the practically truth. So in those pictures, you remember one of the line was very, very, deep furrow was there. Why was it so strong contraction of frontalis? In her, it's very weak. So you should be eyeing for very slow, and brow movement would not be there if you hit frontalis in a very, very stronger way. So when we talk, our brow should move a little bit, like this little bit. So that has to be there. So this is about the frontalis. Then we come to the glabellar complex. So which muscle there in glabellar complex? Procerus, supra, corrugator. Corrugator is going like this. Corrugator is a deep muscle. It's a thick muscle. Ab zara frown kijiye. Very nice. Now see this. So this is corrugator, very small muscle, very small. Now where would you inject 3 points here? You can't. So 1 centimeter up, 1 centimeter left, वो scale लेके लगे रहेंगे हम. It's of no use. Don't do that. Just concentrate on the face. Just concentrate on the muscle. And then you choose your point. See, क्या है क्या बोटॉक्स बताओ मेरे को. इतने तो ट्रायम्सिनोन लगाए हैं आपने. कम लगाए हैं क्या? उसमें लगाने को आपको डर नहीं लगता. Why you like so afraid of this? Don't get scared. This is a very safe area. If you know that कि मुझे यहाँ पर इंजेक्ट नहीं करना, पर मुझे यहाँ पर इंजेक्ट क्यों नहीं करना, right? यहाँ पर बोटॉक्स लगाता हूँ तो it covers the 1 centimeter square of that area, correct? So it means these fibers of muscles are not getting affected by injecting here. So the muscle will keep on working here. If I'm injecting here, the muscle is keep working on here. So you have to just inject those points to make those lines subtle, right? So all these patients will not get the same line, same way. So in this pattern, when I was just like you, I remember in 2004, I was just mentioning 30 units. आप खोल के देख लो पुराना कोई paper, 30 units on the forehead, and they used to inject in the scalp also. We were told about that also. So we are not going to inject 30 units like that, correct? So the idea is now bring it down. 6 to 8 units in her case would be good. So this is about the glabellar complex here. This is about this. Now glabellar. Frontalis, दो तरह की आपको नजर आएगी. It is always there. It's universal truth. Frontalis is either V-shape. This corrugator. So corrugator is either, like V-shape, or it is horizontal in some cases. In men, I have seen a lot of like horizontal one. And in few patients, the corrugator is that big that you can actually see this muscle. She's got a very, very thin muscle. So corrugator is very, very thick in few patients. So when it is horizontal, if you inject, as I have told, then what would happen? You'll end up in injecting frontalis. What would you do? You compromise everything here. So you have to be very, very careful. The moment you inject frontalis here, so this thing is going to come down because all the muscle like muscle depressors, they're going to bring the brow down. So you andar chala jayega sare ka sara. So you have to be very, very careful on that. Now, after the corrugator, we take the beautiful muscle called orbicularis oculi. Someday you have to master this muscle. It's such a beautiful muscle. If you master it, you will say like you can play in this area so safely. Now I draw a line something over here. Where is the orbicularis oculi muscle? We won't be able to tell. We won't be able to tell. Put your finger here. जोर से आंख बंद कीजिए. Relax. जोर से आंख बंद कीजिए. Relax. Can you see the muscle? My finger moving? आप यहाँ पे उंगली रखिए एक बार. Okay, do it again. See, orbicularis oculi is not a circular muscle. It's a muscle which goes like this. So that is the reason when you inject here, if you inject here also, then you are in the safe with orbital oculi. Kariye band zara. Yeah. Relax, please. Relax, please. Kariye zara. Relax. Relax. Relax, please. Again. 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 Relax. So brow is moving and going inwards. This is orbicularis oculi. Here, everywhere. This is not the today's workshop. Otherwise, I can teach you treating hair also, if you know the anatomy, the basic botulinum toxin. So orbicularis oculi is going, so it's going to give us cross feet hair. Jara smile kijiye zor se. Yeah. So these are the wrinkles which appears in many patients. So when you inject here, these wrinkles are still prominent, they'll not go. So you have to tell patient that we will not go to very close to lid, otherwise it will compromise your eyelid movement and all. But honestly speaking, if you master this area and stay in the orbicularis oculi, you can get to them also. Because orbicularis oculi has got two parts, the palpebral and orbital. Orbital goes down and the palpebral goes up. So palpebral is something which is just there in the lid. So if you don't go in that area, you make yourself, only in the confined to the orbicularis oculi, there would be no problem at all. So orbicularis oculi, this is the cross feet here, which we are going to do. So any question till now?
Do you have to know the age of the patient or the wrinkles are enough to inject? And is it Botox required for early stages
Skin,
or later?
if your skin is thin, I pinch like that and you can. So in that case, if you have lines, they'll not go. Because skin laxity is there, you need to combine it with RF. You need to combine something to regenerate collagen. Your toxin would not be enough because this is the skin laxity, not the muscle. There's a difference between skin laxity and muscle. So age is also very important. Again, I tell you, we don't age same way. If you talk about somebody like from in India only, somebody from North J&K, look at their faces. Where are the lines? Why don't they? And the natural collagen regeneration is like being very close to sun and the sunny atmosphere environment there. Why they're not there? So the genes are also important. And then like other factors like emotional stress, hormones, and smoking and all, they all contribute to these factors. So age is also important, but more than age, lines, whether they're motional or static, and whether skin laxity is there or not.
So starting it won't work much.
It works, it makes them subtle. See, when I am not talking also, my muscle is still little under contraction. So the lines, they become very subtle, but they don't disappear. So they will be there. So you have to tell them they'll be there, but they're so subtle, they're hardly visible.
Then we have to use another mode of rejuvenation, like
Yes,
fillers.
yes. No.
Then Botox
Filler,
will not help.
no, filler we will not use here. See, filler you use in the
Your part.
middle glabellar lines when they become very, very thick. So you combine botulinum toxin along with filler. So toxin relaxes the muscle, whatever the static line furrows are there, you just inject it with filler. This is how it is. Or pucho ji. Next. Static lines. Do I have static lines? Hannah? So can you see the static lines? Now, when I'm talking to you, my static lines are visible, motional lines are visible. Motional lines are more visible. Static मैंने बोला आपने ढूंढा मेरे को अभी वहां से. So that's how it is. So when you inject it, so they become very, very subtle. Yeah, they become subtle. Okay, any other question? Yeah, I'll tell you just now. Everything. No, I am asking any question till now. Is it clear? Everything is clear? Under eye, you have to master toxin first and then inject under eye. So it took me like almost 6-7 years to go in that area.
So if antibodies is not an issue, can we continue with Botox for
Of
how
course,
long?
of course, continue as like the patient wants. But the time would come like when it starts,
Static. Becomes static then.
the effect will not long lasting, and the second is the effect is not that great. So you need more number of users. Just switch to another brand.
Antibodies are mandatory or depends on the brand?
No, It depends on patient to patient.
Keep changing the brands.
No, I mean, like you will hardly get a patient coming to you for 10, 20 years. Usually, India, like, I mean, 80% will come, no Botox, no toxin. I would not want anything. I want natural results. This is what exactly they come and say. So only that class of patient who actually knows about it, they'll come and get it.
So does it make any afterwards any touching and all? Will it affect any?
Normal, absolutely normal, nothing else. It is just that you're talking to me, your whole face is moving. Only at certain areas your muscle is inactive. Inactive. It's not the paralysis, it's inactive.
So, and another thing, so people say with Botox, I'm talking about lower face, it becomes like this.
How?
So maybe because of stiff, it becomes.
Why?
No.
So tell me the logic.
Because
You're a
they're not doing
doctor.
it properly.
No, but like how come by doing toxin hair would
Not for
affect it?
this, for this lower part.
Lower part में कहाँ करते हैं हम? यहाँ पर?
कभी-कभी यहाँ पे कर देते हैं ना.
This is DAO. So now DAO जो होता है, this is depressor anguli oris. So DAO is a triangular muscle. So the triangle is like this, okay? And there is a muscle called labii inferioris. Now, when I'm injecting DAO, it is for the marionette line here, correct? So tell me, this is the triangle, and this is the labia inferioris, which is responsible for the lip outward movement. So if you inject the triangle tip, would that be safe, or would you inject the triangle base? That would be safe. Base, because like the margin of error here is very less. You land up in injecting and giving the inward, like a curling of the lip. So this is what we don't want to do. So in that case, that is the reason like anatomy is so important. The points are so important. Don't rush. Relax. Relax. Just take one step at a time. So because like if you master it, आपको ऐसे चलेगा आपका हाथ. You will just put your finger there and just inject it. Okay.
So how do you visualize the muscle by contraction? Because there can be some anatomical variation also. No?
I'm sorry?
There can be anatomical variation of the muscle.
Yes, of course.
So by contracting the muscle, we know the.
Exact. Yes, absolutely. Absolutely. Just. अच्छा करिए दोबारा जरा ऊपर कीजिए relax please, relax. So just in the center point here, so usually like it's the V because here they meet. So we take V, the frontalis I was telling you, and now we will inject one by one. So we'll start with the frontalis first. So ऊपर कीजिए आप जरा.
Why don't
Relax.
you further down because the lines are coming?
No. This is frontalis muscle. The muscle is not here.
Right.
The muscle is here. So if you inject here, it will be waste of the product.
Right.
Yeah. So this is the mid-pupillary line. The first point has to be सामने देखिए. Always make patient straight, and then they say 1.5 centimeter here. So you mid-pupillary line, you make a point here. No, it's. Oh, I'm standing there. Sorry. Okay, it's somewhere here. Okay. This is 1 point here. This is 1 point here. आगे खोल लीजिए जरा. Here, see. So one in the center usually I put. डॉक्टर बॉल उस कमरे में कुछ और बताया था, इस कमरे में कुछ और था, पॉइंट्स थोड़ा सा लेफ्ट राइट थे, कोई फर्क नहीं पड़ता उससे. The muscle should not be, it should be uniformly relaxed. You should be relaxing on this side more and that side less, right? अब ये थोड़ा सा अगर इधर भी हो जाएगा तो कोई फर्क नहीं पड़ेगा, ऊपर नीचे फर्क नहीं पड़ेगा. And we're not going to inject right in the dot. You can inject. So the pattern is that, so you in दोनों के बीच में you inject one unit here. You just inject one unit here. So this is something like now they have given it this name M technique, right? There is no M. It's the Jacob ladder technique, M technique, or like zigzag pattern like that. So in her case, ऊपर कीजिए. So we'll inject one here also. Okay, and then we'll inject one. Relax कीजिए, relax please. So we'll inject 1 point here and one inject. one point here. Okay, so now many like faces we see that we have the forehead is broader. Look at his forehead is broader and small forehead. So don't go beyond that. Do the hairline there. In case if it is visible, upar kijiye, and she's not getting any like of there. So don't inject it. Otherwise, you can inject between these two dots also. Right now comes the point, the Spock point. So tell me, if she raises her brow, वो ऐसे होता है, तो Spock point कहाँ होना चाहिए? तो they say कि tail के ऊपर यहाँ लगा दो. You will see this also. Many books. Actually, we're staying in the oculi only. You have to go in the frontalis. So इसके थोड़ा ऊपर लगा दो. So be safe. हम ऊपर यहाँ पर लगाएंगे. So I usually put it here. Again, in the presentation, it was somewhere there, somewhere there. So it's not going to make any difference. You have to relax the frontalis. The only thing you have to respect, don't inject in the orbicular oculi. चलिए जोर से अपने कीजिए, आंखें बंद कीजिए जोर से. My finger is moving. कौन सी मसल है? Relax, please. Relax. Now, so can you see orbicular oculi कहाँ तक जाती है? तो जब आप eyebrow lift करते हो, तो brow lift के अंदर जो है, you inject in the orbicular oculi. Why? Why? Brow lift के अंदर you inject orbicular oculi. Why? Yes. So this is the brow. This is the oculi and frontalis. जो करना है इनको कर लो. Agonist, antagonist. इसको ऊपर उठाना है, नीचे वाली को relax कर दो, वो ले जाएगी. लेकिन कहाँ पर करें? You have to inactive only that part of the muscle, and the frontalis fiber of that area will pull it up. So you want to give that hockey stick, inject here. You want to give the lateral arch, so inject here. Now in that case, another problem comes is that we do the forehead and when we do the brow lift also. Patient goes back home, comes back, there is no lift in the brow. Why?
It's already getting depressed.
Because you injected the upper part of frontalis also and lower part of brow, and it is still hanging there. So whenever you're doing brow lift, you have to leave that part of frontalis on top so that it can actually, yeah, that's right. So this is about this. And now,
now, this is to keep you all informed that simultaneously we will have the tea laid outside for 15 minutes. So you people can take a call if you would want to continue here or finish your tea as well.
just few units here, that's it. So this is orbicular oculi. Please don't confuse it. Can you see this is classical? Do this please for me. ऐसे कीजिए जोर से. होना ही नहीं है. आप करो. नहीं, frown करो, frown. जोर से frown करो. Frown. ऊपर देखो. Look at this. Can you see? It's like this. Why it is not like that? So if you inject like this, where are we going to go? We're going to stay. This is a horizontal, classical horizontal corrugator here. See, have a look, please. Have a look. This is very important. Very, very important. Yeah. No, it's something which you should know. So that, like marking, we have been told that 1 centimeter left, up and all, it doesn't work in every patient. Okay. So this is Procerus. 3 is a source. The center point. Because it's a deep muscle, thick muscle, so you're going to inject like that. Clear?
It is like the bulk of the muscle, depression tak hai.
It's a very small muscle in her case. Otherwise, the long corrugator yahan tak jati hoti hai. So you inject in the, head and the belly also, and sometimes tail. So the tail becomes much more thinner because you go the dermis. So in that case, I go 90 degrees here, but when I inject the tail, I go 45 degrees.
नीचे या ऊपर?
ऊपर.
So नीचे, it's like this.
No, it could be like this or it could be like that also. Okay, karo zara. Dobara. Can you see? The corrugator is horizontal in his case. Aap kijiye zara. Can you see? In her case, it's going like this. V shape. V shape. Yeah. Or oculi is also very, very, like, you can actually see the oculi. No, we all are like that. Don't worry. This is how, when you will, study yourself, your friends and each other, then it's like very easy. Saline करके भी inject देख सकते हो आप. No problem at all. Okay.
So when we do Bozarus, is it like it should be?
I'll tell everything. Oh, I'll come to the injection part. So now, crow's feet. Crow's feet, very simple injection. Very, very simple injection. Don't be scared of the smile abnormality. Don't be scared of that thing, please. Why? आपने सिर्फ इंट्राडर्मल इंजेक्शन देना है, बस दैट्स इट. यहाँ पर भी इंट्राडर्मल, वो आपको जो ब्लैब है ना वो बनना है. यहाँ भी इंट्राडर्मल, एवरीवेयर, एब्सोल्युटली सेफ. द zygomaticus major is here. So when you inject the zygomaticus major, it's a thick muscle. So you have to go a little deeper. So we are staying in the dermis. Where is the muscle? Subcut के नीचे जाके है. तो आप dermis के अंदर हो तो absolutely safe हो. So just needle tip going inside, inject and come out. That's it. Very safe. तो हमें जो है वो like oculi के अंदर, smile for me please. Yeah. So in her case you can see there is hardly like any profit. इधर कर लीजिए. फिर there is a good hair. But पूरा नहीं बना है अभी. ये बना. Relax कीजिए. Relax. So orbit margin and you put one hair. So it's something like, and one hair. Like that. So this is for the crow's feet. Okay. No. What I'm saying is,
I mean, see, when you hold like this, then you have to change to inject, right? Whenever you change it, the needle moves, it causes more pain. So learn to go in with the jab. Yeah. Perfect. Go in. Good. Okay. And 4 units. Not at all. There's not a filler. It's botulin. If it goes in the vessels, nothing's going to happen. Okay. So that's what the needle was pointing more or less perpendicular, a bit upwards and deep. Okay. He has a lot of very thick skin. So you have to go in deeper. Otherwise, you'll not reach the muscle. Okay. You're going to inject now. So now you're going to inject the tail. Huh? Initially, you may not inject the tail. Okay, be very careful. Now, this is where the muscle becomes superficial, injects into the skin, the dermis. So you got to be superficial. Okay, what you can do is go obliquely, inject here. Don't go too deep. Huh? Don't see a papule. Not necessary to see a papule, but definitely don't go in right in. If you go this way, it will go more deeper. You go this way, it won't go so much. Okay, and direct your needle laterally and upwards. Yeah, little more laterally. See your entry point and your injection point are going to be different. So here, because needle go ahead, na? Yeah, that should be okay. And just 2 units, 2 to 3 units are enough. Bus, that's it. Okay. So the maximum dose is always medially, where the muscle bulk is the most. Or it could be equal doses, and the least dose is going to be laterally at the tail. Huh? So we have 4 units here. Who's going to inject? Come. Similarly, now we have 4 units, right? So inject in the midpoint because we injected 6 here, right? So inject in the midpoint. Same way upwards. Yes, you can hold the muscle. Go a little laterally, midpoint. Yes. Upwards, laterally, go right in. Perfect. And inject the whole thing. Superb. Great. No. I prefer to inject faster. The pain gets over faster. Okay. This is not really so painful. This isn't painful. And he's very, very cooperative also. Who's X? Who's? You can, yes, of course, 2 to 4 units can differ. What I showed in the marking, na? So it depends. This is more or less equal. It doesn't, okay. So give equal. In this case, it's more or less equal. Now, I want you to give the medial most point. She's gone in laterally. I want you to inject in this area, okay? And 6 units. So hold with one hand, stabilize, orbital rim, yeah. Going straight, hold like this. Yes, perfect. Yes, yes. Going straight in, perpendicular more or less. Yeah, okay. Perfect. 6 units. That's it. Gauze. Don't run for ice. If there is oozing, pressure is the first and the most important thing, not icing. Icing comes later. Remember Love and Bailey's chapter? After nephrectomy, they used to actually go and pack the renal artery. For 20 minutes. They used to go and have lunch and then they used to come back. And then it used to clot by that time. Renal artery you're talking about. So first thing what I've seen, people run for ice. Nothing works better than pressure. If there is oozing, give pressure for 5 minutes and wait. Most of the time, the surgeon doesn't have, the injector doesn't have the patient. So ask your assistant to press for 5 minutes. Press for 5-7 minutes and then wait. Okay?
Can I have my bag, please? The blue bag here. Thank you.
स्माइल कब इफेक्ट होगा? हम क्या गलती करेंगे कि
कौन
स्माइल
सा?
इफेक्ट हो जाएगा?
Zygomatic major. कभी नहीं हुआ आज तक. It's a very, very extremely rare thing. Rare thing. Please forget it. मैंने बोला, हाँ, please forget it. We don't have any table here. Just put it on the table, please. Put it on the table. Yeah, just dab there.
Where are the chances of ptosis? Don't remove the points every below the points. That's also.
Sorry?
Where are the chances of ptosis?
Browtosis. Who would like to answer this question? She's asking browtosis.
What about ptosis is when you will inject this area, danger area. That muscle will weaken and that will not pull this up, this will fall down.
Fantastic. She's very alert. She's talking about the frontalis. So you are not going to inject this strip. The reason is only that you don't want orbital occlusion to take charge and browtosis. So we don't inject this.
Or the last line when she cuts.
No, it's not about the last line rule. Sometimes the last line I always follow like around 1.5 centimeters up. Yeah, that's so there is no need to go very, very down in that area. Yeah. Okay.
If they are very deep.
Just a moment, please. I just come. ये ना 40 यूनिट वाली नहीं 100 यूनिट वाली इसको कैसे करना है डिस्प्ले पे Oh my God! Good to see you.
Yeah. So which indication we are using here?
Just tell me about the 1 unit is इसका क्या करना है? Forehead पे लगाना है हाँ.
Diluted with 3 ml, right? Yeah. So every 1 unit is 1 line is 10 units is 10 of this.
1 unit is 1.
1.
एक minute. So we have to give 4 units then.
Yes.
4 units in 1 point in forehead.
Yes.
है ना?
नहीं कैसे? 1 unit.
इसका एक मेरे को forehead पे देना कितना देना है ये बताओ बस. ये 0.1.
1 dash.
0.1 ये वाला.
1 dash.
No ये ज़्यादा नहीं हो जाएगा बहुत.
1 dash.
1 dash.
बस.
Yeah.
तो नजर भी नहीं आएगा वहाँ पे. 40 में तो नजर आ जाता है ना वो ब्लैब भी नहीं रहेगा इसका.
Blab नहीं रहेगा. 1 or 2 depends on.
No, what I remember is that 1 unit is equal to 3 units of Botox. Dysport का मुझे जो याद है.
2.5. It is 1 is 2.5.
2.5. 2.5.
Yeah. So if you give 1 line is 2.5.
Yeah.
So if you give 2, it will be 5 units.
We call Dr. Jyoti.
See, I don't want to tell them wrong because I want to be sure first.
Hey, what he's saying is right. 1 dash is equal to this thing, 2.5.
0.25 होना चाहिए। ये 40 यूनिट के बराबर है ना?
बराबर 0.25 सॉरी।
ठीक चल रहा है। कुछ कभी फोटो ले लिया कुछ। फोटो कब तक करना है हमें ये? वो टाइम तो हो गया। इंजेक्ट कराएं फटाफट। हाँ?
बहुत बढ़िया। हाथी का पूरा डिस्प्ले हो रहा है और इतना मस्त लग रहा है, इतना से समझा रहे हो ना, मुझे से तो कोई समझ में आ गया।
हाँ जी। Just tell me, I have to inject, give 1 point in the frontalis muscle. How much?
1 unit in the frontalis muscle.
Yeah, it will be only one line.
How is it?
2.5. 2.5.
0.25 must be.
See, देखो 1 unit, 1 minute, 1 unit of 40 unit syringe
This
is
is equal to 40 units.
2.5.
I actually came to talk to you. Yeah.
Superficially, half to 1 unit. Don't try this, huh? This is safe. This is safe. Don't try this. Okay? This only comes with a lot of experience, but a very small dose. Okay, yeah. So just inject 2 points out here. 2 units, okay?
Anything, don't ever hesitate कि मेरे को ये पूछना है, you are here to learn. हम भी आपकी तरह थे. Ask anything, whatever you want.
So the concept of spoke and anti-spoke.
Hmm.
Spoke occurs with
Spock.
And what is the brow lift? Is it the same as the
No.
anti-spoke?
Wait.
The three of the things are
Different.
very different.
So this is frontalis muscle. This is orbitus oculi. So first we talk about the Spock. Frontalis ends here in many patients. In few patients, the fibers goes like this also. So when they raise their brow, ऊपर कीजिए जरा, नहीं ऊपर हाँ, raise their brow. This part of the frontalis, because we don't inject, we have been told mid-pupillary line के lateral जो है आपको inject नहीं करना है, correct? So the moment we inject it, so this we don't inject it, this lateral fibers they become hyperactive because the whole muscle is relaxed. So when they become hyperactive, now there are no lines here, but whenever she's talking after 5-7 days, the moment she tries to raise her brow, ये तो हिलेगा ही नहीं, और ये सारा का सारा ये उसको ऐसे उठा के ले जाएगा. So she's like that, right? तो ये ऐसे ही रहता है muscle, और ये ऊपर चला जाता है ऐसे हो जाता है. So in that case, what you give a point in that part of the muscle you want to relax, and that is called anti-spock point, and it has to be in the frontalis. Okay, don't worry. Dev will be here only. So this is like anti-spock point, and anti-spock point will relax the muscle. Now there is no more hyperactivity here. The brow is going to come down when she's talking. One. Second point was brow lift. Brow lift. In this brow lift, we want this. Sorry? We want lateral lift to the brow. Yeah. So in first case scenario, patient is a young girl. She says, I want brow lift. Inject here and send her home. In second point, the patient says that I have got, like I'm in frontalis also, and I want to do this also. In that case, if she has this part, she has to make a compromise here. She has to. Why? Because when you will inject this area, it's going to go little up. So both these things would be there. You have to tell and warn patient. In that case, this is going to be a problem because I cannot inject this part of the muscle because you want brow lift and this part has to activate. So you have to be careful in that. And tell patient before. Nobody comes after 50 for brow lift, 40 for brow. They come like in the younger age only. So if you have to combine both, leave this thing, inject the middle of the medial frontalis and orbicular subcoli. Just 2 points here.
So little bit of spocking will be seen with the lateral lift.
It's not the spocking. Spocking में क्या होता है कि wait a minute. Imagine I have got like a square here, and this is immobile. So this part of the brow is not moving at all, and suddenly this part is going up, and I'll show you the spock. It looks so bad actually. It's like this and then down. ऊपर नीचे. I'll show you that. Oh, Mr. Spock. Huh? Okay, so this is like Dysport today. So we diluted 3 ml, and now this is 100. So it's taken that 1 unit of the toxin. The other thing we use is 2.5 unit of Dysport. What does it mean? It means that in a 40 unit syringe, if I inject 1 unit of toxin, I take the name here, like Xeomin, like Botox and other, they are in the other dilution. So this is something which is dilution of 3, right? So in 3 ml, so the 1 unit of that is equal to 2.5 unit of this syringe. If 100 unit, and I got the 40 unit, so if you divide it, how much is there? 2.5. So 1 unit here would be 2.5 of this. So if I transfer it to the other, it will be 1 unit is 1 unit. Okay, so I'll be injecting 2.5. So don't get that this 2. Like it's just like TS, it's not toxin. So you injected that confidently. You have to be in front of the patient in a confident way. So you have to facing patient. You have to inject which side you have to stand and do it. So 1 unit will inject now here. So I start from here, 1, 2, and 3. We go inside. So I go just that much only. Okay. Then you inject. You have to be careful that the lining should be in front of you so that you can see how much you injected. Just dab it, please. Okay, 1, 2, and 3. Relax. Relax, please. Can you feel the bleb here? Yeah. So similarly, we inject here. So who's going to inject? Because we have only 8 points. 2.5. 2.5. Okay. You can do it from there only. No problems. Sorry? Okay. I go that side. Just a moment. Yeah. Yeah. हाँ.
तो यहाँ पे जो वर्कशॉप है वो चालू होगा. आपका एक्चुअली वहाँ पे लाइव आ रहा था. So we're going to cut it off in next 10 minutes.
Okay.
We're going to continue with the next section.
Okay. All right.
You can take your...
Guys, wait. Guys, wait. Let me come. Okay, you have to see there. 2.5. Excellent. Excellent. Relax, please. Relax. निकाल लो. छोड़ दीजिए. See the bleb here. So the marking, you should not be, like injecting in the heart of the marking. You have to little here, left and right. So who's next, please? There is no need to take the whole needle inside. Just give him the way, please. There's no need to take the whole needle inside. You have to just go inside and inject and come back. So this is what I was exactly saying. I'll teach you how to inject here. Just go inside, inject and come out. Okay, please do that. 45 degrees, please. Yes, excellent. Inside, relax. वापस आओ, थोड़ा वापस आओ. Relax, थोड़ा वापस आ जाओ, कोई बात नहीं. See, now what happening is that you have marked it here. You put your whole needle inside and you will land up injecting. थोड़ा पीछे कर लो और पीछे कर लो, कोई बात नहीं. Okay, you injected? Relax. बस. अब इसको भी देखना है. Okay. See, you have to be very careful while injecting. See, you have to inject half of this. This is 1 and 2. This is 1, 2, 3, 4. So you have to just put half. Yes, yeah, please. Okay. We don't want ki Dr. Kavita baad mein bole pata nahi enna wala pata hai. So now center point. Who's going to inject? Are you okay? Are you fine? Okay, one thing more. Keep talking to your patient. Make them feel very comfortable in a nice, like music and good, lit room and all. It's very important. And other thing is that you have to be, friends with the patient. जब तक ये relax नहीं होंगे ना, आपको result नहीं आना है. The positive vibe, the positivity, everything should be there. आपके हाथ नहीं. हाँ जी. So 1, 2, 3. Okay, please put a little bit here. Center point. Lines, you can see the lines.
60 तक लेके आना ना आपको, यहाँ तक रहेगा, आधा हो गया ना.
6 और.
हाँ, 6 तक लेके आना. इसके अंदर हम 2 लगाएंगे, right? And I have seen like most of the youngster holding, like needle like this. You should. Why don't you hold like that? आप लोग इसको ऐसे क्यों पकड़ते हो?
तो PRP का practice करना है.
Okay, 45 degrees. Relax. Okay, now inject. If you inject intradermal also, then also it works. Don't worry. 6, and please stop. Okay. Yeah. Thank you. Okay.
So what if you
Fantastic.
go deep, sir?
Hanji?
What if the blood is not formed?
Blood will form.
If you go deep.
Doesn't matter. I'm saying if you give intradermal also, then also it works. It's not like ये muscle में नहीं किया होगा. It works. It's a very superficial
Blood
muscle.
is intradermal.
I'm sorry.
Blood is intradermal.
Yeah.
Even intramuscular is blood.
No.
Now you are injecting intradermal.
Now, see, the thing is that intradermal, I'll show you exact intradermal. But I want you to do it, I'll show you later. Intradermal is like when you just go little in the skin and inject, you feel lot of resistance. And then white thing, the pure orange comes. So that is something which is intradermal. Resistance body में dermis देती है. Subcutaneous नहीं देता, नीचे muscle भी नहीं देती. So intradermal is always resistance. You have to push it. Okay, we've given here. So now we give here. Please
No need
still.
to retract.
We have marked the points.
No, sir. अब blood में गया तो ऐसा
No
करना
need.
नहीं है.
Half, please. Bas, half. Don't go very. More,
Tell us
please.
about the complications.
Thank you. Good. Okay, you want to repeat that thing again, the whole thing?
Yeah, we won't mind.
I'll come to it later on. So this is done. Now see, when you inject from here. So you have to be at the distance, so stay at one place and always, inject in one direction, not like that. And try to put this needle very little. There is no need to put the whole needle inside. See, the thing is that it has to be upwards because we want to spare this area.
One unit
Hmm.
in each point.
Hmm.
If there are deep lines, then
Hmm.
how much unit should be put?
One.
Only one.
One unit. No need. Number of points you can increase, yes.
Yeah, the number of points will
And forehead, size of the forehead. If the forehead is that small, how could you land up in putting 15 units there? You'll freeze everything. Beauty is touch up. So I tell to success. Otherwise, so Sarah,
whenever you're going to poke the cock, it's going to get a little blunt as it is, right? Fortunately, it's very good needle. Otherwise, when you puncture the cock, the needle normally get blunt. You're supposed to change it. You can't change in this. So that's why I don't inject more than 15-20 units per needle. Okay? The cost of this is nothing. So it doesn't matter.
So I request the chairperson, Dr. Rakesh Bharti and Dr. Shikha Sharma, to come on stage and preside over the session. Check the mic, please. Mic.
Hello. Good afternoon, everyone. So the next session will be on basics of derma fillers for modern aesthetic practice. So I would like to invite Dr. Maya Vedamurthy for her session on science and background for derma fillers. Ma'am, please.
Good morning. Good morning, respected chairpersons, especially my dear friend, Dr. Rakesh. Good to see you. Hello, good to see you. And dear delegates, at the outset, I would like to thank the organizers, especially Dr. Sahil and Dr. Madhuri for giving me this opportunity. I think it's one of the best conferences I'm observing after AC. AC and BC is no longer before Christ, after Christ. It's before Corona, after Corona. So I think the credit goes to them. My topic is science and background of dermal fillers. I have no disclosures except that I'm a trainer for Allergan, but it's got nothing to do with today's work. The objective of my talk is to give you an overview of the basic properties of dermal fillers, because this will help you to translate the relevance to clinical practice and see how you can best apply it to your patients. So why is science of fillers so important? Why are we all talking about it? For a successful filler practice, three things are important. That's the ATP, just like your ATP of mitochondria. A is for topographical anatomy. T is for knowledge of technique. P is as important as your anatomy and technique. Now, if you look into the history, autologous fat was used for more than 100 years ago. Fat was harvested from the arms for correction of facial defects due to cutaneous tuberculosis. And paraffin was injected into the scrotum as a testicular prosthesis in patients with advanced tuberculosis. Silicone was the next filler agent, but was banned by the US FDA because of the side effects. Bovine collagen was the first agent to be approved by FDA. And since then, many fillers continue to flood the market, and it's a difficult choice for us to make, which is the best. Just to remind you about the science of fillers, what harm it can be done if you don't choose the right filler. This is paraffinomas and silicone nodules. This is a young Korean who injected silicone and cooking oil. Right. The next picture is that of a silicone nodule, silicone injected into the Can I just use this? Yeah, I just. How do I open? Yeah. It's not showing. Which is the green? Which is this is better? This is the pointer. This is silicone nodule injected into the tip of the nose and the columella, and you can see the results. It's a siliconoma. Luckily, we have some safety regulations for our patients. Injectable fillers are considered as class 3 medical devices, which means that these devices have to be approved by the pre-market approval process. So we are much safer now. If you look into the properties of fillers, the composition of the filler is the most important thing. By composition, I mean the filler substance. It should be an ideal filler substance which is non-immunogenic, which is non-pyrogenic, and it should be non-allergenic. It should be safe and biocompatible and yet give you the desired results. The next important thing is HA cross-linking. And the third one is the rheological properties, which consists of elasticity, viscosity, cohesivity, flexibility, and the particle size. What do we mean by rheology of fillers? It's only the physical property of the fillers. It's mainly related to the flow-related properties. It actually reflects different manufacturing process of different products because all these companies have patented technologies, and this rheology will give you an idea of what each filler is. And this is the one that determines the clinical outcome. However, there are so many variables among the fillers. These include the cross-linking, the concentration of the ingredient, the gel hardness or plasticity. The particle size is very important. So is the cohesivity and viscosity. Tissue integration, how it integrates into the tissue after it gets injected, and the degradation properties, which actually helps you to promise the duration of the or longevity of the filler which you have injected into the patient. All these are very important before you choose a filler for your patient. Now, rheological evaluation actually enables the clinician to objectively classify soft tissue fillers and to select specific filler products based on the scientific principles. It also reliably predicts how these products will perform because some fillers you want them to lift, some you want them to just volumize, some you want them to just hydrate. And after they've been appropriately injected, you should get the desired results. And remember that during the injection process, a filler is extruded through a hole in the needle with particular force. And after injection, the filler is again subjected to movements by facial musculature, overlying skin, and fat. Therefore, we need to choose a filler that can withstand such compression and shearing forces to give a good and long-lasting clinical outcome, because this is what your patient is interested in. They are not interested in the rheology of the filler. They are only interested in the cost and the longevity and the results. When you choose dermal fillers, it's one of these indications. You either choose them for volumizing, lifting, hydrating, or biostimulating properties. Fillers are classified based on the longevity as temporary 0 to 6 months, long-lasting 6 months to 2 years, semi-permanent 2 to 5 years, and anything beyond 5 years is a permanent filler. There is also science behind complications of fillers. You need to know the physicochemical properties of the fillers because they influence the risk of certain complications. For example, granuloma occurs less frequently with resorbable than with permanent fillers. And all fillers, remember, contain some foreign body material which may trigger immune reactivity no matter what approval they have undergone, what tests they have undergone, although to a different degree. Example of late, we have on COVID vaccine-related filler reaction, which we all need to remember, no matter what we inject, whether it's a Restylane or Juvidum, it does not matter. Therefore, these are the 4 groups of approved fillers, which I would encourage all the beginners to start with. The hyaluronic acid, we have the Belotiro, Juvidum products, Restylane products, and we have the new RHA, which are actually termed as the dynamic facial fillers. We also have the calcium hydroxylapatite, the PLLA, and polymethyl methacrylate. So it's good for you to just start with the approved fillers. These are some of the key considerations in a filler practice. Remember the 4 Ps. You have to plan injection strategies. That is the anatomical placement, the active numbers, that's the amount of filler that you're going to deposit in a place. The delivery based on viscosity, extrusion force, and elasticity of the product. You would either choose a needle or a cannula. To preserve facial dynamics, you need to choose appropriate gel firmness. And for projection, you need to choose the product formulation because you need to choose a filler that has a good lifting capacity, which is dependent on both the G prime and cohesivity. And most important is to predict the longevity. You have to know the degradation effects because this leads to loss of clinical effects. Of this, cross-linking is very, very important. Cross-linking is definitely needed to prevent digestion by the body's own hyaluronidase. Remember, all of us have natural hyaluronidase in our system, which is responsible for degradation of these HAs. Non-cross-linked HA is a liquid, therefore it is not fit for injection. And the cross-linking provides structure to transform the liquid to a gel or a solid state. Now we have, based on cross-linking, we have monophasic versus biphasic fillers. You need to understand the difference between the two. Monophasic gels are a mix of high molecular weight and low molecular weight HAs, example, the Juvidum family. And biphasic gels consist of cross-linked HAs suspended in non-cross-linked HAs, which serves as a lubricant. They do not cross-link with the HA. This is the Restylane family. Why is this important? What is the clinical implication? Monophasic HA fillers show a higher degree of swelling than the biphasic, so you need to inject less of the monophasic when you're promising results. And most important is a hyaluronidase reversal. Sometimes you want to reverse the effects or you want to inject hyaluronidase when you come up with complications. Remember that products of the Juvidum family require more hyaluronidase to dissolve than the Restylane family. For example, 30 units of hyaluronidase is required to dissolve 0.1 cc of Juvidum and 10 units of hyaluronidase for 0.1 cc of Juvidum Ultra, whereas you need just 5 cc of Restylane. That is necessary based on the amount of filler that you have injected into your patient. Now, cohesivity is most important. Remember, it's just the ability to stick together. Think of a bubble gum or a chewing gum. This is what it is. Filler cohesivity describes addition between cross-linked HA molecules. It is the capacity of a material not to dissociate because of the affinity for one another. There is less fragmentation in the tissue. As you see here, a most cohesive product stays together. Low cohesivity fillers spread easily after injection, making them well suited for a superficial and highly dynamic areas such as a lip. Whereas high cohesivity maintains their structure and projection, making them better suited for deep injection, for volumization and structure. This is what you want when you want to have a lifting effect. Now, moving on to the next property, viscosity, which is described as double G prime. It is basically the flow characteristics of the gel, which defines gel spreading. Think of water and honey. And I also have another analogy to show you. It is basically a measure of the capacity of a material to remove the ability to resist deformity to shearing forces. You can compare it with peanut butter, where there is less spread and less subject to shear thinning, versus the butter at room temperature, where there's more spread and more spread to shear thinning. Elastic modulus is G prime. This is very, very important. It is another way of describing how much the projection or lift can be given with that particular filler. This filler has to be highly cross-linked and have to have a high concentration of HA. Otherwise, you're not going to get the desired results. It's basically the ability of the gel to return to its original shape and the ability to resist compression. Think of an elastic rubber, how it comes back to shape even after a shearing force. It is used commonly to characterize the firmness of the gel. And this is basically the difference between high G prime versus low G prime. In a high G prime, is the analogy is gelatin mold versus a chocolate pudding. In the high G prime, you need higher extrusion force from the needle, and there is more tissue lifting, and it is stiffer, feels more palpable. So when you want a lady who just wants to have a firm mid cheek, this is a filler that you need to choose. Versus another person who just needs subtle volumization, you need to choose a filler with a low G prime you remember that force from the needle, less tissue lifting, softer feel, and less palpable. And especially higher G gels require is mainly injected into the areas where you want more lifting, and low G prime where you want more softness. There is another measuring scale, which is a tan delta scale. It measures the viscoelasticity. It is a ratio of G double prime versus G prime. And remember that fillers with low delta is injected into the deeper planes because they are more viscous, and fillers with high delta are injected superficially because they are less viscous. Now, particle size, how is this important? Uneven particle size may result in an interrupted flow of the product through the needle or cannula during the treatment, whereas a homogeneous particle size, which is present in the Restylane family, allows for a more precise gel placement during the treatment because there is no disruption during injection. The depth of the filler placement is very important. When you place a HA gel in the deeper layers just above the supraperiosteum, remember that there is more stretch and compression and less shear and torsion. Therefore, you need to choose a filler with more viscosity when you're placing it over the periosteum. And remember that fillers placed just superficially, there is more shear and torsion and less stretch and compression because there's no musculature or no fat to press down the product. So there you need to choose a product with less viscosity. Otherwise, if you put a higher viscous product there, it will look lumpy and bumpy. This is just to give you an example of the different technologies. Restylane has two technologies, one dedicated to filling, lifting and precision, and this is considered the natural technology. It is more suitable for nose, chin, and jawline. But remember, just the center of the face. If you remember, lifted parts of the face. OBT is designed for contouring and expression. Example, the lips, nasolabial fold, and the cheeks. Now, Juvederm has a similar variation in their products. We have the Hyalocross technology versus the Vycross technology. The Hyalocross technology products are the Juvederm Ultra and Ultra Plus, whereas the Vycross is the Juvederm Voluma and Volbella. Hyalocross, it has just cross-linked high molecular weight, whereas Vycross, you have tightly cross-linked low and high molecular weight. This is the analogy is if you have a jar filled with pebbles, it's just a Hyalocross. If you add gravel to it to make it tightly packed, it's a Vycross. So these are simple things how you can remember. Rheological properties translate to clinical indications. For a person who wants a cheek lift, jaw defining, or a chin defining, you need to use products with a lifting capacity that is a high G prime because this is when you would get a good projection. Supposing you want a patient who wants tear trough or nasolabial fold or perioral lines, remember that these are soft structures. Therefore, you need to choose a medium G prime product and a softer material just to give you a good support and structure. You don't want any lifting. You don't want any elevation of these areas. Similarly, for areas around the lip and lip complexes, choose products with less cross-linking so that your product is flexible and soft. And remember that it needs to look and feel natural. Now, tissue coverage and G prime is very important. We have sometimes mature patients who have thick skin, and you also have some young individuals or even older individuals who have thinner skin. Therefore, your G prime should vary. Patients with thick tissue coverage require a good lifting capacity. Therefore, you need to choose high G prime products. Whereas patients with thin tissue coverage who are bony, they just want to have some cheek elevation. Choose products with a lower lifting capacity because they just want a chisel look. They don't want a bulky look. And you need to choose products with a low G prime. Now, HA concentration is important for hydration. The effective HA concentration is actually the cross-linked HA minus the non-cross-linked HA. So you have to look for the amount of just the cross-linked HA. Don't take the whole cross HA into account. Concentration is also important for longevity and swelling properties. The swelling ratio decreases with the degree of cross-linking and increases with concentration. So we have a few hydrating fillers in the market. We have the Volite, the Profilo, the Restylane Vital, and the Bellatiro Hydro. You can see how they vary in their technologies, and this is what makes it versatile. And after injection, you also need to know how these products get integrated into the tissues. For example, biphasic products aggregate pushing apart the dermal collagen bundles, they stay together. Whereas the monophasic products get dispersed, they get integrated in the tissues. That's the reason you need more amount of hyaluronidase for reversal. Whereas products like PLLA, which are supposed to be biostimulatory, they form a capsule, a fibrous capsule around the product. As I mentioned earlier, biodegradation reflects the longevity of the filler. Remember that biodegradation can happen with free radicals. And remember that all of us have dermal hyaluronidase in our system, just that we know that it varies in the area. For example, around the eyes, we have less amount of hyaluronidase compared to other parts. That's why under eye stay longer than the other parts, hydrolysis, and by mechanical stresses from muscles and fat which are placed above the filler. But in real life, what do? We just see where the filler comes from, which company it comes from. We want to know whether it is an approved filler. You want to know the manufacturer. You want to know the composition, whether it contains a local anesthetic or it's just a pure filler. You want to know the needle size or the cannula that is acceptable for that product, and you need to know the depth. So it's good to have this in your office to see as a ready reckoner. Coming to the basic indications based on whatever I mentioned today, and in today's workshop, we are just going to see the first two basic indications, the nasolabial folds and the mid-face lift. However, the beginners can also try injecting the marionette lines and the resting crow's feet because the learning curve is less here. And I would recommend the MD codes for beginners who want to start off with the filler practice. In conclusion, science of dermal fillers is very important. It allows classification of fillers that can be used to predict a filler injection's outcome. That is whether you want it to be volumizing, lifting, or hydrating. The rheological tailoring facilitates selection of specific filler products to achieve specific clinical endpoints. And it also helps the injector to meet patients' objectives more fully and cost effectively. And this is what is most important in our practice. Thank you for your patient listening.
Thank you, Dr. Maya. It was lovely. When the organizers asked me to chair this session, I thought I am a square peg in a round hole, a basic dermatologist listening to fillers. But then it is important for a dermatologist to know because they can cause complications. So our next speaker, Dr. Nitin Sethi, is talking about the complications of these fillers and their management. And I think organizers have also told me that Dr. Tarun Mittal is here. So he'll be chairing the session with us.
Yes.
May I request you, sir, please? And with that, I'll request Dr. Nitin Sethi to talk about the complications and management of fillers. And thank you very much, Dr. Maya, for that lovely talk. Thank you.
Good morning, friends. I'm Dr. Nitin Sethi. I'm a plastic surgeon, so it's great to be among a group of cross-specialty friends. I think we've been discussing a lot, and we talked about this a number of times. Whose line is it, anyways, right? I think it's everybody's line. I think anybody who's skilled enough today can go ahead and inject as long as you have a valid degree to do that. So I don't think there is a real difference in whose line is it really. But anyways, I'll take care of the complications. I'll help you go through it. I think this is very, very critical. What the mind doesn't know, the eyes won't see. So if you don't know what complications can happen, I think life is very, very difficult. And as Dr. Maya, I admire her a lot. She's a very dear friend. We've discussed this a number of times. I think 2 or 3 important pillars of what we do in our practice. One is the knowledge of anatomy, the knowledge of aging, and I think complications is part and parcel of what we do in our practice. Anybody in the hall who thinks that, oh, I do fillers and I've never had a complication in my practice, there is, I think, just one answer to that. You probably have not done enough work, right? So, I'm going to prove that, right? So it's going to be very, very interesting. So just a toolbox for all of you young guys. It's not a race, okay? So don't try and chase the number of syringes that you can pull off probably in a day or probably in a month. It's not important. If you can pull them off in the right manner and have more happier clients, I think that makes much more sense. Safety is in a slow hand, and you will see this through this entire presentation as well. If you are safe, there is nobody as an absolutely safe injector, but you can be a safer injector. And I think that is the most critical thing of what we do in our practices. Wait and look before you start. So, I think as in aesthetics is so glamorizing that I think we tend to forget our basic knowledge of the art and science of medicine. There's a beautiful book that I did read about Dr. Farooq Udwadia. He's written this beautiful book saying the art and science of history taking. It's an entire book on history taking, which is surprising to a lot of us. And we think, what is so important with history taking? Maybe I think there is also an art and science to clinical examination. So please do examine your patients very well before you start injecting. So the color of the primary area that's being injected and the color of the surrounding secondary areas, which can potentially get affected if you are doing fillers for your patients as well. So, if your clinic closes at 7:30 or 8 o'clock in the evening, please don't start injecting at 5, 7 o'clock. So try and call these patients in at an earlier time. So there is enough time if something goes wrong and your friends and your well-wishers are available for you on call if something goes wrong. Okay. The most important step, I think this is probably a very important slide. I love this one. I think, there is always a rear view mirror on the face, and treat the glabella as the rear view mirror. It's an area that will point to you first and foremost if something goes wrong to your patient, especially for a vascular event, right? So always know what the primary quality of the skin was in the area, the primary texture of the area, the capillary refill of the area, before you actually start injecting anywhere else on the face. And I think that is very, very critical. Now, this is very, very important. This is from a study, a very interesting study that Dr. Greg Goodman, we all know him, is a plastic surgeon, very famous in Australia. Greg did this study in a conference where, they asked about more than 100, they asked about 52 trainers who had more than 10 years of experience in aesthetic practice, if they had a vascular complication in their practice. And 67% of them said yes. In fact, 71% said, they had it more than once, right? So this is very, very interesting. Not just once, it may happen more than once to you. So, be aware and be ready for something like this if that happens ever. The area that was being injected when the vascular complication happens the most, right? The nasolabial fold. It's the area that most of our patients are often asking us to inject also. That's the unfortunate part. The two indications that most of us are asked to do by our patients are actually the most complicated as well. One is the nasolabial fold and the other is the tear trough. So always be aware of the complications that can happen in this area. The same paper continued. And if it was an intravascular obstruction, what was the most likely cause? So the nose, the nasolabial fold, the forehead, and the glabella are very, very tricky areas. So please, if you're a beginner, don't try and inject these areas. Try and have enough confidence in your practice before you actually start to do that, and have your fail-safe mechanisms in place if something goes wrong. My life's been made easy by Dr. Maya. Ma'am's spoken a lot about rheology of fillers. I think rheology is very, very important. It's very important to know how the filler will behave once it's injected. Not all fillers are just mechanical fillers. Some of them have inflammatory action as well. And knowing that will help you decide what sort of a complication you can actually end up having. Now, I'm an anatomist by choice. I love anatomy. I think it's fun. A lot of people find that boring, but I think it's fun. And I think that makes us much more safer when we start to inject. This is a very interesting paper. I'm going to talk about it for about a minute or so, Dr. Taylor, Ian Taylor, to all plastic surgeons, he's a godfather. We've all read his textbooks on flap surgery and flap dissections. Dr. Taylor came up with this very recent paper in 2017 when he talked about the concept of choke vessels and true anastomosis. Just to give you a brief idea, I hope the pointer works here. No, it doesn't. It's okay. Is there another one? Yeah, I checked. Anyways, just a second. Yeah, I just want to be here. It's okay, doesn't matter. So just the two figures you see, the one on the left, on the right of the screen is an anastomosis where the size of the vessels becomes narrower to the post-anastomosis site, right? That's very, very critical to know. And also there are certain true anastomosis which can exist, which means the size does not change as time moves on, right? As the vessels are moving from one area to the other. So having a knowledge of where these anastomotic sites exist, I think makes a lot more sense. There are certain sites which are definitively known to have these choke anastomosis. The facial anatomy is blessed. It's blessed in the sense that we have a dual blood supply on the face. While it's a very big advantage for vital facial structures like the eyes, it's also a disadvantage to an injector. You can actually start injecting into the extra carotid artery or the external carotid artery system and end up injecting into the internal carotid artery system through the presence of these true anastomosis that you have, right? So that is why if you're injecting a patient, say in the nasolabial fold, and suddenly the patient says, "Oh, I'm having a shooting pain, which is disproportionate to the size of..." Perfect, thank you. We found it finally. So if your patient tells you that I've had a pain which is disproportionate to the site of injection at a site which is distant, please stop injecting there and then. Don't try and finish off the syringe because it'll get wasted and then decide what to do next. So the most important step is there and then. Okay, and this is just from the same paper. Paucity of time, I don't think I have enough time to explain the phenomena of choke and true anastomosis and how the presence of choke anastomosis will restrict the spread of a vascular event, while the presence of a true anastomosis will let the vascular event spread more and more, right? And that is why if you're going to use products like nitroglycerin paste to manage a vascular event, be wary of it. Any vasodilatation will actually cause the product to spread even further, okay? So that's an always challenge. A typical example of a true anastomosis is your arteriovenous anastomosis, which is normally there, right? And most arterial anastomosis are choke anastomosis. So that means there are certain areas, if you inject into one angiosome, the adjacent angiosome can get affected, but the angiosome just next to that one might get spared, okay? And that knowledge is very, very critical. So these are the sites, and this is from a beautiful paper which has come up very recently by a friend, Isolda Hendrich from South Africa. These are the sites which we know are sites of potential choke anastomosis, and having a thorough knowledge of these sites gives you a fair bit of knowledge about when you're injecting into a particular area, what sort of a complication you can end up getting. Just to give you a brief idea about some of the anatomical landmarks, it's important to know the location of these landmarks so you know what sort of a vessel or a nerve you can hit in the area. Certain danger zones now have been very clearly defined as well. And whenever you're injecting in areas like the temple, know what are the safe zones to inject. And if you're injecting around the zygomatic bone, also know there are danger zones right below the zygomatic bone and above the zygomatic arch as well, right? So if you do not hit the bone, do not inject. Very, very critical, right? So this is some of these knowledges that you will come to know if you have a thorough knowledge of the process of aging, or the process of aging, as well as the knowledge of anatomy as well. Now, let's talk about cannula versus syringes. And I'll just load up the entire slide so that, just a second. Yeah. So that I know where we are. Now, a lot of people feel cannulas are safer. Yes, cannulas are much more safer than the needle because you can control the spread of the product. But the choice of the size of cannula does play a very critical role. Whenever you use cannulas which are smaller than 25 gauge, that means 27 and 30 gauge cannulas, they behave like needles. And there is enough evidence to show that the complication rate between cannulas size smaller than 25 is the same with the cannula and the needle. So whenever you choose your cannula, please choose the size of the cannula very well. Okay, and also the direction with which you inject with the needle. Now this is interesting from the same paper by Isolda, and they did a cadaveric study where they changed the direction of the needle just to check how the product spread. And in the cadaver, you can see that the product moved in multiple layers if your needle direction was not right. So whenever you're injecting into certain areas like the forehead, be wary of your direction of the needle, right? Which is also very, very critical. Can cannulas cause complications? The answer is yes. And this is from this beautiful paper by De Lorenzi. His work is actually the founder work for whatever we know about complications, vascular complications. So cannulas can definitely go through the vessel and cause complications. And complications can happen by retrograde movement of product back into the vessel through the tract that has been created by the cannula itself. Okay, so choosing the size of cannula is also very, very critical. Do you aspirate? I think for the moment, the answer should be yes. There is a long debate which is going on whether you should aspirate or not to aspirate. As a beginner, I feel it probably make me much more safer when I aspirate. My logic is very similar to when I use local anesthesia. So if I use local anesthesia and I do not aspirate, and if the anesthesia becomes intravascular, if a patient has complication, no forum, no expert panel, and no consumer court will spare me ever. So remember, we are in the review of so that means Viral in his opening presentation talked about it. I think it's very, very important for the younger generation. It'd be very prudent to talk about the antiseptic no-touch technique that we practice with filler injections. I think it's very, very critical to understand this. Most of your complications the immediate complications and the infective complications can be avoided if you clean the area well and try not to touch the area. So whenever your patient is bleeding, please do not use your thumb to control the bleeding. Your hand is not sterile. We are working in a clean, contaminated environment, and that is very, very critical to understand. Identification of key parts, I think, is very, very critical. So please know that proper dusting, cleaning in your clinic in the area where you're going to set up your filler injection is very, very critical. This is especially true for chain clinics, especially where dermatology is only a part of other services which are being offered in the clinic as well. So please set up an area which is isolated, set up an area which is cleaned regularly, and no oils or massages are done in the same setting as well. I think that is very, very critical as well. Just to give you a few points, for who wherever you will not inject. So any patient who's unwell, especially in this current setting of the COVID scenario, if your patients had a fever, a flu, a viral infection in the near future, please, the patient may be in a hyperimmune state. So try not to inject your patient there and then. Ideally, you should wait for at least 3 weeks post the filler injection, post the resorption of the symptoms in the patient, and then you should go ahead and inject your patient, right? And, a lot of people now are talking about immunity boosters. So people are taking a lot of immunity boosters, which are over-the-counter drugs, which they just go and buy from the chemist, or Amazon's doing a wonderful job as well, helping them buy products which are OTT products. So, please make sure that you've asked your patients to stop all of those drugs also before you decide to inject them for filler injections. We are doing a lot of combination treatments. So surface active dermatology procedures, you should space them between the filler injections and the procedure also, which I think we've had a debate and we can discuss them. Certain indications and contraindications, which are absolute and relative contraindications. Beautiful paper by Koen de Boel. Everything's tabulated here. I'll just run through it because of paucity of time. But it's probably a good idea to just take this take a printout of this table and just have it in the clinic so you know under what circumstances you should not inject a patient. This is a nice consensus paper where, and this is from the Australian consensus, where they said that few things are absolute must before a filler injection. One, clear the injected area for makeup and make sure there is no makeup, or you cleanse the area very well. Mark your injection sites if desired, but make sure you've cleaned the markings, or do not go through your markings when you're injecting. Sterilize the area, again, very, very prudent, and do not touch. So the ANTT protocol does play a very critical role. Now, there is just so much in complications that I can do a full 3-day session on complications alone. But just to save time, I'm going to stick to something which is becoming very, very interesting. And I'm going to make sense of why and how in this COVID era, fillers can play a role in your patients coming back with nodule formations. And this particular term, the late onset nodules, is very, very pertinent for all of you dermatologists to understand and practice. Now, there are 3 things that control any product outcome or any treatment outcome. One is product factors, second is patient factors, and third is injection procedures. So these patients, there can be patient factors which can be contributing, which we've already discussed, and I don't want to spend any more time on that. There can be product factors as well. So you must know what type of product you're using for your patient. And then also know the molecular weight of the product, because certain low molecular weight products have been known to be pro-inflammatory in treatment. So this was an interesting in vitro study which was done. What they were trying to see, hygienic or not. Now it was found that the raw HA is not antigenic in the study, right? And when you are using fillers from different companies as well, it was also found that they were actually, certain types of fillers were actually suppressing some of these mediators for immune response. So what was then contributing to our treatment which could cause the problem? And what they did was to use the most common problem that we often face. They used P. acne as an adjuvant in the treatment, and they realized that whenever fillers were injected in the presence of P. acne, there was an activation of the immune system, which means to suggest that fillers per se are not antigenic, but they can act as adjuvant. And I want to come quickly to this point. They can cause a syndrome, which is very popularly called the autoimmune inflammatory syndrome induced by adjuvants, or the ASIA syndrome. Okay, so that is why whenever you're going to inject your patients with fillers, please be aware that if they are in a state of hyperimmunity, there can be possibility of late nodule formations in your patient. So how do you manage these late nodules? These late nodules can be non-inflammatory, which is because of how you position the product, or they could be inflammatory as well. If they're non-inflammatory and not visible, you don't need to worry about them. But if they're visible, you will need to hylase them either with the hyaluronidase, if it's an HA-based product, or with 5-FU, again with HA-based products, or sometimes you may have to do a diagnostic biopsy as well. The challenge actually is with these inflammatory products, because they can be either delayed reactions or biofilm formation. And the only way to make a diagnosis is to do a biopsy, which is your biggest challenge invariably. So we've discussed this, I'll skip that. Quickly come here. So both of these, the foreign body granuloma and the biofilms, can only be diagnosed with biopsy, and they are treated totally differently. So in one, you will use steroids. In the other one, you do not use steroids at all. So that is your biggest challenge. Just to talk about inflammation, but I'll skip that and come to how I manage most of my complications. So the early complications, try and control bleeding on the table. Make sure you give adequate pressure before you inject your patients. For the early complications like lumps or for superficial placement of product, you have RF available now, and we discussed that point as well. I'll just finish up with a couple of more slides. You have RF available, and that can be used, or you can hylase the product or try and massage if there is adequate time. But if you're early acute onset infections, you need to manage them as an acute infection. We would do that. And this is for the late complications. I'm out of time, so I'm just going to stop here. This is my last slide. A lot of us do not talk about hyaluronidase. Hyaluronidase is very important to know about it, especially if you're using an HA-based filler. If you're using hyaluronidase in your practice, know that it comes in a vial, which is a 1500 unit vial, and it's a bovine origin hyaluronidase. So there is potential for immune response or hypersensitivity to your patients. So if you're going to use hyaluronidase for non-vascular indications, you need to do a test dose for your patient. But for vascular indications, it's an emergency in itself, and you can skip the test dose. Okay, I'll stop here. Thank you so much. And we can talk.
Hello. Thank you, Dr. Nitin. It was a real wonderful talk. And I think fillers, without knowing complications, don't stand anywhere. So before starting, we need to be aware of this and to be aware of the hyaluronidase. You don't know when you land in the soup. It may be the day one. So that was very important and very nicely presented.
I think we should carry hyaluronidase with us all the time.
Yes, yes. Like the mask. So next, we have none other than our own Dr. Malvika Kohli. A big round of applause for her. And she'll be talking on personalization. It's a Galderma sponsored session, and she'll be talking on personalization, excellence with Restylane. Dr. Malvika make pearls whatsoever she speaks. So I think, like me, all of us are fan of her, and I welcome you, Dr. Malvika.
Good morning, everyone, and thank you so much, Dr. Tarun Mittal. We've had a long relationship as colleagues, and it's wonderful for all those kind words. And I stand here with mixed emotions, actually, because this is the first in-person conference that we're having in this COVID pandemic year of 2020-21. And I'd like to pay tribute to the mask. It has taught us much, and it has taught us to reinvent ourselves in this year of challenge. And I would like to congratulate SODC for taking. And it's a wonderful, wonderful experience. And thank you, Dr. Sahil. Thank you, Dr. Madhuri, and the team of SODC for inviting me here. And I'd like to thank Galderma for giving me this opportunity. Well, this pandemic year taught us so much. It taught us that this aesthetic industry that we're all in actually got fueled. We heard about so many new terms like lockdown phase, Zoom boom, and Zoom dysmorphophobia entering into our lives. Digital platforms became the way to communicate, and all of us began to look at ourselves the way others look at us. We never ever realized that when we talk to people, we don't have a mirror in front of us, but what we convey to them may be very different from what we think we're conveying. So people began to focus onto themselves. And lots of times, because people were working from home, there was no makeup, and so imperfections came up, asymmetries. And so finding physical perfection has really fueled the aesthetic industry into 2021. I personally have seen patients, both loyal patrons as well as lots of new patients coming in and younger patients. That really shows a trend that even now the younger ones are beginning to perceive their need to look their best at any stage. So I'm now going to run through a whole portfolio, which is very interesting, and I'm going to also share my experience with it. So personalization with the Restylane portfolio has become a very interesting add-on in our aesthetic practices because it offers really a very nice comprehensive solution. So in the Galderma Aesthetics collection, we have Relax with botulinum toxin, and we have Refine with the whole Restylane range. And within that is the Lift to fill and to volumize. And then to refresh, we have the Skin Boosters. The whole Restylane portfolio, science and innovation, is really ranging from firm to flexible. Can we reduce the lights a wee bit? They're very intense. Can you dim the lights a little bit? They're very sharp because the slides are slightly pale. So the innovation is from firm to flexible. And here, if you see, on your left is the Nasha technology. And on the right is OBT. So Nasha means that it's so firm that even if you take a hammer down, it's not going to move and shift. Whereas in the other one you saw that as the hammer came down, it was a bit more jelly-like, which made it more flexible. So you're going to use firm products where you want structure and structural support. And you're going to use flexible products where you want more natural movement and in a more dynamic area. This is very simply put and easy to remember. So the Restylane portfolio, which is the Nasha designed for lifting and precision, and Dr. Maya really beautifully brought out the basics of fillers and how to differentiate. And as she said, the Nasha, which is designed for lifting and precision, is Restylane Lift and Restylane Classic. And the OBT is basically designed for contouring and expression. And in that portfolio is Restylane Define, which is the newest on the block, Restylane Wall Lime, and Restylane Kiss. So let's look a bit at the Nasha technology. For lifting and precision, it has a natural entanglement with minimal modification, less synthetic cross-linking. These are firm gels with low flexibility. Therefore, they have more pronounced lifting capacity for projection and structure to enhance cheeks, filling lips, wrinkles, folds, nose, chin, and jawline, where precision is required. So when you're looking at Nasha, it's structure, precision, lifting. OBT technology is for contouring and expression with varied degrees of particle sizing, cross-linking of the HA to create a range of gels for more natural-looking effects. These are softer with high flexibility, distributed product integration, thinner tissue coverage. These are the kind of patients who do well for contouring in areas of dynamic movement and natural expression and areas. So if you look here on the left with the Nasha technology, you will see that post-injection, it stays where it has been injected and has a lifting effect, whereas with the OBT, post-injection, it diffuses and has a more diffuse distribution and has a softer curve as well, which allows for movement. Now, again, just a little bit more about the product range, because it's very important for you to know the specifics of each product. When you're using them, you know why you're using, where, and at what depth. Because as you heard from Dr. Nitin Sethi, the precision, product choice, precision, and product placement is key to having the best results and giving your patients a personalized approach and giving them the best possible result and giving them the best versions of themselves. So if you look at this graph, you have at the far left over here, Restylane Lift, and you have classic Restylane, and these are the highest G prime and are very, very firm. This is firmness, this is flexibility over here. And then in the middle, you come to Restylane Define, you have Restylane Wall Lime and Restylane Kiss, and these have flexibility. They're less firm, but Define is a little different because it has flexibility, but also a good amount of firmness, which makes it good to be used in mobile areas and areas of expression. And then, of course, at the far end are the skin boosters because they're flexible. So now that the extent of deformation of a material can stand before yielding is what we call the G prime. Now, let's look at the portfolio. In the portfolio, it is skin quality, hydration and glow, relax and refresh is skin boosters. Classic for tear trough, the Restylane Classic for tear trough works really well. It's robust and yet it doesn't look stiff and artificial. It gives some hydration but not too much, which is also not desired too much in the tear trough area. Restylane Lift is for structure. So these are the areas you will use it, as I said before. Then you have Define, which is for contouring, projections in the cheek, chin, and perioral area. Very good in the perioral area. Restylane Define is fantastic in the lower face. Lips and oral commissures is Restylane mucus, and then you have wall lime. For something where you want to give more volume and still have the flexibility, wall lime is great. If you have thinner tissue, then define is good. So this is how you can place the two in different areas. Now let's go for the Galderma facial assessment scale. And this is based on the concept that attractiveness in a face lies in facial harmony, and the 5 parameters that have been taken into consideration are skin quality, facial shape, facial proportion and contour, facial symmetry, animation, and emotional expression. And we are going to use this scale on the patient that we have today as our demo. The Galderma FAS has been developed to help guide aesthetic consultations. But the most important thing about an aesthetic consultation, as you see more and more patients, is to make sure that you are systematic about it and you standardize it. The evaluation covers the entire face. The patient is engaged and is involved in the process, and treatment priorities can be visualized, planned, budgeted, and also staged. This is where the score really helps. So it's a circle with concentric circles. It's got parameters over here, which we'll go through in our patient. And the whole idea is to mark it in its order of severity from 0 to mild to moderate to severe. So it's like connecting the dots. I'll show you how it goes. And once you connect the dots, the wider the circle and the less concentric it is, the more is the disharmony. And the closer you bring the circle and connect the dots into a better circle, a smaller, better circle, concentric circle, more is the harmony and better is the look of the patient. And that is how you're using the scale. So now let's look at this patient we have to inject, which I'm going to be injecting. So really the session that I have is first the presentation. Now we'll discuss the case, we'll do the assessment, and then I'm going to do a live demo behind scenes, and which will be projected over here. So let's look at this very attractive 61-year-old lady. She hails from the city of Chandigarh, and these are the 3 views. These are the minimum 3 views that you will take of any patient: the frontal, the profile, and the 3/4. Now we can see a lot happening out here. I have done a facial assessment on her earlier today, and I've aligned myself with her issues, which I'll discuss when we meet her, and also her concerns, both. So this is the other side. Now we can distinctly see that she has differences between both sides. So that's why both sides are very important to take photographs of. And this is for my younger friends over here. Your photography should be good. Your light source should be good. Your angles should be fixed. And the black drape behind, a black drape in front, a black band really helps to highlight all the pluses and minuses in any face. So now let's go for the first criteria, skin quality. So these are the 5 criteria we're going to assess in her. And first is skin quality. I think you'll all agree with me that she has good skin quality. And she has the first, sorry, just once. This was the first one. This is loss of radiance. She really has a very nice skin. You'll see it even if you saw it in person. So she gets actually a very good score for radiance. But the loss of firmness is moderate. So this is how you put mark 0 here and you mark moderate out here. And this is the first limb of the 5. She has thin tissue coverage. She's got very fine, sensitive skin. Her overall skin quality is very good. Now let's go for the second one. That's facial shape. In facial shape, we've given her a 2 for sagging, which is moderate, and we've given her 3 for volume loss. The reason being that you can see that she has considerable sagging, creating jowls over here, as well as she has a lot of volume loss in the mid-face as well as the lower face, leading to a lot of ptosis of the tissue of her face. And that is why, because of mid-face volume loss, there's a lot of ptosis, leading to also a lot of, she's 61, so she's bound to have volume loss even around the perioral area. So volume loss I have graded as 3, and her sagging I've graded as 2, because apart from the lower face, she's luckily blessed with great cheekbones, which has helped to save her mid-face, and her upper 1/3 is actually really well preserved for a 61-year-old, except for some areas which we'll discuss soon. So this is her score: 3 for volume loss, 2 for sagging. Her face has also acquired the inverted triangle, which happens as we age. As we all know, the divinity or triangle of youth is this triangle, but hers has now begun to get into the inverted triangle. So face shape from oval is getting more oval square. Moderate to severe volume loss and sagging, these are the two criteria in facial shape that we assess. She also has prominent jowls and perioral loss, as I just described. The perioral loss is very important to assess in anybody above the age of 50 and 55 because the skin is getting thinner. The dental structure could be going through mechanical wear and tear. And also, you get some amount of bony loss in the 60s, which can then begin to create a lot of change with all these factors in the perioral area. And therefore, the lips will also change. But the whole idea in someone who's more mature is to assess perioral area with the lips and not just the lips. That's when problems start happening. Now let's go to the third criteria, that is facial proportion and contour. So over here, these are the thirds of the face. And you can see that, you can see that her thirds are reasonably proportionate, except that her lower one third looks a bit longer. So the lower third is longer. She definitely in the upper one third has hollowness of the eyelids. So actually, if you look at it, let's go upper one third right from the top. Nice shape of the forehead, still has a nice frontal prominence. Her brows are symmetrical. However, she is definitely dropping in the brow, lateral brow area. She's got hollow temples. And then if you come to her tear trough, she's got a very prominent loss of volume as well as hollowing in the lower eyelid area. I don't know, this laptop is very touch sensitive. So we talked about hollow temples. And then we come to, something's happening, sorry. This laptop is just tripping a bit. Yeah. I think if I just touch the lectern, it moves. If you look at her profile, you'll see that she has a sunken mid-face. Her nose is looking more prominent. Remember, as you age, your nose can look more prominent because of the volume loss of the mid-face. The nose can start looking more prominent because there's less of supporting tissue for the contours. And this is the rickets line, which you can see from the tip of the nose to the chin. You can see that the lips definitely need more projection and volume, and you can distinctly see perioral aging over here. Distinctly see this. So if you go to her three-quarter view, you will see that she has a saggy OG curve as well. And also what's very important is you'll see that the hills and the mounds and the valleys on her face, she doesn't have a regular outline out here. As you can see clearly out here, you can see that the OG has descended, it's not so prominent. You can see this little bump out here, that's actually the prominent nasolabial fat now, because the mid-face fat is shrinking. And you can also see that a nasolabial fold is prominent. So the first question when I asked is, what bothers you the most? The nasolabial fold. Exactly what Dr. Nitin Sethi and Dr. Maya were saying. Patients come with that, but they don't know that the music is elsewhere. And this is the consequence of noise. Music, when it becomes noise, creates a problem. So you must have a smooth mound to have a more youthful look. So in the scale, you can see that we have given her for imbalance in proportion, scale of 2. And for asymmetry, we have given her a scale of 2 because you can clearly see that she has facial asymmetry. So in her facial asymmetry, her right side, and you can see her left side, both of them are distinctly different. And you can see that she has loss of volume, contour. She has mortosis on this side as compared to this side. She also has a slight problem here, which on discussion turned out that there was some filler used there. And that's probably the Tyndall over there, which is, the filler is not sitting well out there. So we're going to try and correct that as well. So in facial asymmetry, we have given her 2 in the imbalance of proportion, and her left cheekbone is higher than her right. This is higher than this. She also has lip asymmetry. Naturally, if you have asymmetry of the midface, you're going to have lip asymmetry. And so we've given her a 2 for asymmetry as well. Now let's look at the presence of both static and dynamic lines. You can see them all over there, especially when you see her in person. So she has got a 2 over there as well. Dynamic and static both have got 2. So this is her final assessment scale. And you can see that she has a circle that's in the middle of the whole ring, which means that she's got moderate to more severe changes. Her circle is not smooth, okay? And so therefore she needs quite a bit of work done. This already begins to tell you what you need to do. So you'll sit down with her after you've assessed her, discuss all this with her, and then you have to start planning. You give your grading over here in this chart, and this formalizes and begins to help you plan her out as to what products you're going to use over here for her. And with this, what happens, very often the patient has come to you for a consult, but does the procedure a month, 2, 3, even 6 months later for various reasons best known to them or socially or otherwise. So when they come back to you, this is very easy to pull out and say, this is how you were then. Let's reassess you again. Or if they come even in 15 days after the first consultation, it's all ready for you to see, assess, discuss once more, and probably reiterate. Sometimes budgets change. So you can also help to prioritize what you will correct first and next. And that will be a very satisfying journey for both the physician and the patient. Yeah. So now let's go for the last part, which is in the tear trough. Yeah. In the tear trough, we would like to use 1 cc, half on each side, and the product will be Restylane Classic. Wall line, Restylane wall line, we will use in the temples, okay, as you can see over here. And we will use half cc on either side. When you see her, you'll see she's got very thin skin and fine bones. So good bone structure, fine bones. So I think half cc either side would be safe. So your tear trough is there and your temples are there. Now let's go to zygomat midface. In the mid, so the upper 1/3 done. Now let's come to the midface. We would do the zygomatic arch with 1 cc of lift, where we'll inject on the zygomatic arch, body and the canine fossa. And then we come to define. We would use 1 cc of define, 0.5 to 1 ml on each side. So minimum of 1 cc, maybe 2. And that's where we would use define, as you can see, in the more medial area. So define is light blue in the medial areas. Lift is for structure on the bone. And in the lower 1/3, we would use 1 cc of lift. That's the firm, the high G prime gel, 0.5 ml on each side for the jowl, pre-jowl area, to correct the jowl. And we would use define in the NLF, mouth corners, submental and mandibular area, and perioral area. We would use define, and that will help. We probably need 1.5 cc's on each side, therefore 3 defines for the entire face. With this, I will now be moving to the live demo area, and I will leave you with some magical moments that I have experienced in the last 4 days, because I'd taken a vacation in the mountains, and the mountains taught me something that I would like to share with you. And COVID taught me one more thing, that scrubs and sneakers are trending. And this is why I'm in my sneakers today as I go to do my live demo, and which may explain why I'm wearing them. But let me share with you what the mountains taught me and what we all need to know: how to layer, how to progress, how to make it artistic, and what an aesthetic journey can be for all of us as physicians and for our patients. So I leave you with this as I move down.
Thank you, ma'am. It was a wonderful session. Now, next will be the hands-on session on basics of fillers. Yes. Thank you, ma'am. You wonderfully covered it. So we'll be looking forward for the hands-on session. Thank you.
Thank you, Dr. Malvika, ma'am, for the excellent analysis. So we would now move on to the hands-on filler session. I'll also like to take this opportunity to thank all the speakers and the chairpersons of this session. we would probably want them to collect their certificate of appreciation and the memento on the dais, which is in the garden area. Now, those who are registered for the filler session, the basic filler session, the registered delegates, we request them to move on to the workstations, which is just on the other side of the wall. And those who have not registered can still view it through a live screening, which will happen on the screen. Thank you, one and all. For the demonstration, we would like all the delegates to probably be seated and view it in the conference hall itself. We'll make another announcement for the hands-on session. So request all the delegates to be seated just to have a look at the live demo. And then we want to request them to join in for the hands-on session.
But you could see the color changes? As long as you could see it. Okay, you don't worry about that. Let's start. Have they started the streaming? Okay, how much time do we have? Okay, 1 minute. I'm just going to remove one mask. Huh? Why me? I've seen my hands, man.
Yeah, please start. It's already live. Yes, thank you.
Okay. Hmm? Start this thing. Hello, can you hear me? Just go and check. ये चालू है? Oh, yeah, I could hear myself. Okay. Can you hear me? No? आ गई? हेलो, अभी ठीक है? Hello. So, my friends, I'm going to start now the live injections. We are doing one side of the face today. I will finish the other side. The reason I've chosen this side is because I always believe that take the best side, make it better, and then match the worst side. Because if you start working on this side, it will become very difficult to balance it because you have to identify which is the better side. The reason this is the better side is she has definitely more volume here. She has more volume loss over here, as you can see. But she also has that problem with the extra filler, which is not sitting well. And ideally, if she had come to my clinic today, I would first have dissolved the filler out here, which I can firmly feel as a cushion. I would have used Hylace and called her back. She was in a hurry, in not earlier than 24 hours. Others, I'd call her back in a week and then start working on her face because now I'm going to have to mask this area. But sometimes these are challenges in our practice where the patient doesn't have time. So then we have to mask this area. That's why I'm starting with this side first, and then I'll proceed to do this side. Now, if you look at her, the tissue quality is actually lovely. She's got beautiful radiant skin, but you can see deep volume loss, deep volume loss. And here I have quickly marked the vascular anatomy, the facial artery coming out of the facial notch, bifurcating at the modulus 1 centimeter away from the angle of the mouth, inferior superior labial artery coming up as the angular artery, becoming the transverse nasal artery, and then joining the dorsal nasal artery, which also has an internal communication. That's why you have to be very careful out here. Trochlear and supraorbital. And here is the arteries over here. And here is the superficial temporal artery coming out of a preauricular position, coursing all along the hairline, feel for pulsations over here. And this is the temporal fossa, which I'm going to be injecting first as I'm starting with the upper 1/3, coming to the middle 1/3, and then injecting her lower 1/3. I'll be using a mixture of both needle and cannula. And as I inject, I'll tell you why I prefer the needle and cannula in the areas and which product I'm going to choose. When we start with the temples, this is the frontotemporal fusion line, and this is her zygomatico temporal fusion line. So this is the whole temporal fossa. And then when you draw perpendiculars, this over here, this is the point which comes 1 centimeter above and lateral to the temporal fusion line here and here. So this is where I palpating to see if I can feel the superficial temporal artery. And the layers here are 7 in the temporal fossa: skin, subcute, superficial temporal fascia, over which the superficial temporal artery is running. Then comes muscle, and below that deep temporal fascia, where the deep temporal artery is running through the muscle. That's why you inject below the deep temporal fascia on the bone. So your next layer is 6 layers aponeurotic, and the last layer is bone. So that's how you get 7 layers. Now here I am. The patient has been counseled, prepared, spoken to, peers, allied, and so I'm not going to go through all that. I'm going to inject the temple. She's very keen on doing the temples. So first I'm palpating for the superficial temporal artery. The product I'm using is ball lime, primed and preloaded with a 27 number needle. So this is where I can feel the pulsations of the superficial temporal artery. This is where I'm going to inject. One centimeter above and there. I'm going to now do the gunshot technique where I'm going to touch the bone. The technique I'm going to use, I'm going to now inject, okay? 1 centimeter. Checking for any vessels. I don't see any vessels out here. I'm going in perpendicular. I must touch bone. Is it hurting? Yeah. I just touch bone. Patient may wince at times. This is one area we will always aspirate for 15 seconds to ensure that you're in a safe area, you're not touching any vessel. So I'm counting to 15. I agree, aspiration very important here. And then I'm going to proceed with slowly injecting them. I'm starting. Do you feel something going down? Is it very painful? Okay, you can see slowly the temporal fossa is beginning to collapse. Don't press on the bone. Take the pressure off the bone. Okay. Just check from that side. On the chocolate. Light is very sharp. Can you make a 0.5? Good morning. Up to there, right? Yeah. And here we go. Okay. So friends, this is not a procedure that a beginner will do. This is a more advanced technique. I'm coming out, giving pressure over here. Sometimes it may bleed, but it shouldn't. Sometimes if you touch a superficial vessel, it may bleed, but otherwise there should be no bleeding at all. Here we go. The reason we did the temple was to give a lateral brow a lift. And as you're older, your skin is more lax and crepey here. You can see now that she's got a lovely lift of the lateral brow almost instantly as compared to this side. And the way that skin is moving over the eye, the brow, the upper brow is beautiful. Now we move to the next area. So temple done. Okay, I usually tend to give more compression out here for a couple of more minutes, but due to lack of time, I will do that later. Should we go to the next one? Yeah, you're doing good. So I'm now coming to the mid face and doing all the points for structure and for lifting. So I'm using the product Restylane Lift, and I feel for the zygomatic suture line. This is the inferior border of the zygoma, superior border of the zygoma. I'm going to pinch it up, go vertically down with a 29 number needle, usually is loaded. I'm touching the bone very gently, giving that first shot, and I plan to put, when she's older, plan to put 0.2 out here. And if your hand is light, you don't jab on the bone, the patient barely feels any discomfort. Here I'm out, and I like to give pressure. The reason I'm doing it in this area, the zygomatic line, is because you also have to give support to the ligament and repose the tissue backwards, which helps as when you're older, because it helps in bringing a posterior positioning of the tissue, because as you grow older, with lateral loss of volume, facial tissue moves anteriorly and gives a heaviness here and too much of flattening there. Okay, can you just give a bit of pressure out here to the temple? So you can see no bruising and a nice movement of yeah. You can see now that, if you see how this whole area has now begun to move backwards. I wouldn't do her zygomatic, the body of a zygoma and the eminence, because she has a very good eminence already. And now by doing the temple, she's got a nice transition line. I will now progress to giving her support in the canine fossa on the bone, as well. The technique that I like to do is to, and I put 0.2 cc here, I'm going to put 0.2 cc here, is I go from the opposite angle of the mouth and I go in this direction away from the angular artery which is there and go on the bone. It's going to hurt you a bit. I'm already touching the bone and I just place product over here. I don't like to put more than 0.2, but I don't want to cause any vascular obstruction. You can either occlude the artery by injecting in it or occlude too much around it. And then you can get even a delayed vascular episode. Needs a bit of massage here, but it will immediately give support to not only the nasolabial fold, because it's lifting it, but also the nasojugal line along with the nasolabial fold. Both improve. And so she's got a nice support now out here. Already in just 3 jabs, you can see that she's a lot better. I've used 0.2 and yeah, totally I've used 0.5. I actually put 0.2 here and 0.3 here and 0.5 cc of ball lime here. Now we'll move to the next, and that is we're going to use the cannula. The 27 do you have a 24 number needle? Won't go otherwise. So now we move to the next zone, and that is I'm going to give it a resting lift. I'm going to give a support now to start working for the lower face. So I'm going to finish my job out here by giving, you can see that she's got a nice chin. Her jawline is good, but she's got so much of volume loss out here that she needs structural support. Okay. So I'm going to use at just tracing from the angle of the mouth downwards, I'm looking for some vessels and I'm going to give a support on the mandible, on the bone. She's got a lot of blood vessels out here. On the bone, and I'm going to put 0.2 of Restylane lift on the bone to help give, if you scratch the bone, the patient feels the discomfort. Okay, so you can see and you can see that there is a bit of same volume loss extending there. So from this, I'm going to go in and I'm going to give her another 0.1 ml over there, gently withdrawing to help in giving continuity to the line. And you can see now that if you compare her with this side and this side, the indentation has vanished and her jowl already looks more supported. I'm going to finish the last part. So I like to do all the structure first and then do the contouring. So here is the angle I'm injecting on the body of the ramus, 0.2 cc's into the body of the ramus. And this helps to finish the last part. She already of my structural work for this side. And then I give it a little posterior massage, which helps to extend the jawline a little more posteriorly. And now you can see how we can help in few. Which is this? Yeah. Now let's look at coming back to this area. Now, in this area, the medial cheek and in the perioral area, I like to use the cannula. and gently pushing the cannula deep. Define is placed subdermal. Define is not placed superficial. It's always subdermal. So right up to here, you can see the tip of my cannula. When I keep it downwards, are you okay? Any pain? Okay, come back a bit. Better. So now she's better. And I'm beginning to inject. And its define is rather hard because it has a high G prime. So the injection is slow. I'm now giving it some. Are you okay? Now I'm coming backwards. After giving a bolus over there, there's a cover. Cover. I'm now beginning to come backwards. Doing a retrograde right now. I'm working to give a better in this region. This is the region of the infraorbital vessel. The infraorbital vessel, open your eye, lies 8 millimeters below the eyelid and along the line of the medial limbus, and then the whole complex of the intraorbital vessels and nerve then go medially, and it's deep. So if you're in the subcute, under the subcute, you're still safe. And this is how I'm injecting the fine. Now, we will do her, now by creating all the support, okay, we will now, you can see now that she has far more support. Her nasolabial is improved. Everything's looking a lot sharper. I have used, just see how much, 0.3. I've used 0.3 of define in this area. I need to give her some support there. Then it will be much easier to do her tear trap. Yeah, 1 second. I need that define. I'm just going up again here in this area. Do you have any pain here? She has no pain over here. Small amount. Put a little more support out here. A little more support out here. Now we shall do her tear trap. So we're keeping the delicacy of her face, but we're volumizing her very subtly. I don't want to give her, you can see that when she smiles. Can you smile, please? Yeah. The movement of the cheek when you smile is very important. Everybody today says, Doc, don't give me the apple in the cheek look. So now smile. The smile should be with the cheek going more laterally, not bunching up here, and open your eyes and smile. Now smile. Look at the camera. And now smile. Yeah. Can you see the eyes not getting chinky? The eye remains in its position. You can also see the eyes looking in better position after having done the temple, the nasolabial looking better. So now I'm going to inject with the cannula into her. I need the needle. Entry needle. This is Restylane Classic with a cannula. I always preferentially do the tear trap with a cannula. Now, tear trap is a little challenging. I may actually go from the same entry point because it's going to be very difficult to ride up from there. So I'm now using Restylane Classic, which is robust, not so hygroscopic, because the skin is thin. You don't want a very hygroscopic. Now you can see I'm traversing in the subcute, going all the way up to the tear trap out here. I'm very, very careful and gentle out here. I can see a blue little vessel, so I'm going to draw a bit, and then I'm already injecting the Restylane. Coming down, and then I'm going to go back to the second level there. And then I'm going to go up here. One very nice point I like to do in difficult cases like this, which is right on the bone with a needle. But she's got a huge blood vessel out there. So I'll avoid using the needle out there. I'm going to be slightly challenged traversing the cannula, but I've done it, and I'm on the bone. Stay on the bone, on the infraorbital rim. Do not cross the infraorbital rim. You can see I'm doing her tear trough now. Skin is really thin. She's a good candidate for define because of thin tissue coverage. There I go. You can see her tear trough is nicely improving. And then give me the needle. I'm going to take the needle. She's got vessels out here and inject a small amount around it with the needle. No, the injecting needle. One could also put a bit of Restylane Classic in this line, which would work very well. No, I want the needle of the Classic. Which is the needle of the Classic? No. The cannula. The injecting needle. Yeah. Now the Restylane range has this 29 number needle. It's thin walled with and the lumen inside is larger, which allows for very good flow of product. So I'm going to work in the lateral orbit area with the needle, putting small amounts. I'm watching for blood vessels. Small amounts here. Small amount here. I'm on the bone. Tiny amounts here. I'm going to be really careful out here. I often say a little prayer and injecting here when there's a blood vessel sitting right there. But it's worked. And you can see that her tear trough. So you can use a combination of techniques. Leave the spirit sword, please. And then we can give her some. These are all the periorbital points on the orbital rim to help give some support. You see here. So far, no bruise. Good lighting, very important. And don't be in a hurry. Take your time. Let's now do the perioral area. Okay, so just give me that needle again, the entry needle. I'm going to show you the periorbital area now, how we're going to do it. So there are going to be 2 points from where I'm working. Just hold on to this. You can see now, can you open your eyes? Yeah. Sit up. Can you see that now the periorbital area is looking much better, less of, yeah, the patient wants to see herself. Good? Okay, fine. Now, I usually take a line, with, a point of entry with a cannula between the 2/3 and 1/3. So here I go in, come out, inside the fold. Yeah. And now I'm going to work in the periorbital area with a 25 number cannula with define. Just giving a little support, and it will also help to project her lips a lot better. Define takes it's a slower injection because it's quite hard. And you can see she's got periorbital lines. Can you say ooh? Ooh, say ooh. She's got these barcode lines. So I'm going to go in along the lip border and inject her barcode lines as well. And here is how we do the periorbital area. And then go up to the angle of the mouth. And this is how we can give a nice coating to the periorbital area. You can see already her lip border looks a lot better. Give me the needle again. And now I'm going to do the lower face, which is, we're going to do an entry point over here. Again, say ooh. So you can see this is the DAO. Just here, inside of this perpendicular line from the angle of the mouth down. I just go in there, watching a vessel if there is any. And then from here, oops. Give me a cause. She's got a small vessel there. A little deeper, which is sprouting. Now, yeah, I got the cannula in. Get more gauze, please. And this is now how I'm going to rejuvenate the submenton. And now we're also doing the region of, turn this way, region of the DLI, and also go downwards. Just a little bit. And now we'll go upwards to do her marionette lines. So we're going to correct the volume loss. Say ah, relaxing. It's going to hurt you a bit here. Now I'm going to ascend up and complete this area. And I've done this whole work with 0.8 cc for this area. And now I'm going to ascend up and put it in her nasal labial as well. And then with the cannula, I'll just pull out the syringes. How many we've used so far? One syringe of Define we have used so far, totally for both the mid face and the lower face. So we're staying with the plan that we had made with her during facial assessment. And but this line is very tricky. But what I do is I wing my cannula down and I go into this line. Skin is very thin out here. And then I fill it up. Okay. One more. All right. Now we need, you have that wall line left, right? She needs volume here. Sorry? Needle cannula. I've got the cannula. Will you just take another one? And now we've got just the lateral area to do. I want to do this area. She's got a lot of blood vessels everywhere. So I'd like to avoid another insertion point. And this is the beauty of the cannula. You can fan it. So we're done with the CC of Define. Something to clean her face, get the Cetaphil. Let's start cleaning her face up. So now let's see what's left to do. Yeah. Can you sit up? Put on gauze and leave it in. Let's see how much time is left. Okay, so I'm just cleansing off all the markings. Just cleansing her face now so we can see the difference in her face. Now remember, product always expands with time. So as the product expands and stump tissue edema develops, the patient looks almost 50% more. But over a week to 15 days, it comes down and the patient will always have an improvement of at least 25 to 30%. But initially, there is some edema. And also product expansion and integration has to happen, which happens over 3 to 7 days. So you can see that there's really no bruising. Now let's look at her. Sit down. Okay. So you can see clearly that with the temple injection, this has gone up. You can see that her infraorbital rim is much better. She has, I'll have to give her a bit of a massage, but you can see that her coloring has improved and the color of her skin is looking brighter, not so crepey. So the texture is improved. She's got a very, very big blood vessel out here. I may have to go in and do some refinement over there. Light massaging will help. And you can see that she's got a good lift over here of the mid face, good contouring of the mid face over here. The mound has come back and it's continuous now. And we have to put some define over here for a little more continuity, which I plan to do. And then her nasolabial is not looking so deep. The perioral has distinctly improved. And the upper lip is looking a lot better. However, I still need to work on the lower lip line and maybe some more in the pre-jowl sulcus area with my cannula. More work here, more work here. My choice of product here would be defined. Here I could also use ball line because she's much older. And I would definitely work with the angle of the mouth. And remember, in older people, keep it neutral. Never give it a tilt or lift. The max you will do is this much to give a neutral position of the lip. And you will see even without any work, you will be in the lip, you will give her a very good projection of the lip and improve her rickets line. So you now have to work to improving the lower lip and get it a little more projected this way. And we'll be able to give her a very nice profile. So let's quickly look at her on profile. We still have some work left to do there. And frontal and three-quarter. Okay, so in the three-quarter, can you see the improvement in the OG curve? Are we done? Is time up? Conclude. So with this, you can see, friends, with this work that we've done today, you can see that by prioritizing areas with the correct product, with giving her a personalized program, and also with a nice placement of product using needle, cannula, the versatility of the product, versatility of the technique that the product allows, and by giving a better contour, facial proportions, symmetry, and symmetry will come later when we do the other side, but giving her more harmony in her own facial structure and keeping her own natural features and restoring more youthfulness to her face is what we're going to finally achieve once we finish the other side as well. And I just have to finish a little work over here. And we'd be happy to show the photographs maybe tomorrow in the filler workshop. We can show you the final result of all the work that we've done. So far, we have used how much? One ball line. Okay, so one ball line, one lift, one define, and half of the wrestling classic. So eventually, we'll be done with 8 syringes, 4 on each side. Thank you very much.
Thank you so much, ma'am, for the
listening
wonderful
and for all
demo.
the,
So we
the time
quickly move
given to
on to the next session now. That's the filler hands-on. I request the registered candidates to move to their workstations just on the other side of the wall. For those who have not registered, we'll have a live stream going on the screen in a couple of moments.
Mask is big. And also, you should be in a comfortable position to inject. When you're injecting any, whether it's Botox or filler, don't inject like this. Don't keep the elbows stiff. You have to have dexterity with your fingers and your wrist. It's a finger wrist coordination. Okay? Okay.
Send the delegates, yeah. Yes.
For her?
Yes.
Yeah. 2 left and 2 defined is that's it? Yeah. 2 left, 2 defined.
Please finish in 15 minutes. We are very much behind time.
15, okay.
50, 50.
Oh, 50.
15.
Yeah, 50 is fine. How many delegates are there?
Around 10.
10, 30. Then how many minutes each one gets?
No, ma'am. Everyone will be there. For 20 minutes, you explain them everything.
And then?
Okay. And then
30 minutes?
0.3 ml kind of a thing.
But time each one takes?
You just mark the injection point. They just inject and get the feel
That
of
is
the
all.
product.
That's all. Okay.
Okay.
Okay. Yeah, give me. Give me. Do you have a pencil? Not this. Marking pencil.
There's a marking pencil on the table.
Where is the marking pencil?
Thank you. हाँ वाई पे टेम्पल मत करना कम से
Just won't go back a little. Huh? Just go back a little.
Lotus?
Is everybody in? Just can you just make her lie down a little? There's no audio. Mm. Hello? Can you hear me?
Please check.
No. Can you hear me?
Yes.
इसमें से बीच में लगे मैम बीच में
I don't know. Beach means what? It's not going down, huh? Okay. Can you hear me?
Hi, Malvika.
Can you hear me?
Yeah, Dr. Maya, this is Anurag from the
no,
audience.
you
We can hear you. We can hear you loud and clear.
Can they hear me? Can you hear me?
Yes, we can hear you.
You can hear me. Okay. Is everybody in? I think can you just is everybody in?
Okay, everyone please come inside. Yeah.
Is everybody in? Okay. You want me to ask questions or just go? What constitutes a mid-face?
Mid
Okay, I think she.
from the propeller to the angle of the mouth.
No, wrong. From the nasofrontal angle to the subnasal. So it's nasofrontal angle to the subnasal. Okay, this is the mid-face. And what is included in the mid-face? The tear trough, the mid-face per se, and the nasolabial fold. Okay, this is what we have to address. But today, being the basic course, we are just doing the mid-face lift and the nasal. Okay, you need to know the anatomy and the landmark first. Okay, the first thing that you need to know about the mid-face is the zygomatic arch. Okay, so you mark the zygomatic arch like this, and then you mark the lid cheek junction, because these are the no-go zones. And you see the patient in all angles. You look at her straight, then ask her to make her bend forward, because sometimes you might have excess fat here, and then that will be a no-go zone. And then ask her to bend back. If she bends back, this gets better. So definitely she's going to improve. And then another assessment for, remember the demonic grandpas. G is for gender, R is for race, A is for age, M is medical history to find out if she has any problems. P is if there's any history of previous injections on that area. A is allergies, and C the shape of the face. Okay, so you just make a note, talk to the patient, ask her what her, all these things come in the history. After that, examination, straight, front and back. Okay, and you have to, the thing is a lip cheek junction because you don't want to get into the orbit. These are the important things. And then if you want to know if the nasolabial fold is helping, there's something called a stretch test. You just measure the distance, you just mark the edges of the nasolabial fold, and then when you stretch, it should not be more than 50% of her original. Okay, because if there is excess, that means she's got more skin laxity and she's not going to, because you have to promise the results. You have to tell her how much improvement you can give her.
Ma'am,
So
can
these
you
are some of
repeat
the,
this?
it's called a stretch test. You just mark the edges of the nasolabial fold, measure the distance, and then when you stretch, again see how much it is stretching. If it's more than 50% of the original, it's not going to do well. If it's less than that, she's a good candidate. Okay, so you have to mark the zygomatic bone, and I think you all saw the artery, right? Just clench your teeth, mark the masseter, or otherwise 3 to 3.5. You'll feel the notch. All of you, as I'm explaining, see for yourself. Okay, you'll feel the notch. Okay, relax. Okay, and this will be the entry of your facial artery. Or if you want by centimeters, it's about 3 to 3.5 centimeters. You can also measure. And then it goes, it has a tortuous course. And then from here, it's again 1.5 to 1.6 centimeters. This is a danger zone, no-go zone. And then it gives off columella branches. I think all that she said. Another important area is 1.2 centimeters from here to here is the nasolabial artery. So these are the areas where you have to avoid. Then it goes up as the angular artery. Okay, why is it tortuous here?
No, because to allow the movements, otherwise it will rupture the stress.
Be careful. We have such an informed person here. Okay, good. So these are the danger zones. And then you have to also mark the infraorbital foramen. In your, all of you can actually feel the infraorbital foramen here. Hmm? In fat individuals, it will even be difficult. You basically have to take a red pencil and mark it here so that, and it's usually about 8 to 11 millimeters from on the medial limbal line from the orbital rim. So mark that. Okay. So so when you're injecting, make sure that you don't go medial to it. And also there is a line, a safety line, which is from here to here. Okay, try not to inject too much, because if you inject too much when you're doing the infraorbital thing, you can actually go into the angular vein, or you produce engorgement of the angular vein. Okay, and then here you have to, I'm sorry, you want to come this side? Come this side. And also make sure that the facial artery is somewhere here. So you have to be careful in these areas. And if you want to know, today I'm going to teach you. We'll do the CK codes. That's a cheek code. CK means cheek. And for the cheek codes, and there is something called a ligament line. That is a temporal fusion line, the orbital thickening, the zygomatic, the masseteric, and the mandibular. Okay, anything outside the line will produce lifting. Anything medial to the line will produce volumization. So if you want to do a lift, make sure you're not injecting here. If you want to do a lift, it should be only outside. Basically, you're stretching these ligaments. Okay,
What
these
is
are
the surface marking of this line?
it's called line of ligament.
Surface marking?
Surface marking is just the lateral orbital rim, just straight down. Okay, these are the major things you have to do. So here we are going to mark CK1, CK2, and CK3. CK1 is 3 points. You just feel for the suture. Okay, zygomatic or temporal suture line. And then the center point is here. The medial point is 0.5 millimeter, 0.5 centimeters medial to it, and another line 0.5 centimeters lateral to it. This is CK1, 3 points. CK2 is actually the most eminent part of the zygomatic prominence. One, you go from behind and see that, or a rough calculation is you see the lateral canthus and the tail of the eyebrow, you just drop a line and you draw a line along the orbital rim. Okay, the point where it meets here will be the CK2. And then you have to mark CK3, and CK3 is just 1 finger breadth outside the infraorbital foramen. Okay, that will be CK3, or it's a you've heard of Hindra's lines. Yeah, so it's just around that line. That will be CK3, and then CK4 is just below CK1. But again, if you want to define that, it just bite. You just mark the borders of the masseter. Then you have your lower portion of the zygoma. 3 centimeters from here will be the CK4 point, and then you divide it into 4 quadrants. As I told you, it is the lateral part that has to be lifted. It is the auricular fascia, which is about 3 centimeters from the tragus. So you have to inject into this area to produce a lift. And CK5 is just below CK2. So it's very easy. And these are all subcutaneous injections, whereas these are all on the bone. Okay, so we'll just clean her up. And always when you inject, you have to pull up the points and inject because you want to tighten the zygomatico-cutaneous ligament. And always touch the bone. For all these points, you have to touch the bone. And then when you're injecting the CK3, you have to place 1 finger on the infraorbital foramen, 1 finger breadth, just to make sure that you're in the right plane. And the 3rd finger will lift up the ligament. Okay. And then you go on the bone and inject. Okay. And make sure that there is no malar mound. If there is a malar mound, again, that will be a no-go zone. You should not inject into the malar mound because it will produce more lymphatic obstruction and worsen the mound. You should always inject under the mound. Okay, these are, and nasolabial fold, there are 3 parts to it. One is NL1, NL2, NL3. NL1 will be on the periosteum deep injection. It should be 1.2 centimeters away from, that is the ala. And you have to place your needle in this direction, pointing towards the opposite corner of the mouth. And you have to touch the bone. Okay. And here, these are all subdermal injections. Using a linear threading technique, you can use your needle. So here ends our surface markings. Any questions, any doubts? Always remember the surface markings, you'll never go wrong. We have 300 units of hyaluronidase here right away. Maybe a little higher. It should be almost in front of the tragus. This is a little over. Aseptic measures are very important. You have to ask them to wash the face with the chlorhexidine at least 3 times, and then clean with the betadine 3 times. And every time you inject, make sure you wipe that area with the alcohol swab, and don't touch that area.
Before the procedure. Cleaning.
Little more, little more. You don't have chlorhexidine this thing to betadine. Can be used on the face, right? You can Cetaphil cleansing lotion is there, only moisturizing there. Huh? So sometimes you can even use okay, clean again then. So I'll just mark the area so that you can start injecting. And always make sure that you mark in the upper half of this. The reason is when you lift up, it's always good to inject a little anteriorly and inferiorly, and not too much, because there is a transverse facial artery which goes about 1 centimeter below the zygomatic bone. Again, anatomy is very variable, so you don't want to take chances and inject here. So, so this will be the 0.5 centimeters, 0.5 centimeters. So we'll start hands on. How many pricks does one get? One. So we'll first finish this. I'm sorry. Can you come this side? I'm already, my throat is dry. Come closer. And any doubts, please ask me to repeat. I'm ready to repeat.
Ma'am, can you please
No, we're
explain
all-
CK points?
CK1 is the middle point is the suture line. Okay, and 1.5 millimeters in front and 1.5 millimeters behind in the direction of the zygomatic arch. The zygomatic arch comes like this, right? And then when you're injecting, it's always good to inject you should never inject into the marking area, because it will produce, look at that. So, and always try to inject, pull up the ligaments, because you're trying to tighten the zygomatico-cutaneous ligament, pull up the ligament, and then inject anteriorly and inferiorly on the bone. CK2 is the most prominent part of the zygomatic eminence. You can go from behind and mark that, or if you want surface marking between the lateral canthus and the tail of the eyebrow, it's just the midpoint. Or if you want measurements, it's about 1.5 centimeters outside the canthus and 2 centimeters below. It is not RD point. Okay, that'll be the CK2. CK3 is the infraorbital foramen, 1 finger breadth away will be the CK3. Okay, CK4 and CK5 is very easy. Just below CK1 is CK4. That's a rough arbitrary thing for you to remember. And below CK3 is CK5. But if you want, again, dimensions, you have to ask the patient to bite. Mark the anterior and posterior borders of the masseter. And 3 centimeters from beneath, you make another marking. Make that into 4 quadrants. It's good to inject into the posterior quadrants. But if you have product, you can also inject anteriorly. The reason posterior markings is because the auricular fascia, which is outside the parotid, extends up to 3 centimeters from the tragus. So these are your anchoring points. Okay, so make sure, see, actually when you pull these things, you can see the changes. Can you see, when you see the lid cheek junction, you can see it improving. Can you see? The best thing is to keep your fingers wherever you're planning to inject and then see the difference. Your nasolabial fold becomes much better. You will need less product. So there is something called an algorithm. How you inject. Actually, after the teardrop, you should inject the temporal fossa. And then you come to these things, because temporal fossa itself will produce elevation. Can you see that? But since we are not doing that, so read up everything. So whatever I'm saying is there. You just have to look up. So there's something called an algorithm which you should follow. Right. So let's start. Okay, right. Who's gloved up first? Let me also have a glove so that 7 is not my size, ma. Oh, very bad, no? So see, if you'll want to practice, even with that cap, I need aspiration for every bit of thing. You have to hold. If you can aspirate with one hand, it's fine. Otherwise, you fix the needle and then use both your fingers to aspirate. Aspiration should be at least for 10 counts. Sometimes we say, I mean, what happens, you see, when they're injecting, you see that trembling and all that, just hold your breath. If you hold your breath, you will not have tremors. And you inject very slowly, okay, steadily, because that's the reason we are saying low pressure, low volume. These are your safety points. Remember, you have to repeat this in your mind every time you do. Say low, slow, low, slow. Otherwise you will forget, and in a hurry, the patient will wince or the patient will scream. So you'll try to push in the product, and that's when all the problem comes. You have to be steady. Okay, come, let's start. You guys won't have lunch. Somebody needs a 7. Come, all of you wear your gloves. And then bevel up, bevel below, does not matter in the CK points. The only thing is you have to stop the injection before you withdraw your needle. All of you be aware, she's a doctor herself and she knows more about fillers and injections, right? Huh? So they have to be extra careful with you, like a googly patient. No, very sweet. No. Very sweet. And she knows I'm here to. Yes. No? Dr. Venkat sent you to see me? Yeah. You didn't come.
I called.
You called.
The response. But
Anyway, you're here
next
today.
time.
Yeah, sure. Alcohol swab. Somebody has to give an alcohol swab. Yeah. Who's starting first? Come. Take the syringe. Where's the syringe? Syringe. Somebody open it for her, no? Somebody who's not gloved up, please open. Lift. Lift first. So be thorough with your anatomy. That is very important. All the surface markings, the no-go zones, these are all no-go zones, like the infraorbital foramen, like 1.2 centimeters from here, 1.5 centimeters from here, and 3.5 centimeters from here. And then some people have a high arched zygomatic bone. Some people have more volume here. So you can change your. You have to open it like this. Yeah. Okay? No twisting, no turning. And please don't touch, keep it like this, because in case there is product left, this has to be sterile.
Yes, it has to be capped.
Okay? And again, rotate this. And what you do is, can you see the spiral thing here? You have to make sure that it's tight. Okay? And then pull it out. Okay? And make sure you prime. And this has to be stuck onto the patient's case record.
Yes.
In case there's any problem, you have to report. Yes. So one is you prime. Again, there are some situations where we don't prime. I'll let you know. Okay, only when you prime, you'll know the thickness. And please see the markings. So when you're injecting, make sure the markings are visible. Otherwise, don't put the syringe and then rotate for you to see the thing. Okay, it does not matter whether the bevel is up or down. Don't concentrate on that. Concentrate only on the marking and hold like this. If you want to, where is this cap here, the blue one?
What is prime?
Priming means when you put in the needle, is the needle hollow or does it contain the product? If you want to know how to aspirate, you can, if not sterilize the place, no, you just practice like this. Okay, and then you lift. Can you see the bubble? So this is one hand aspiration. Okay, if you don't know how to do that, you steady the needle like this and then aspirate. This is two hand. Okay, because I don't think you're like well versed with that. So try two hand, no harm. But make sure that the needle is in contact with the bone. So now she's going to clean every time. Don't clean off the markings. They need the markings. No. No, don't clean the markings.
They're light ones.
So if you want to do with the plastic, you have to do that before cleaning. Priming, you want to know what it is. When you put the needle on, when you cap the needle, this portion is hollow. Okay? So what happens is when you inject first, what comes out? Air. So there will be a false sense of volumization or lift, which you don't want. Okay? So this is called priming. You have to see it at the thing. And what you do is don't wipe it. I've seen so many people on the stage using a gauze and wiping. You just tap it. That is all. These things are very important. I'm telling you, even people are using, and at no point in time are you touching the needle. Never, never. Even if it's bleeding, you pull out the needle and then give pressure. Don't give pressure when the needle is there.
Ma'am, how much are you depositing at each place?
Good. That's a good point.
Yes.
1.1.
0.1. Everyone is going to do.
Are you familiar with the 0.1? Just one marking.
See, this is there.
One marking.
One. So one horizontal line is 0.1.
Just one horizontal line.
This is. But you 0.2.
No, but what goes is only this, no? 0.2 is not. No. That's right. From here to here.
Oh.
Okay? Right. Somebody hold her face in case, because I don't know whether she's comfortable. So, lift the skin like this. Okay? Pinch the skin with the lift.
Then take the center.
Use the center. You always, it's good to do the center because you know one front, one back. The way you mark. You understand?
Right.
And it should be straight. It's a bolus. It's, yes, bone. How do you hold the syringe? Right. Hold it tight. Yes. Just anteriorly and inferiorly to the marking. Go perpendicular. Straight. Go straight till you have to hit the bone. Have you touched the bone? Wait.
Right. Yes.
Right, no? Okay, now aspirate. How are you going to aspirate? Can you aspirate like that? If you cannot hold, do both hands.
Two hand
aspirate. See, what have you done?
Wait.
No, see the mistake. You've gone somewhere else. Can you see the puckering? Okay. You cannot do with one hand, right? There should be no hair. That is what? All that. Right. That's why I said I wanted a micro pour tape. I put a micro pour tape and taped it all around. At no point in time there should be in contact with hair. Okay, now you start to go all over again. Feel the bone? Did you feel the bone? Did you hold the zygomatic bone like this? See the lower and the. Okay, if you cannot pinch, no, just leave it. Just if you can't do that, don't force yourself to do something which you're not comfortable with. Huh? Okay, I think this way you're better off, right? Perfect. Yes. Perfect. Right. Steady. Okay.
0.1. Just see the points.
Right. Perfect. Good. See the marking? Are you seeing the marking? Oh. Slow and steady, right? Perfect. Now what you have to do is, yes, hold this and pull it out gently. Slowly and gently. Perfect. And immediately give pressure. The reason is you don't want the product to track back. Otherwise, it'll come to the edge of this opening, and then it'll have an opening, and that'll be a nidus for infection. Perfect. Good. Yeah. Next, you're coming. Okay. Who's coming? All of you stand in a line so that you know who's coming. You inject the one below.
Dr. Maya?
Yes.
You ready?
Yeah, sure, no problem. This was the center point, right? You're going to come anteriorly and inferiorly. Why did you move?
No, we can remark that. It's okay.
If you don't feel the bone, don't inject. It was the same line, no? You saw her line, right?
You need to do this, ma'am. I'm holding this.
Just here. You don't want to lift it? No. Right.
See the marking?
Came out. Yeah, okay. Slowly, steadily. Gently withdraw and give pressure. Right. Lift it up like this. Only then the ligament will be stretched. You can see the marking, right? Anteriorly and inferiorly. Wait. Where is a swab? Every time before injection, you should swab and then. That's the best cleansing agent. Good, no? Antiseptic, no? Right. Touch the bone, go deep. Are you touching the bone? Huh? Okay, now withdraw. Should count 10. Right, good. Right. Right. We finished that set because don't go too behind because there's a superficial temporal artery close to the hairline. So always anterior and inferior would be just in front. You just sit up, let's see. You can see the underline much better on the right side than the left. Can you see that? More bulging on the left.
Yes.
See, and even the nasolabial fold, can you see? The direction of this is like this. This is little elevated, right? Okay. This is with just 1 point. Now who's doing it? Right. Are you able to appreciate it? The nasolabial fold. Can you see it or no? If this has improved, the tear trough has improved. We have to clean. Yes. Yeah. Anterior and inferior to the midpoint. Not into the marking, away from the right. Perfect. Just anterior and inferior. Right. Must touch the bone. Okay. Aspirate. Your needle thing should not move. Hmm? Because if it moves, you're aspirated in one area and injecting in another area. See the marking? You're able to see the marking? Okay. Low volume, low pressure, steady. Low pressure also. Hmm? Because even if you're injecting inadvertently into some vessel which produces blindness, you're doing it low pressure, it will not track back. Yes. No, straight right now. Right. Aspirate. Right. You should see this portion, the visible portion. This is called negative aspiration. Pardon? Yes. Good. Yes, because of the product, because of lift product, high G prime product.
It's highly viscous.
Yes, highly viscous. And only a highly viscous product can give you the lift. The low G prime can only give you the contouring. It will not produce a lift.
Because it will spread.
Correct.
Since we marked the upper and the lower border of the zygomatic, can we just lift it rather than holding the zygomatic bone and give it?
You can, but this is just for safety.
Okay.
See, there your needles are moving. Did you all see that?
Yes, ma'am.
So at least we are holding it, no? You won't slip and go underneath. This is just for a beginner, for all the safety aspects. When you're holding it, even if it slips, this finger is going to. Otherwise, what will happen is you'll go and hit the facial, transverse facial artery here. You're doing okay. Yes. After you touch, what was the thing? Cleanse. After cleansing, don't touch it. Cleanse.
Cleanse I've already done.
No, then she touched it. See, at least make sure she doesn't get infection from our procedure. Even if she doesn't get the results, that's fine. Touching the bone. Right.
The patient feel that they're touching the bone.
You won't feel. Only thing you'll hear a crackling noise when they're. Now, after 2 pricks, definitely the needle gets a little blunt because you touched the bone. So let's change now.
And what is the gauge of the needle?
All your no, this is your wrestling lift filled with lidocaine. This one, it depends on the pricing. Yeah, okay, because they have both with and without. Without is cheaper, and I think 0.3%.
And what is the gauge of the needle?
Yeah. Just read the box is there behind. Again, you have to go prime. now we're going to do the lifting again. Okay. The next lifting point is the lateral aspects of the CK 4. Okay, now this will be subcutaneous. Who's not had a chance? You, ma'am, come. Okay, come. This will be subcutaneous. Okay. Okay. You know the arbitrary marking, no? I told you just below the CK1. Just below means not really. Not. I told you, it's about a line drawn from the lower zygomatic. Yeah. And the 100? Yes. Okay. Just, and it's 1 centimeter below the lower border of the zygomatic arch is a transverse facial nerve. So you should not inject 1 centimeter below. Okay. Below that. Below. It's here. You can inject one here. Now it's subcutaneous. If it's subcutaneous, the direction of your needle has to change, not perpendicular. It has to be at least about 45 degrees angle. And always, see, again the direction. What did I tell you? What structure is there? Then why do you want to direct your needle? You should always direct towards the safety zone. Which is a safety zone? This is a safety zone. So you'll be injecting here. Okay. So all these things are important. To this direction. Yes. At this point, right? Yes. Aspirate. See, actually, the face will become slimmer because of the lifting effect.
Like how much maximum that we can
See, these are what these things are called boluses. Maximum bolus you'll be injecting only in 3 areas. That is the temples. You can go up to 0.5. Some people even inject 1. The conian angle of the mandible, and then the chin. These are the only areas where you can inject boluses larger than 0.3 because there is no compression of the arteries or any structures. The rest of the areas, it has to be below 0.3. People use 17 and 20 syringes in one session. Only thing, whether the patient can afford it, that will definitely overscore than the amount that you can exceed. So you are safe. Now, who has to do it? Come. So you can do 1 below. Remember, I made that.
So this will also be subcutaneous.
Subcutaneous, yes. See, the anchor point here was the zygomatic cutaneous ligament that you were trying to elevate. Here, you want the anchoring to occur over the auricular fascia. So there is a reason why you are injecting. Okay, don't, since it's a subcutaneous injection, make sure it's not visible. Just massage it and spread it a little. Here you don't want to massage because it's a vertical periosteal and you want the towering lift. So you don't want to distort that there. Here it's okay. So you want it to act like a gum. It acts like an adhesive. So you can actually lift it up and hold it like this. You make a sit up and see. Can you see here there's no hollowness? And here it's almost flat. See the under eye teardrop, it's improved there. We have not done the CK3, but just letting you all know. Can you see the difference? Come. Somebody do that side. Who's not done? Come. You'll have the same order so that I'm not missing anybody.
Ma'am, for practice, can we just try this with saline? I mean,
Yes.
that would be.
But it'll be painful.
Okay.
Saline will be painful. Or a left-hander, is it? Come this way then. And when you want to do this, you can ask her. This will be much convenient. Hmm? 1 centimeter below that, anywhere, just in front of the tragus. It should be within 3 centimeters from this. It's too parallel, no? Just with the subcutaneous arm. 30, right, perfect. In your direction is not so safe because that's where the artery runs. Same side, this way. Parallel to the artery. Yes, perfect. We don't want to see all this happening. You should also wear a cap. All of you, see, because it's, would you like this? Always answer this question. Would you like this to happen to yourself? If you do that every time, the patient will not have any complication. No, that's the first thing. And then primum non nocere. First, do no harm. Understand? These two things will help you reach greater heights than a normal person does. One more to go, no? Three more. No, come. Stand in a queue. You want to? Oh, left-hander. Okay, right. There's a faint one there. Can you see? First, tell me which direction will you be injecting. One of you tell her. Parallel to the transverse facial artery. No. What you did was right. Right.
Ma'am, this what we're doing is CK.
This is CK4. CK3 I have not done because I want. We're behind time, huh? Time, huh? Oh. Then I'll tell you what. I'm going to miss CK3 because I don't think none of you all are confident to. It's a little risky area. I don't want to risk the patient. I will let you do nasolabial fold and then there will be 6.
Ma'am, can you do the CK3 so that we can at least see
sure.
how to do it?
How much chance are there that it
There's no chance. It's only there's 100%. You can only be safer, never safe. Because if you see the anatomy of vessels, It'll be like a cobweb, vessels everywhere. Understand? That's why we are saying take all these precautions. You have to wait, ask the patient wait for half an hour in your clinic. Sometimes they even come back later when the embolus forms and it gets into the vessels. No, you can also get it. You'll get a herpetiform eruption, which means that the vessels are compromised. So you have to highlight it. Can we have another one?
Left
Oh,
only.
sorry.
There is still one unit left.
Oh, I'm
in this.
sorry. But where will he inject 0.1? We need more, right? Take
Right.
another one. Take another one. Take lift, we can give it for them. You're familiar with injections? So you are still there? Who else is there? Two are there. No pain, no?
This way.
No, nothing. What I'll do, no? I'll give that one, this thing, let him inject in this other quadrant also.
Yeah, we
You
can.
inject here. Just in front of that, all the four quadrants will be injected.
Yeah.
Come. You are there, no? Come. Sorry if I'm missing you all because I don't know your names. Come. Fast. They finish that off. Boluses. Yes.
Planning you're not doing.
Yes. There's only 0.1 left.
Where are you injecting?
Yeah, let her finish. Huh?
No, I need to check that.
Yeah, take it, please. Take it.
Okay, we are taking a lunch break now. I would request all the delegates seated here to have a quick lunch. We will be starting the next session in the next 10 minutes. The workshop will go on for the hands-on registered candidates inside, but I would request you all to have a quick lunch and come back for the next session. I think Dr. Bennett is here. Okay. Dr. Vineet is here. Dr. Case Mehta.
Recording stopped.
inviting us here to chair this important session. And this is a session on lasers, and we have very eminent speakers here. All are key opinion makers in the field of lasers. And we'll begin with the first session. Dr. Swapanil Shah is a speaker. We'll be talking about evolution of treatment of acne scars from surgery to energy-based. Acha. Extended application of laser. Sorry. Dr. Swapanil will be talking about laser toning, carbon peels, and much more with Q-switch lasers. Over to you, Dr. Swapanil.
Good afternoon, everyone. I hope everyone has a good lunch. And I'll be talking on extended application of Q-switched Nd:YAG laser. So we know that Q-switched Nd:YAG is a workhorse for pigmentary lasers, especially the long pulse Nd:YAG is a workhorse in Indian skin. However, it's a difficult to maintain laser because we have very few indications which can be treated with it, like nevus of Ota or tattoos. Careful manipulation of the beam parameters may often produce very interesting and appropriate clinical results. Laser toning, soft peel, and carbon peel is introduced for the day-to-day clinical problems such as acne, wrinkles, PIH, melasma, and many more indications. Coming to the laser toning is a treatment method using 1064 nanometer wavelength. Excuse me. 1064 nanometer wavelength in a Q-switch mode with a pulse duration of 5 to 20 nanosecond without any external carbon lotion for melasma, pigmentation, and intractable scars. The basic principle of laser toning is low fluence and multiple pass technique. Rather than giving it in a single pass, you use multiple passes. The traditional treatment is based of any laser is based on principle of selective photothermolysis. The selective photothermolysis results in destruction and death of the pigment containing cell. In response to cell death, inflammation follows and results in repigmentation and recurrence of that condition. The high peak power, ultra short pulse duration, and a flat top beam of modern generation Q-switch Nd:YAG results in destruction of the only melanin in the target cell, but the living cell, cell being alive. And this is termed as subcellular selective photothermolysis as against selective photothermolysis. Since fluence used is very less and there is no cell death, inflammation and heating is kept to minimum, so it results in less chances of recurrence. So this is an ultrastructural photograph on zebra skin explaining what is laser toning. You have a melanocyte with a long dendrite process, and these yellow, brown, and red dots are basically the melanin in process to transfer to the keratinocytes. And just after laser toning, if you say the dendrites had been cut short, the melanocytes are at basic phase. The nucleus and cell membrane is, however, is in intact shape, and the melanin which is in the process of transfer has been cleared off. So this is the basis of laser toning, that you are not killing the cell, you are just destroying the melanin in the cells. And this is a 3D micrograph which has been labeled as dendrectomy. So the procedure is extremely simple. The fluence used is depending on the spot size, whether you are using 8 mm or 10 mm, between 1 to 1.2 joules, never exceed 1.5 joules in Indian skin, and 5 to 10 hertz with less than 50% overlap. Ideally, there should not be any endpoint, but a mild erythema or 2 to 3 process perpendicular to each other is the endpoint for toning. The advantages: it's convenient and easy to perform. It has a very short operating time. No bleeding, no casting, no scabbing, so no downtime, minimized PIH and recurrence, and can be used as a combination therapy in many of the indications. Coming to melasma, we know melasma is not the lasers are not the answer for melasma, but it can be used as a third line treatment where everything else fails, and patient should be explained about the chances of recurrence, and absolutely no results can be there with lasers. However, these are few patients who have been treated successfully with Q-switched Nd:YAG laser toning. With 10 sessions, you have a partial response to melasma. This lady improved a lot with 11 sessions with almost complete clearance of melasma. And this remission can be maintained with the topicals what we used. Again, a very difficult patient with a lot of steroid abuse and not responding to melasma, but responded significantly with 10 sessions. Another patient with 10 sessions. So generally you take around 8 to 12 sessions to clear melasma. This patient has generally dull looking skin with melasma. So I treated with 12 sessions of laser toning. Her skin tone and skin texture has improved. Melasma responded by 50% only. Another patient with good improvement in skin tone and good improvement in melasma. This is pigmentary demarcation lines. which is been treated with 8 sessions of laser toning with topical vitamin C and responded very nicely. The same patient on a profile view, melasma with steroid acne. She has melasma treated with steroids and had an acne. So it's been, we combined with isotretinoin and laser toning. The acne and pigmentation improved, but melasma is still there. And of course, as I told you, there are responders and there are many non-responders. So this patient with 9 sessions of laser toning didn't improve, and he started developing what is called as confetti leukoderma even with 1 joule, and we have to stop the sessions. And there is absolutely no response to laser toning even after 10 sessions. So melasma is a tricky situation, and patient counseling is very, very important while treating with melasma. But that's not the case with laser toning in post-inflammatory hyperpigmentation. You can treat it very nicely and successfully. This is a scald pigmentation. She developed this after very sensitive skin, not able to tolerate any topicals. So only sunscreen was used. And in 6 sessions of laser toning, we achieved a good reduction in pigment. Post RTA, it resolves on its own, but it takes a long time. So if you combine it with laser toning just in 2 to 3 sessions, this is superficial pigmentation and improves very nicely. So this is a post triple combination pigmentation all over the face. She has an marriage in 2 or 3 months. So we treated with every week, once in 10 days of laser toning, and we can able to get back her normal skin. Again, the same patient in another profile with a good improvement in her pigmentation. Again, post-traumatic acne with a lot of acne excoriae. She's been treated with combination of toning and isotretinoin and responded nicely, this patient. Post burn PIH, and this is an interesting case. She had melasma, rubbed hydroquinone, developed PIH. So treated with laser toning, the PIH improved, but there is no effect on melasma. Post chemical peel burns can be treated successfully. It can be used for generalized hyperpigmentary disorder like seborrheic melanosis or generalized pigmentary dyschromias. This is for with acne with an acne excoriae. So we used soft peel with toning, and she responded very nicely. Acne pigmentation following acne excoriae, and again laser toning extremely helpful. It can be used for photomelanosis and all other conditions in combination with topicals and sunscreen. Lip pigmentation, tongue pigmentation can also be treated with laser toning, or you can use here standalone Q switched, not in a toning mode. That increases the pain, but this can be treated. Coming to carbon peel for inflammatory acne, this is very good. You use carbon as an external source chromophore, apply it on the skin, wait for 20 minutes, and use 300 microsecond mode, which has been there with all the Q switch lasers, and use a fluence of 1.2 to 1.6 joules. And then this is followed by 2 passes of laser toning or Q switch mode in nanoseconds. The carbon lotion acts as a photo enhancer, settles down in the pore. 300 microsecond pulse mode gradually heats the particle. This heat stimulates the epidermis and dermis, and also supposed to kill Propionibacterium acnes. And the 5 nanosecond Q switch mode results in instantaneous blasting of this carbon, which results in transfer of the heat to the stratum corneum, and it supposed to correct the dyskeratosis at the pore junction. So this is in short about carbon peel. I use it. This is the commonest indication where I use spectra honestly in my practice, the Q switch laser in my practice. So this is an inflammatory acne, and just in 2 sessions of carbon peel, they improved. It can extremely useful in steroid acne where patients are generally not able to tolerate any topicals. So I treated. This is a disturbed patient with a lot of inflammatory acne. So I just did it 2 carbon peel with oral isotretinoin 20 mg. And just in 1 month, the inflammation subsided, the acne improved to a great extent. Again, an acne excoriae patient, nodulocystic acne, same combination of isotretinoin with carbon peel, and 3 months results are evident. I have not used ILS for this patient because she was not ready for injections. Acne excoriae responds wonderfully even in a dark skin patients. This is just pre-marriage acne where I treated her and she responded nicely. Coming to the gold toning, this is something which is not a laser because 532 is converted into 595 using a solid state dye. The beam is not coherent, but this serves the purpose of treating diffuse vascularity on the skin. So this is a nodulocystic acne which has been treated with carbon peel, and she had a persistent erythema which has been treated with gold toning just in 1 session. Another patient of same protocol treated with carbon peel and isotretinoin, and just in 1 session of gold toning. This is what you get it at the end of gold toning, where you have an edema and inflammation on the skin. Another patients where you have a good results in reducing the erythema in no time. I mean, just in 1 month. So this is basically a reconstruction of erythema, and just in one session of gold toning, you can see the erythema reduces significantly in this case. Another interesting indication of Q-switch India xanthelasmas, where you have a lot of treatment protocols available. Most of them are removed either surgically or with radiofrequency or with an TCA, which results in a long-lasting ulcer and takes a lot of time to heal. This paper describes using a very high-fluence Q-switch India with around 4 mm spot and 9 to 10 joules per square centimeter and bombard till a pinpoint bleeding and just wash it up. And they respond in just 1 or 2 sessions. All you need is a topical or an infiltration anesthesia and a corneal eye shield. And the downtime is really less because in 4 to 5 days, the wound heals completely. And the last indication is onychomycosis, where you can use to treat superficial white onychomycosis or not so dystrophic onychomycosis with Q-switch NDR. So in all, the newer protocols are makes Q-switch NDR versatile workhorse laser. Newer indications, safety and versatility makes it perfect choice for aesthetic and dermatology clinic. Thank you.
Thank you, Dr. Swapnil, for that wonderful presentation and excellent results. We'll take up the questions at the end of the session.
I would like to invite next speaker for this session, Dr. Sharad Mutalik, who will be sharing his presentation on evaluation of treatment of acne scars from surgery to energy-based devices. Dr. Sharad, please.
Good afternoon, everyone. And at the outset, I congratulate the team under Dr. Sahil for an excellent conference in the beautiful city of Chandigarh. Nice to be here in a physical conference after ages, as Maya said, before Corona and after Corona. So I will just be talking about the evolution of the treatment of acne scars from surgery to devices. The name of the conference is Stalwarts. So when Swapnil and Sahil called me, this was my reaction. I'm not at all a stalwart, maybe a small wart in the dermatology. And this is how I'm here. I don't claim to be a stalwart, but for today I have come to learn from the stalwarts. So I love in distance learning. So talking about acne scars, this is the surface of moon. Looks exactly like acne scars, and there were so many songs in Hindi films on moon. But after astronauts landed on the moon, Chand sa mukda kyun sharmaya. So coming to the business, celebrities also are not spared. So let us start reversing acne scars. But when I passed out, there were limited options to treat acne, leave aside scars. So it was thought as a part of young age group by parents, so nobody consulted us for acne. Nobody ever thought of pathophysiology, what could be the reason. External appearance and personality started getting prime importance later. And then, as with any other techniques, evolution started. What is evolution? A process of change in particular direction. So we know in our history, Sushrut was a plastic surgeon, and he used to perform sitting on the floor. And similarly, cutaneous surgery in India was in infancy, and that also sleeping in the 70s. Laser was not seen even at the horizon of India. And how did this revolution start? The stalwarts with passion and dedication, starting from Professor P.N. Behal, known as Guru Dronacharya, and then the phenomena called Dr. Satish Sawant. His initiative and CME's books, workshops stimulated dermatologists and propagated cutaneous surgery all over India. Then came the textbooks of dermatosurgery from Christopher Zakari, Roland Milland, and Satish Sawant. And all these stalwarts who came together as a family in Association of Cutaneous Surgeons of India. And then, yes, we started grasping something. And then acne scars were classified. This is a nice article. And this is how I explain the patients about the scars. So we don't remove the scars completely. We make them aesthetically present, or we remove the depth of the scars, make them more shallow so that more light is reflected. Now everybody knows that what stimulates scar formation. It is infundibular inflammatory process and rupture of the follicle. Just because of short of time, I'll run through the slides because today's topic is evolution. The pure comedonal acne, if not pricked, heals without scar. So no treatment was offered till 1980s, and then superficial scars were easiest to treat. And the best treatment available at that time was peels. And we had only resorcinol and salicylic acid at that time. These are the results of Shahnaz Arsiwala. Then came microneedling or dermaroller. Then came the electrical motored microneedling. Most the scars, medium depth scars or rolling scar. At that time, even we used sandpaper. When the dermabrader was not available, sandpaper was stuck to a pencil or a pen and then rubbed. And then came the Cow's motor. But one of the free camps, I saw this patient, one plastic surgeon used to do dermabrasion for anything under sun. And this lady, poor lady, went for acne scars and came back with keloids. Limitations of peels, we know. Dermabrasion requires skill and downtime, persistent erythema and chances of keloid and milia are there. Deep scars become more prominent. When we remove the superficial and medium depth scars with dermabrasion, the deep scars become more prominent. Coming to punched out ulcers, punch excision or punch flotation is the exact method. My method was to excise the punch, and after you excise, through that hole itself, you do subcision. So the negotiation becomes easier. And then take a stitch. When you approximate the edges, automatically the surrounding shallow scars, they become less obvious. No-core needle came later. I use a lure lock syringe to fix the needle so it can be held as a handle and negotiation becomes easier. Windshield wiper movement or to and fro movement. And lately, we saw this new instrument that is Taylor liberated probe for subcision. This is an article on that. Most difficult to treat was deep and ragged scars. Treatment offered at that time was wedge excision, subcision, dermabrasion, and then came ablative lasers. The patient expectations are pretty high. They want a gloss finish. In reality, patient expectations, were we able to meet? I don't think in aesthetics we are even today able to meet the expectations. So how much to promise? Could we keep the promises? Selection of method is very important. You know all this treatment. At laser treatment of acne scars, we are going to see it in the workshop. The first encounter with lasers, my encounter was in 1998 when we first tried this ablative RBM YAG. I neither knew the physics of laser, nor there was any scanner, nor there were any parameters. So this was like hitting with a pistol, a blind man hitting with a pistol. And that's how we started with lasers, and these were the results before and after with limited options available at that time. This is Dr. Patrozan's case. This is again a bad scar, subcision per RBM YAG. This I did with the ablative CO2. Now Sapnil had recently posted such photographs. Now I could, at that time I didn't have a good camera. This was taken as a printouts on SLR and then I made the slides. The ragged scar was excised and then I did CO2 ablative. This is again a pretty bad scar. Then came the fractional RBM, fractional CO2, and you can see the pixels. Sometimes it can cause PIH and persistent erythema. Most difficult to treat are ice pick scars, but now we can try cross technique. This is again a difficult to treat sebaceous hyperplasia. You can ablate it with radio frequency and give intralesional, but it recurs. Keloids with ILS. So first decade of this century, there were major advances in the treatment, defining the needs and refining the techniques with new devices and adjuvant treatments. And we are getting some pleasant aesthetic outcome. Devices, n number of devices are there, and every day a new machine comes, it is outdated on the day it is launched. This is a nice article, review article by Sadik. And you know this algorithm. Adjuvant treatments, new peels combined with the laser, platelet-rich plasma, autologous fat, and fillers. And lately, Dr. Somesh Gupta also published an article about collagen, autologous collagen. Then came fractional CO2. And it has many advantages over the ablative CO2. And these are the results, post-fractional CO2 plus salicylic and glycolic peel. This is Dr. Dhanashree's case. This is immediately after 2 sessions, that is around 6 months post-op without PRP. This is Swapnil's cases. He is the expert in this and he will detail the things during the workshop. Then came radio frequency. This is very important, the pyramid shape without disturbing the epidermis. And it enables 3D fractional volumization. This is Swapnil's video only. This is MNRF and less downtime, good results. We could not have thought 30 years ago. So this is the Niti Khungar's algorithm. But don't be too aggressive. Select proper cases, use appropriate parameters. And these are the stalwarts from whom I tried to learn lasers. But this is not a cup of tea for me. And then I was fortunate to meet my mentor sitting here. The rock, I can say, the Rock Sanderson of India, and has followers world over. So ablative lasers such as CO2 and RBM YAG lasers are most efficacious severe atrophic scars. Now we are having non-ablative as well as ablative RBM glass. And patients with darkened skin, particularly in this part of the world, what we are worried about is the persistent erythema and PIH. So good results. The patient, to avoid patient's headache, we say that we should be less aggressive. So wishing everybody Diwali full of light, of knowledge, health, and without any scars in our families and friends. Thank you very much.
Thank you, sir, for a nice and informative presentation.
The next speaker for us is Dr. Anil Ganju. He'll be talking on what's new in diode devices, dual, triple wavelength, and much more.
Okay, friends, good afternoon. I'm happy that the hall has got filled up again. I was a little apprehensive when we came in, there weren't many people. But to congratulate Sahil and his team, it's really a wonderful effort after such a long bad time that we've had with COVID. We've not had physical conferences. This is one of the biggest that I'm seeing after that, although we have had 1 or 2 workshops in Delhi. So welcome friends to this session. I'm going to talk about diode lasers. If there has been a change in evolution in laser hair reduction, it has been because of the diode lasers. And they have really changed the way we treat hair and remove hair. So that's what I'm going to discuss in this presentation. This is a part of all of my LHR presentations, that hair is not vital, but is of immense psychological importance, because men and women both are always apprehensive about losing their hair from where they don't want to lose it, from the scalp. We'll do a transplant tomorrow to restore that, and they don't want hair on the areas that they don't want, like on the face. So we're going to treat those areas now today. The advent of LHR has come as a huge boon to these patients. They used to run from pillar to post, doing all sorts of physical, modalities, but they would never get satisfactory results. And with this LHR, we have provided to them a method that has really, really given them a lot of relief. We used to work with LHR on the principle of selective photothermolysis, where we would target a single chromophore, heat it, dissipate the energy around this chromophore and cause damage to the surrounding area. So this was the theory of selective photothermolysis, but we moved on. This is a very important diagram for all of us laser surgeons, the absorption spectra of various chromophores. And in this diagram, if you see, melanin has a very wide range of absorption, right from about 400 to about 1200 nanometers, which means all the lasers that use melanin as a chromophore, all the lasers that produce wavelengths in this range could be used for hair removal. That's why we have a large variety of lasers for targeting the hairs. We have the ruby at 694, we have the alexandrite, diode, Nd:YAG at 1064, the intense pulse light, and then now the combinations. And most of these studies have shown that all these wavelengths and lasers, if used properly, with proper fluences and parameters, they all give similar results, as was seen in this retrospective, analysis of about 12 comparative trials. They had compared various technologies, and they found that most of them gave similar results, except that lasers had an edge over IPL. Now let's understand the wavelengths of LHR. Broadly speaking, the shorter the wavelength in this melanin absorption spectrum, the better is the absorption in the melanin. So ruby laser is the best absorbed in the melanin, while as 1064 nanometer is not as well absorbed. But our kind of skin, the skins of color, are better off with the longer wavelength, because the shorter wavelengths can target the pigment in the epidermis and can cause damage. And 810 diode laser has been a good balance between efficacy and safety, because it would be absorbed well also and would be safe also in our kinds of skins. The diode lasers, in contrast to the rest of the lasers, like the Nd:YAG, like the ruby, or the alexandrite, are produced by what are known as semiconductors. They are not produced by the crystals of their name. For example, Nd:YAG uses an Nd:YAG crystal, neodymium yttrium aluminum garnet crystal, and ruby uses a ruby crystal. But these diode lasers do not have a crystal as such. I was understanding what are diodes. They basically are semiconductors which have the ability to produce different wavelengths. We used to have a single wavelength of 810 nanometers earlier, but with the improvement in the technique, they have now been able to produce several wavelengths, and that has helped us to evolve. So what are these semiconductor diodes? They basically are a bar of a material which does not conduct electrical energy, uniformly and completely. It semiconducts, and with this, it produces a photon, and these photons combine together and produce a laser light. And in this semiconductor, if we put impurities of different concentrations, which is known as doping, we are able to produce different wavelengths from the same semiconductor. These diode lasers have the advantage of being solid state. They are quite robust machines. They have the advantage of having the in-motion technology so that we can use it in a better way. This is a diagrammatic representation of what a diode semiconductor is. Basically, two plates of a material which is made of a material are placed one upon another. One plate has is a positive plate, the other one is a negative plate, and in between they have an active area. When the electric energy travels from the upper end and from the lower end into this active area, the photons are produced and this laser light comes out of the central portion. And depending upon the impurities in these plates, the wavelengths can change. So that's why we can produce several kinds of wavelengths from these diode semiconductors. So what has happened to diode lasers? They have really evolved over the recent past. Conventionally, we used to have an 810 diode laser, which would be used in a stamping technique and would use the principle of selective photothermolysis for doing it. But then the in-motion technology came. Selective photothermolysis, I'll tell you what that is. Then came the production of different wavelengths from the same semiconductor. So now we had Alexandrite wavelength 755 coming from the same semiconductor and 1064 ND YAG type of a wavelength coming out of the same. So this made it easier and possible to produce all these wavelengths at the same time, shooting as double and triple wavelengths and being used as in-motion technology. So this has led to the evolution of the world. We have had started with IPL, we came with in-motion, now we have triple and double wavelengths. So these are the recent advances that have happened. One is the in-motion technology or the SHR technology. To understand this, we have to know now what is thermal damage time. We used to work on the principle of selective photothermolysis, taking into account the thermal relaxation time of the chromophore. So what is the thermal relaxation time? All of us know is the time taken by a chromophore to lose about 50% of the energy that it has gained from the laser light. But we moved on to thermal damage time. The thermal damage to not only the chromophore, but to the surrounding area also. This is done by gradual heating of the area over a short period of time, using multiple passes of minimal energy and building the energy in the area slowly. So this leads to more diffuse heating of the area, what is known as in-motion technology or SHR. So SHR works on the basis, on the concept of thermal damage time and the theory of extended selective photothermolysis. If you look at the diagram on the right side, this is a comparison of the two principles, the principle of selective photothermolysis on the left side and the principle of extended theory of selective photothermolysis. In the selective photothermolysis, we target a single chromophore, heat it, and the surrounding area is damaged. But in the extended theory of selective photothermolysis, which the in-motion technology uses, we cause a slow heating of the whole tissue, and there is diffusion of the heat to the chromophore rather than the chromophore getting heated and getting destroyed per se. So this produces more diffuse damage and treats multiple hairs at different at different depths as well as in the whole area. So now there are a number of studies available which have proven that this low fluence multiple pass or the in-motion or SHR technology is as effective, if not more effective, but at the same time very, very less discomfort associated. There's not much pain associated with this in-motion technology. Another study which showed in a split leg comparison that this technology is as effective and much less painful. An Alexandrite wavelength produced in a conventional laser compared with a diode Alexandrite wavelength producing less pain in the patient. And now we have these multiple wavelengths coming at the same time. And this is being done by placing several semiconductor bars in the same machine at the same time. So one semiconductor will produce 755, another one will produce 1064, and another one will produce 810. And that's how we'll have three wavelengths coming out from the same laser at the same time, and we shoot. And what is the advantage? It has been proven by many studies that it is effective and better. The advantage is that you are going to three different depths, one. And also, the melanin is better absorbed at the shorter wavelength of 755, while as 1064 is less absorbed in melanin, but more absorbed in water. So there is diffuse heating in the area by targeting the water. There is absorption in the melanin, which targets the hair. The two put together produce a more diffuse damage, just completing, to the whole area, and thus the hair are treated in a better and more effective way. Also, the three wavelengths go at three different depths of the hair follicle. The deepest, or 1064, will be most effective on the bulb and the papilla. The 810 will treat the bulge and the bulb, while as the 755 will treat areas above that. So there is more comprehensive treatment of the whole hair follicle. This is a summary of what I've already told you. We have dual wavelengths also available now. This is a technology which uses two-dimensional dual 755 and 810 nanometer. So friends, to conclude, LHR has come as a long way. It has been a welcome boon to these patients of hirsutism. Diode lasers have made it possible for us to evolve as far as LHR is concerned. These are semiconductor diodes, which basically are able to produce multiple wavelengths. The hairs better. The need is to select your patient properly, counsel your patient thoroughly, do an extensive workup. Don't forget that. That is the most important part that we as dermatologists can do better than the cosmetologists. Manage them medically if it is required. So medical treatment is to be combined. Select your best wavelength, best pulse width, best fluence to get the best result. I'll close with this slide of an invitation extending to all of you. The SARC AAD is doing its next physical conference, the Dialogues in Clinical Dermatology, with the theme of Innovations in Dermatology on the 18th and 19th of December at the Luxury Collection Hotel ITC Kohinoor in Hyderabad. I want all of you there. We are also happy to announce the launch of this Academy for Dermatologists called DIAS in association with the Aesthetics and Skin Institute of Australia, where we are going to train and give fellowship to young budding dermatologists at 14 centers across our country. You're all welcome. There are numbers and address down there to note, and you can get in touch. Thank you very much for your kind attention. Thank you.
Now I invite Dr. Neeraj Pandey. Neeraj doesn't need any introduction. He's the current Vice President of IADVL, Secretary of SARC. He'll be talking about high intensity focused ultrasound in modern practice. Over to you, Dr. Neeraj.
Can I get my presentation, please? Thank you. Thank you, Dr. Vineet. And at the outset, I'd like to thank Dr. Sahil and the other organizing committee and the scientific committee chair, Dr. Madhuri, for organizing such an event, and that too physical, in the era of uncertainty. My topic today is HIFU in modern practice. See, I just want to disclose that I added this technology just 15 days back, so my experience is limited, but yes, I'll share the experience of my peers, seniors, and few clinical pictures also. See, as we all know that facial and neck skin laxity traditionally been addressed using surgical lifting techniques. A wide range of non-surgical treatments have emerged as an alternative to surgery. RF, ablative, and fractional laser skin resurfacing provide variable degree of tissue tightening through the delivery of controlled dermal heating. Unfortunately, less invasive approaches are historically associated with low efficacy, inconsistent clinical response, and a less durable or the sustained tightening effect. So in 2009, HIFU was introduced to deliver precise focused zones of thermal injury at the treatment depth greater than the aforementioned technologies. And the HIFU device may be uniquely suited to address the problem. So aging phase, we all know these all are visible signs of aging. HIFU can be placed along with other procedures which we do regularly like Botox, fillers, or monopolar RF, or any other treat like threads, which we are doing for skin tightening, this Botox for relaxation of muscle, fillers for volume. And similarly, the HIFU, when we're doing all other procedures, we talk about the jowl or the lower face. I think HIFU is one of the best techniques which can be combined with other procedures. So the hours of rejuvenation, we all should be aware of this. To relax, Botox. To rejuvenate, lasers, chemical peels, medifacials, and many other treatments. Restore, facial volume, fillers, nothing else. Retighten, HIFU, and somewhat threads. Ultrasound is sound of frequencies higher than the dose detected by human hearing, at least 18 kilowatts of, or 18,000 cycles per second. Aesthetic ultrasound is well-known concept. For the laser, it's for skin tightening. Intense pulse light is for skin tightening. Radio frequency is for skin tightening. But where the HIFU is different, it's for skin lifting and tightening. So tried and tested ultrasound technology, it uses these sound waves to safely firm and actually lift skin tissue without disrupting the surface of the skin. It gives immediate effect, less pain, less discomfort, accurate and safe, no downtime. It produces small microthermal regions at precise depth in the dermis up to the fibromuscular layer. So the goal is to elevate to the local temperature to at least 65 degrees centigrade, the temperature at which collagen contraction begin to occur. As compared to any other procedure, this is the maximum depth which we get with the HIFU, whether you compare it to any other laser or RF. And it causes the thermal zones while sparing adjacent non-target tissues. So this is what the USP, the heat to 60 to 70 degrees centigrade. And in addition, de novo collagen formation occurs within the areas of thermal tissue, coagulation, and viscoelastic collagen forms. This is the slide which makes it different from any other procedure. The HIFU selectively target the superficial musculoaponeurotic system, SMAS, or the SMAS layer, composed of collagen and elastic fibers similar to the dermal layer of the skin. However, it has more durable holding property and less delayed relaxation after lifting procedure. So as compared to any other procedure, it's deeper and it's for the longer period of time. And it's the desirable target. And the HIFU was the first and only energy-based system FDA approved for inducing lift, that pro lift. But gradually, with time, this is of something around 2011. With time, we all know that what exactly and what indication in our clinical practice we can use HIFU. It's very precise, discrete, focused, and it causes thermal coagulation points occurring in the. This is one of the pictures where you can see. It spares intervening tissue, and it gives you a sustained lift. Inside, when you compare it to this radio frequency and lasers, they penetrate through surface, and HIFU completely bypasses surface. And this, when you say lasers, they reach shallow depth, but HIFU targets precise multiple depths. So HIFU versus the rest, if you'll see here, you see the temperature at 60 to 70 degrees as compared to any other, whether be it RF or the laser, it's much higher. And the depth, if you see, this is higher. So that's why it's targets more SMAS layer. So why HIFU? See, why I bought HIFU, I'll tell you, because we almost had all the machines. And when when I used to go to conferences, I used to see my seniors and peers speaking about HIFU, that this is one technique. When you combine it with other aesthetic treatment, it gives you desirable results. Specifically, when you're talking about the lower phase. See, again, I'll repeat, we are doing Botox, it's for relaxation with the dynamic wrinkles or the upper face. When you're talking about fillers, it's specifically to give volume. But what for the lower phase? When you're doing thread or other thing is HIFU. HIFU is giving you more sustained this. And when you combine it with other procedures like Botox, filler or RF, it gives you even better effect. And this is what the study say, the statistics from 2019. If you see the 67% are 15 to 64 years. So there is a demand. The demand, see, of late, the patients are coming with the demand, doctor, do you have HIFU in your clinic? So this is what gradually the Google Baba is letting the patients know there is procedure called HIFU also, which can be combined with other procedures. And there is maximum demand of anti-aging treatment in the middle-aged population, that is age 30 to 50 years. And patient want best treatment outcome with minimal sessions. And HIFU is one of the treatment which within a session or two gives you a desirable effect along with combination of other procedures. And it's very comfortable. I would say painless, but less discomfort. And its capability to reach deeper tissue layers, we have already discussed about this. It's a lunchtime procedure without any downtime, natural and long-lasting results up to 12 to 18 months. And now advantage of HIFU over the threads. It's a complete non-invasive procedure as compared to threads. There is no possibility of rippling and granuloma and infection post-procedure, unlike threads. It's very easy to perform. HIFU results are natural and you get sustained effect. And HIFU has no downtime at all if there are no complications as compared to threads. And then HIFU, advantage of HIFU over the monopolar RF. See, generally I'm combining with my monopolar RF with HIFU. The first session of HIFU, or maybe if we require 2 sessions, the first session, then after that 4 sessions of HIFU fortnightly, 4 sessions of this monopolar RF fortnightly, then again a HIFU. If there are a category of patient, those who does not want any injectable procedures, in that you can combine HIFU with monopolar RF or any other procedures to give them a desirable effect. So here when you combine it, when you compare it HIFU to the monopolar RF, you see the temperature 60 to 70 degrees centigrade, it's what the HIFU reaches, and there is 40 to 50 degrees centigrade. HIFU gives you tightening, lifting, and contouring, whereas monopolar RF gives only tightening. And then, see, I won't say that it's advantageous over fillers. Fillers are completely for different indication. It gives you volume, but yes, when we combine it with HIFU, we can get even better results. The indications are face and jowl lifting, nasolabial tightening, face contouring. It's a long list, but generally these are the top 4 indications which we generally use HIFU for. There are specific body transducers also which you can use, but I'm not doing it on body. And combination is the key to the success. See, HIFU is not the only machine which will give you the desired result. You have to combine it with the other treatments which you have in clinic, be it monopolar RF, be it Botox, be it threads. But you have to be cautious when you're using it with other procedures, when to place HIFU exactly. You have to start with HIFU and then go on to the other procedures. Patient selection is very, very important. Mandible line is in the patient which mandible line is not defined, moderate nasolabial fold, dull face due to aging signs, moderate wrinkles around neck and on face, moderate double chin, etc. Bulky face. This is one picture which I have. If we do HIFU, say around 2 sessions of HIFU along with 4 to 5 sessions of monopolar RF, we can get desirable effects. This is also a good candidate for cryolipolysis, cool sculpting, and then we can combine HIFU post cool sculpting also after a month or so. So this is one picture. I don't know whether HIFU is done or not. So the HIFU candidate is young with normal wound healing. Clinical response to HIFU is dependent on de novo collagen synthesis. Patient with mild to moderate skin and soft tissue laxity. Old age, photodamaged skin laxity, and platysmal banding skin may require high energy and maybe more than one treatment to achieve maximum benefit. And better, see, this is about body. When better outcomes, patient with BMI less than 30 kg per meter. We are not doing this one. We are generally specifically doing it on the lower face. And the no-go zone or thyroid gland is palpated and marked before treatment to avoid inadvertent delivery of ultrasound pulses over the area, temporal branch of trigeminal nerve area, and mandibular nerve area. And we have to be very, very cautious when we're using this 4.5 mm or D. There are many HIFU machines which have 4 mm or more. If we are targeting the buccal fat area specifically, you can have buccal fat depression there after the treatment. So marking is very important, specifically where not to do. And areas to be avoided are thyroid gland, thyroid cartilage, and trachea, major vessels. The contraindications is active infection or open skin, as in other energy-based devices, metal stents, implants in the treatment area, bioabsorbable mechanical implants. Area treated with botulinum toxin, at least for next 8 weeks, you should not do HIFU if you have treated that area with Botox. So there are complications, generally are mild transient, and there is moderate, severe, prolonged, is none yet reported. We can prevent complications if we are cautious. So this is one slide. ROI is very important. When you are buying a machine, we know that it can be where to place it. So I already mentioned that we can combine it with other procedures. If you already have say monopolar RF or the other machines, you can combine it with, there is a specific category of patient in which either you don't want to do injectables or either the patient doesn't want to go for injectables. You can combine in those procedures, and along with injectables also, this can have its own specific place, and it's cost effective as compared to any other machine. So there are clinical results. It's not mine. Thanks to Dr. Ishibara sir and the parent company. I'll just go through this. This is a gentleman. You can meet this, but he's already in the conference. So there are many like this. So I'll just go on the summary of HIFU benefits. Non-surgical, non-invasive treatment, proven ultrasound technology, convenient 45 to 70 minutes procedure, no special requirement or no downtime, natural gradual results, commonly one treatment, and if you get If you combine it with other procedures, you get desired results and visible and invisible results too. Dr. Ganju has already mentioned that this is Academy for Dermatologists by dermatologists. If you want to know more about HIFU, Botox, fillers, or any other aesthetic procedures, these are the numbers you can connect with in association with the Aesthetic Institute Australia. Thank you. Thank you very much.
Thank you, Dr. Neeraj, for this very informative talk on HIFU.
I would like to invite Dr. Chiranjeev Chawla for this session on laser and energy-based devices. She will be sharing her presentation on expanding the horizon of body contouring beyond the muscle, beyond fat to the muscle. Dr. Chiranjeev Chawla.
Hi, friends. I'm Dr. Chiranjeev. This topic which I'm talking about today is expanding the horizon of body contouring beyond fat to muscle. I must share with you that I have been doing body contouring since, non-invasive body contouring since 2002. So it's now almost the 19th year. And practically I have experienced for my patient each and every technology. So when this topic was given to me, like it is the last topic or the latest innovative treatment which is on the scene today. And I thank the organizers for inviting me to talk on this. Now, when we talk of body contouring, we first started talking how to reduce fat. We needed machines to reduce the fat. Then we thought that there is laxity. So if I have to contour the body, I should reduce the laxity with certain treatments, RF or other devices. Then there is a technology which has come which says that, we need to reduce, we need to build the muscle, we need to tighten and tone the muscle. And I will be specifically talking of this technology called high intensity focused electromagnetic energy. And the experience I have is with this equipment called M-Sculpt. Now, this treatment of M-Sculpt or HIFM has got a lot of publicity through articles, online, offline media, influencers. But when a technology gets so much publicity, it has to live up to it. Okay. And if you don't deliver results, then it will fall flat. I have been using M-Sculpt for the past 2 years now. And I'm going to be sharing my experience, actually my genuine, very, very personal experiences with this technology. So if we start the history, means why should we do it and where is the science coming from? Michael Faraday described the principle of electromagnetic induction in 1831. Now this is relating electricity to magnetism and magnetism to electricity, and HIFM or M-Sculpt is based on this principle. So now what does this principle say? That if there is a conductor and if there's a magnetic field around the conductor which keeps varying, then it will result in an electromagnetic or a voltage, which means अगर magnetism है और conductor है, तो वो voltage produce करेगा और वो electrical conductor में electromotive force आएगा. So this is what is HIFM all about. And HIFM or M-Sculpt, which I've been using since mid-2019. And the technology has got FDA approval, I think, in 2016-17. So what happens is, the law of electromagnetic induction says that any change in the magnetic field will induce electric current and vice versa. Now, in this equipment, there is an applicator, and inside the applicator, there is a coil. And when you pass current, AC current through this coil, and when this current fluctuates, an alternating magnetic field is produced. And this magnetic field goes to the motor neurons in the muscles on which you applied it. And the motor neurons cause contraction of the muscle fibers. So now it's like a long process. You go to the muscle, and what happens is the muscle contracts. And this system of contraction is bypassing the central and the peripheral nervous system, which means the patient will not feel the influence of so many strong contractions which the technology is producing in the body. So in this treatment, in 30-minute session, there are 20,000 pulses or 20,000 contractions. Just imagine if your abdominal muscle, the rectus abdominis, is undergoing 20,000 contractions in 30 minutes, what could happen? Now, these studies have shown that this induces an increase in the muscle fibers, which we call the hyperplasia, and it also increases the size of each muscle fiber, which we call muscle hypertrophy. And this results an increase in the muscle layer by 16%. Now, these supramaximal contractions have another effect is that they, because of the contraction of the muscle, that influences the adipocytes on the surface, means which are on top of the muscle, and these adipocytes, the free fatty acids, start breaking down in a lot of quantity. The cells undergo something which is called a cellular stress. The fat cell breaks up and there is apoptosis. So all this is happening by supramaximal contraction. So two things are happening. If you see, let me show you this slide, that if we see voluntary contractions are smaller, spaced out, M-sculpt or hyphem is producing very high intensity contractions. There is no gap in gap. And it is if you can you see that higher intensity pulses happening. Now, you may think, if my muscle is subjected to this, will it get damaged? So again, research studies have shown that in this period of 30 minutes, there was no damage to the muscle fibers. But friends, I also believe that future studies need to be done to understand it more. But till now, whatever we've seen, that there is no muscle damage. But yes, there can be excess lactic acid, but that gets sort of removed from the body over the next 48 hours. So supramaximal contractions resulting in muscle growth and fat disruption. How does it help in body contouring? The fat which reduces gives a better shape, and the muscle growth, muscle toning that is happening allows a surface on which the skin can drape better. So it is very important from the point of view of shape. Like if a person loses fat, the skin can become podgy and lax. But here, if the muscle is developing underneath, then the skin appears to be tighter because it drapes better. I'm sure I'm going to share, there are various researches which were carried on, and if somebody is interested to know more about them, you mail me and I will send you these papers. Okay, so ideal patient, we say somebody with the normal BMI range that is below 30, and the subcutaneous fat thickness should not be above 3 centimeters. Challenges are that it is an expensive treatment. It is treating limited area. Patient expects too much from it. But you know what? In cosmetic dermatology, which is the procedure where the patient's expectations are low. So it is better patient selection and managing the patient's expectations, which are important. Now I'm going to share some photographs with you. This shows us how the abdomen becomes more shapely. The stomach appears to be flatter. Again, if you see this lady on the bottom, the abdomen is looking better. So in my experience, out of all the non-invasive body contouring procedures, this is one of the better ones. It also does butt tightening. Butt lift is a very popular treatment or asked for thing in Western countries. So post-pregnancy for mommy makeover also, this treatment is being widely used. Now, we did a small little study on 10 patients for which we did 9 abdominal shaping and 3 gluteal region. And all these patients were very in the BMI range 26, 27, very, very fit people and very, very oriented towards fitness. So what I found is that I'm not going to go over these levels. We did a patient satisfaction scale. And what we found is that 50% of the patients were very happy, satisfied, and would wanting to go for a new treatment. And the people who were dissatisfied were the ones who just did one treatment. Actually, we recommended 4 treatments over 2 weeks. There is a new HIFM M-sculpt technology which is coming, which is combined with RF, and it claims to have better fat reduction and a better muscle development. So friends, I hope I have thrown some light on this subject. And thank you very much for attending this session. HIFIM is a modality for body contouring that ranges from improving the muscle as well as reducing the fat, is my conclusion. And thank you again. We at Alive Wellness Academy, that is the academy that I run, we conduct fellowship programs in non-invasive body contouring modalities and procedural dermatology. If anybody is interested, please do mail to me. Thank you very much, friends.
Thank you, ma'am, for a learning and wonderful presentation.
Somebody will have to close.
Thank you, ma'am. Thank much for the organizers inviting us to be the chairpersons over here. I'll hand the mic over back to the chairperson. Yes, ma'am. Yes.
The chair. Sorry, guys, I forgot. I'm going to be doing a demo in the other room. So it's going to be relayed here. And after that, anytime during this meeting, if any of you want to do a treatment of M-Sculpt on yourself, there is an M-Sculpt lounge at the entrance. Please go there and book your slot. Thank you.
Thank you, ma'am. Thank you, Sahil. Thank you for calling us.
Now we
Wonderful
move
conference.
next to the hands-on session on lasers. I invite the moderators, Dr. Anil Ganju and Dr. Anishpal, to take over.
So friends, hello. Yeah. So friends, I welcome you all to this on behalf of my co-moderator, Dr. Anuj Paul, and myself. We welcome you all to this session on hands-on on the lasers. So we'll be going to live demonstration of a number of technologies. We have about 15 to demonstrate, and we'll have our faculty demonstrating, and it will be relayed here. So any questions, please come up immediately because we don't have much time. We have to demonstrate many. Okay, any questions for the session that we've had as we connect? Dr. Sahil, please connect us to the workstations. Anything that you want to ask about the presentations that were done? We have the speakers here. Can that light go off, please? This light is very jarring. कर सकते हो उसको बंद? हाँ. हमारे को उधर कनेक्ट कर दीजिए. Thank you.
Sat Sri Akal, everyone. Good evening. I'm Dr. Paul with Dr. Ganju here. See, we are all here to learn, and learn. So don't hesitate if you have any question. So mics are over there. You can, always ask and connect with the faculty there. So first to begin with, it's like M-Sculpt. The Dr. Chiranjeev just talked about it. So in the meantime, when she starts, if you have any question regarding any other doubt not related to the session, you can please ask it. The mic is right over there.
Do we have the feed coming? Workstation से feed आ रहा है? उसको relay करिए. Yeah.
So good afternoon, people. Good afternoon, friends. I'm going to show you how I do M-Sculpt in my clinic. See, for me, two things are important. The three. First, it has to show results. Second is patient should be very comfortable. And while I was listening to Dr. Ganju's presentation, who said that even in hair removal laser, patient doesn't want pain. So similarly, in body contouring, also patient doesn't want pain. And there are some treatments which are a little painful, non-invasive treatments. So that's why I love it. What we do is that we make the patient lie comfortably. There are 5 areas which can be treated by M-Sculpt. One is the abdomen. The other is the butt. Then there are the calves, because a lot of athletes and a lot of people who are inclined towards fitness want even fit calves. And as we all know, calves are the second heart of the body. So if calves are strong, then we will be able to have a fitter body and we will be able to run till the later years of our life. And then there is the biceps and the triceps. So these three areas, the biceps, triceps, and calves, are for the athletically oriented or the fitness oriented people. And the abdomen and the butt are for the people who really want to lose fat and a better shape. Now we put this is a Velcro. We just place it here. As you see, it's as simple as this. And this is the applicator, which I showed you. There is a coil inside it, and it produces a current, which produces an alternative magnetic field. And what we do is we slip it just under this. Now she is a tiny girl, so I'm just putting one applicator. But there are two applicators. So when I need to put two applicators, I will put one like this, and I will put thoda aage kar do. Then I will slide one like this. And it's hands-free. It will go for about 30 minutes. How we set it is go here, and now
We are not able to see the screen, please. The camera has to turn on the machine.
so I'm just this.
Dr. Chabra, can you hear us?
I put two now. So you have just put one here.
Dr. Chabra, can you hear us?
So we take this out. Okay. So it's as simple as this, that I just put it here. We slowly increase it. First, I've taken it to about
Dr. Chabra, can you hear us?
total intensity.
Sahil.
How are you feeling? So,
Dr. Chabra, can you hear
she
us?
says that she's feeling vibrating. Okay. So, guys, this is as simple as this. I have taken one applicator. This is one applicator, second applicator. But because we're using one applicator, I put it at 70% intensity. Then you ask your patient how she's feeling. What are you feeling? Tell me.
Vibrations.
Do you feel any contractions?
Yeah, also. Contractions. No.
It's not painful. Okay, you know why it's not painful? Because in this treatment, their peripheral nervous system, CNS, there are no messages going there about the pain. So it is very restricted to the localized area. So this will go in for about half an hour. And after half an hour, this will stop. We'll just remove this. And that's it. Patient will go home. Do we need a massage post this? No. Do I restrict her exercise? No. I tell her, in fact, she should exercise the way she's doing earlier. But I would normally tell my patients that, see, you're doing something for body contouring. So please stick to your balanced diet and exercise at least 3 to 4 days a week. Now, I'm going to take you closer to the sound which this machine with these vibrations are producing. So there are two types of vibrations. One which are spaced out initially, which goes for 30 seconds. And the next 30 seconds of the vibrations are closely placed. So there is a difference in the tone of the vibrations. And friends, after 30 minutes, what I'll do is I'm going to stop the machine here. And why I'm showing you this is, first you remove the applicator and then you just remove this. And I would like you to see that there is no change in color, no redness, no edema. Are you okay? Any pain at the moment? No. So for me, a person like me, I would want something which is painless for my patient. But you know what? You're going to go home. You may, just about 10% of the people have a feeling of soreness. And that soreness just goes in about a day's time. And most people don't have it, but you may have this sensation.
Can
it will not happen after the
Dr.
workout.
Chabra,
If
can you
work
hear
out,
us?
it won't happen. The soreness is similar to the soreness that happens after the workout. And you will be doing this twice a week for 4 to 6 sessions. Okay?
Dr. Chabra, can you hear us?
Any questions, if
Check,
anybody
check.
has, you may ask me later.
No,
Dr.
we have
Chabra,
time.
When I'm in the hall.
We have time. Can you hear us?
Done?
Dr. Chabra, can you hear us?
No, she can't, Dr. Anju.
Dr. Sahil, please arrange for a two-way communication. वहां पे स्पीकर नहीं है क्या? तो फिर क्या हुआ? Dr. Chabra, can you hear us?
We can give her mobile phone. Jitin, phone दे दे.
Dr. Chabra, can you hear us?
मैं तेरे को phone कर दूँ, phone दे.
नहीं जा रही यार आवाज जितिन.
चल मेरा phone दे. Dr. Chabra, Jitin.
Dr. Chabra, Dr. Chiranjeev.
हाँ जी बोलिए डॉक्टर अंजू, मैं वहीं आ जाती हूँ.
Okay. Can we hear from the patient as to what was her exact feeling while the current was being passed?
So I'm going to put it to the patient.
Yeah.
Okay, so what was your exact feeling? What was your exact feeling when the treatment was going on?
The vibrations are increasing and it's like sucking my tummy. The contractions, like something is sucking my fat or tummy.
Was it comfortable?
No, not at all.
Was it like some feeling of a massage?
Yeah, more like a fit. Yeah.
I think it would be a little stronger than a massage.
Yeah. A little stronger. When you increase the intensity, then it was a bit stronger, I feel like.
So would she be comfortable doing it for half an hour?
She was there. We did it for 10 minutes, less than 10 minutes, 7-8 minutes.
Yeah.
But even if she would do for half an hour, I'm telling you because of my past experiences with my patients, that the sensation remains the same.
Dr. Chabra?
Yes.
Well, like you did put the applicator on cloth. So is it okay?
I beg your pardon. I can't hear you.
You put the applicator on her clothes. So like the direct body contact is necessary for that?
No, we did not put the applicator on the
cloth.
No, we can't put it on the cloth. We
Okay.
have to make the area. We have to remove the garment. It has to directly touch the skin because otherwise it will interfere with the magnetic.
Got it. Thank you. The other thing is like most of the body contouring devices, we skip the umbilicus.
Yeah.
So like when we were doing it, was it on the umbilicus also at that point of time?
Yes. So yeah, it was actually on the in the center. So it was on the umbilicus. And there are other body contouring devices. We do in and around, like say cryolipolysis, we do it in and around the umbilicus. We just leave the umbilical area. But in this case, we do it on the umbilicus also. So that's no contraindication.
No contraindication.
No.
All right. So you showed like wonderful results on the buttocks also. So what is your take on cellulite in this kind of, device?
I don't think it works on cellulite. See, it is
your experience, ma'am.
Yeah, my experience is that I have not treated anybody. I have not told anybody this treatment for cellulite. So, because I don't believe it works on cellulite, it is the muscle and the muscle, whatever is happening in the muscle, is going to the fat, and that fat is nearer the muscle. So, this is not acting on the fat or the fat cells entrapped in the skin. I don't think it works on cellulite.
So, keeping this question further ahead, like the kind of body contouring patients we get, they have got fat in inches. So by contracting the muscle down there, like at to 30,000 contractions per second, how much improvement we are going to get in that kind of fat in our Indian scenario?
मुझे ना आपकी आवाज समझ नहीं आ रही है.
Ma'am, Indian scenario के अंदर जो fat है, that is in inches.
Yeah.
So this device is acting on electromagnetic contractions of the muscle. So question here is that how would it help and how successful it is going to be in Indian scenario?
Okay, actually, I can hear you, but there's so much commotion in and around me that I'll answer you. So what happens is, I understood that in Indian people the fat layer is too big, and so it is ideal patient is somebody whose fat layer is not more than 3 centimeter, 3 centimeter, or the pinch is not more than 6. Hello.
Yeah.
So
We can hear you.
yes, so we say that it's ideally it works on people with a total skin fat depth of 3 centimeters, which means अगर आप उसे pinch करेंगे, then it should not be more than 6 centimeters. And I will go a step further and answer your question is that there are people who have a lot of fat on the abdomen. So will it work on them? Not to its best capacity. It will give partial results, because I have done it for very fat people also who don't mind little compromised results, because the contractions in that case will be milder than what it would be under best circumstances.
So you think it would be a good idea to combine it with other body contouring devices along with it?
Yes, perfectly.
In such scenario?
Perfectly. So that's how what I do is I tell my patients that this is going to work on the muscle and it is going to work on the fat which is closest to the muscle. And for the more superficial and more subcutaneous fat, I normally do cryolipolysis for them. So I combine cryolipolysis with M-Sculpt in my practice, and I find that patient satisfaction increases markedly.
Okay, so it means like it's a single device to go for if the patient has got like less fat, but if there are more, you need to combine it with other devices.
Sure, yes.
All right. So what's your take
Any questions? Let's take questions from the audience if there are any.
Any question from the audience, please? Right over there. Please speak.
Yeah. Please. How many sessions are needed?
How many sessions? The brand, the Amstrad company says, VDL says 4 sessions are more than enough. In my opinion, 6 to 8 sessions are required.
At what interval? Interval between sessions?
Interval is it's done 2 sessions a week. 2 sessions a week.
Can it replace semi-surgical techniques like liposuction?
No. I believe that all non-invasive treatments most non-invasive treatments cannot replace the surgical treatments, but people who do not want a surgery, and most people don't want to, I mean, all people don't want to undergo liposuction. It's a good sort of option for them.
What other areas you can do apart from abdomen? You told in your session, you told another one thing.
I beg your pardon. Can you repeat?
What other areas you can do?
The areas,
arms.
The areas which we can do are biceps, triceps, calf muscles. Calf muscles means we are doing the glute. So these are the 3 areas which we do. This enhances the shape of the body. Nowadays, girls and boys both do biceps and triceps. And then we do the abdomen for shaping, flattening, and the butt for a butt lift.
Is there recurrence?
Is it?
Recurrence.
Can it recur? You're asking, can the fat come back?
Yeah.
Okay.
Yeah. So see, it is supramaximally induced apoptosis. Apoptosis means actually the fat cells are breaking, and the fat cell is not reducing. The fat cell is breaking and getting destroyed. So it's going out of the body. So recurrence will not happen. But if there is a person who eats a lot, I mean, kahin to jayega na fat. So either it will go and deposit in some other part of the body, or in extreme situations, a new layer can be formed, which is different from the layer that has been removed from the body.
From which
Okay, we'll
age
have
we
the
can
last
do?
question.
From which age we can start doing? And what is the percentage of improvement? Percentage of improvement?
Can you ask this question later with Dr. Chiranjeev, please? Thank you very much, Dr. Chiranjeev. We will be planning to move to the next workstation, and just asking about the consumables in this device.
Okay.
In short.
There is a consumable to the device.
Yeah.
And see, each session, the consumable, it costs you about $3,000 per session for the consumable.
Okay, ma'am. Okay, let's have the last question, please.
Sir, can it be done with the patient with hernia, the umbilical or abdominal hernia?
Can it be done in patients with hernia?
Okay, now I do not I would like to get them to correct their hernia first. and then possibly do this treatment. But if there is no hernia and there's just divarication of recti post pregnancy childbirth, then it is seen that in fact it improves the divarication by 15%.
Okay, ma'am. Thank you very much. And we close this session. Give her a big hand, please. Okay,
Thank you very much for the appreciation,
Thank you,
guys.
thank you, Dr. Chiranjeev.
Thanks. So let's go to the next, please. We have gentle YAG being demonstrated by Dr. Swapnil. Can we go to his chamber?
Yes. Am I audible?
Chamber number 2. Yeah, Dr. Swapnil, please. Please start the timer.
No, Dr.
No, you are
Swapnil,
not
you're not
audible.
clear. You're not clear, please.
Station 2 का mic on करिए. Timer बंद करिए पहले. It's not clear. एक बार mic.
Adjust the
Can you test it?
Station 2. Hello.
आवाज साफ नहीं है यार.
Jatin, please adjust the mic of Station 2.
No.
No, it's not clear.
Okay. We'll wait, sir.
Yeah. Speak again.
Am I audible now?
Yes. Please go ahead. Start the timer, please.
Okay. So good afternoon, everyone. Now I'll be speaking on demonstrating Gentle Max Pro from Candela, US, which is distributed by Spectra Medical System. So basically, this is a long pulse NDR. It's a pro system where you have two wavelengths, either Alexandrite 755 or 1064 NDR. You can choose any of these two wavelengths, or you can upgrade. You choose one wavelength and then upgrade. This is not a diode-based wavelength. This is a solid-state crystal, which is available with this system. So coming to the system, this is 1064 nanometer YAG, which we most commonly use. It has a spot size from 1.5 to 1.53 mm.
The mic, please.
So it has a 1.5 and 3 mm, which is used for vascular lesion. Then it has 6, 8, 10 mm, which is used for non-ablative regeneration. And then it has 12, 15, 18 mm, which is being used for hair removal. So since this is a hair removal workshop, we will be focusing on hair removal. The good thing about this system is you have a pulse width ranging from 3 milliseconds to 100 milliseconds, and you can adjust it from 3 to 10. So for each spot size, this pulse width is available. The repetition rate, close the door.
AV people, can you look into this?
Excuse me, Dr. Swapnil, you're not clear. Just hold on for a minute, please.
So much of noise around, actually.
No, there's a problem in your mic also. वो corner mic first station का इनको दे दो.
Hello.
Yeah, Dr. Swapnil, thank you.
Go ahead.
Please go ahead.
So should I start again, sir?
No.
Yeah.
Go on from
Just show those, the
pulse width.
Yeah. So this is basically a long pulse NDR. The pulse width range from 3 milliseconds to 100 milliseconds for hair removal indications. It ranges up to 350 milliseconds for non-ablative regeneration. And for vascular lesions, we have a pulse width from 0.25 milliseconds to 100 milliseconds. So you have a wide range of pulse width available for your indications. The repetition rate is from 0.5 hertz to 2 hertz, which is pretty fast. Now, the best part is fluence ranges from 10 joules to 30 joules. And here is the spot size, which is around 12 mm. For 12 mm, you have 70 joules as a maximum fluence available. And this is a handpiece. If you want to change the spot size, you just have to press this and pull the lever backward, and it changes to 15 mm. For 15 mm, you have 44 joules. And for 18 mm, which is used for body hair removal mostly, So it has a 30 joules. So for all spot sizes, you have sufficient fluence to treat all types of hairs. So there's a conception or misconceptions between the users of NDR that you can't treat light hairs, thin hairs in a fair skin individual, but that's not true. Thanks to the pulse width, which is from 3 milliseconds, every single spot has a pulse width of 3 milliseconds. So you can treat actually the villous hairs with NDR, and the fluence available is very sufficient. The machine has an internal calibration where you can, whenever you choose one particular fluence and the machine fires itself in between when you start it for 3 times, and then you get a calibrated fluence through your handpiece. The handpiece is extremely light. It has 2 controls. This is a finger switch, and you have a foot switch control also. So the laser can be fired by finger switch and foot switch also. Another good thing about it comes with a patented cooling device which is built in the system, and this is a cryogen which is being used as a patented cooling system. This cryogen fires before the laser, and this can be adjusted on the screen. So now if I choose this as 20 millisecond, that means that the cryogen is going to fire before the laser pulse come out for 20 milliseconds. Then there will be a laser pulse. And then if you want a post cooling also, you can choose a post cooling and the cryogen will spray for the post cooling. Candela do not recommend post cooling now because and it is dangerous to use in a dark skin patient. The temperature achieved is impressive from almost minus 9 degrees centigrade to almost 5 degrees centigrade, depending on the duration of fire. So that's one of the best things available. You have variety of indications when you choose it. You have hair removal, redness, vascular region, the non-ability of face tightening, and a onychomycosis where it has been recently used either a long pulse or Q switch. When you go to hair removal select pattern, there is a which is very easy to use. Let us say if you choose a dark skin patient with a medium or fine hairs, the skin type of 5, and the most important thing, it asks whether the patient has a tan, active or established tan, and an established tan you should not treat with an hair removal. So that's a very additional safety feature which the machine has. So once you select no tan and go to next screen, the machine calibrates, and this is a preset parameter which machine gives you. So the recommended fluence with 18 mm is 18 joules. If I reduce the so if I use a 15 mm spot,
Dr. Swapnil, sorry, we can't hear you. Just a moment, please.
Mr. Jatin, can you please?
Just a moment, please.
Can you pause the timer?
वहां से pause करेगा.
Dr. Swapnil, Mr. Jatin, we cannot hear Dr. Swapnil.
Crash हो गया वहां वाला.
Light. Dr. Swapnil, you can come on the stage and let's talk about the device over here. Dr. Swapnil sir? Swapnil sir, can you hear me? Go and call sir on stage. Swapnil sir, please come on the stage. Let's discuss it over here.
He is not able to hear.
Dr. Swapnil, can you hear me? Dr. Swapnil, come on the stage. Let's discuss the next few points over here.
So are there any questions from the audience on this technology? Dr. Swapnil, give us the salient features of the machine,
Yes,
why
sir.
it is better than other long
Yes, sir.
pulse NDA and electronic.
This is basically a solid state laser with 1064 and 755 nanometer solid state crystals in the machine. It's a very powerful system. 81 joule is the maximum energy this machine has. Most of the NDRs comes with 40 to 45 joules per as an energy. This is 81 joule machines. You have variety of spot size, 1.5 mm, 3 mm, 6, 8, 10, 12, 15, 18. So you have a whooping 18 mm, which is good for body hair removal. The fluence available with 18 mm is 30 joules per square centimeter, which is sufficient to treat any types of hair. The pulse width is the beauty of this machine, which has a range from 3 milliseconds to 100 milliseconds for hair removal lasers. If you want to use hair removal, if you want to treat regeneration, it starts from 0.3 milliseconds to almost 300 milliseconds. And for vascular lesion, again, 0.3 milliseconds to 300 milliseconds. And the best part of this system is you can choose any spot size, any fluence, and the pulse width will be chosen independently of the spot size and fluence. So you have an option to choose the spot, the fluence, the pulse width, and the repetition rate. So it's very professional system. Now, if your assistant is using it, you have a preset parameters whereby you can choose the parameters, whatever you want to choose, depending on the skin type, the hair type, the whether the patient is tanned, if there is active tan or not, and the machine suggests you some parameters, you can always modify that parameters. The machine has an inbuilt cooling system, which is basically they called it as a dynamic cooling device. The dynamic cooling device also you have a liberty to choose the duration of that cooling. Basically, it's a gas which is fired before the laser, during the laser, and after the laser. So you can preset these parameters. Like here the machine says, I have chosen the dark hair thickness very fine, skin type of 4, and there is no tan. So the machine gives you a suggestion of 24 joules, 3 milliseconds, and 1 hertz. The pre-cooling is for 40 millisecond because you are using a very small pulse width. So you have to have a good cooling. Now by this choosing these cooling timings, you can actually adjust the temperature from almost 5 degrees centigrade to minus 9 degrees centigrade. So much is a powerful cooling, and which is especially useful for treating small telangiectasias and vascular lesion. It has a preset where you can use whatever indication you want. The newer indications like onychomycosis, diffuse erythema, keloids, hypertrophic scars, then telangiectasias, rosacea can also be treated with this machine. I'm using these machines in almost last 12 years, and there is absolutely no burns. It can be used in any skin type, any skin color, and on any areas of body.
Okay.
Okay.
Thank you very much. Yeah.
No, Dr. Swapnil, 2 minutes. It's very nicely explained, and I could see like NDA using for finer hair, you said. We have got seen all advantages of NDEAG. So why should we invest in machine having Alex also? So what are the advantages of Alex in this machine?
So it's not about why should it's basically gives you a liberty to choose between 1064 and 755. Indians as a dark skin patient, we are interested in 1064. If you go to like Europe and America, their predominant wavelength is 755, and they use 1064 for vascular indications more.
That's right.
Telangiectasias and rosacea more. So it is tailor-made. It need not, you should not or need not choose 755 if you don't want to. So the 755 anyway comes.
I think it has a definite advantage. 755, the thinner the hair, as the hairs go thinner.
Yes, sir.
755 works better than 1064.
Of course, sir. But
so
then
you have an advantage of having.
To best of my understanding, they like promote this device 755 in the Western world for for vascular lesions and superficial epidermal pigmentation also.
That is for 755
55.
and hair removal. The
75.
vascular is 1064 for them.
So like for, like this pigmentary, like freckles
Yes,
and epidermis,
they use
promoted that.
755 for that. You can use 755 for that.
And how about in hemangiomas?
Hemangiomas, I tried. Hemangioma, the only problem of 1064 technology, in higher fluences, it is an extremely painful technology. That is the only problem which I come to know. So for hemangiomas, generally you require a longer pulse duration of 50 milliseconds, the energy between 110 to 120 joules, and a spot size of 7 mm. If it's a kid, it's an extremely painful treatment for him. Of course, I have treated it, and it is reasonably, especially useful in ulcerative hemangiomas, where the ulcer heals in no time.
Quick one in 5 seconds. 755 for vascular leg veins and facial veins.
No. 755 is not for
But they promote it. It's close to PDL. They promote it.
Maybe, but the best wavelength for vascular lesion is 1064.
Okay. Thank you so much, Dr. Swapnil. Thank you
We
very
have
much.
seen 1064, Dr. Nitin uses a lot of it, and I have seen disfiguring of the areas with 1064 because usually you burn the skin. With the 1064, with those high fluences, actually it causes a lot of collateral damage.
No, sir, but for which indication?
What the vascular indications?
No, you mean telangiectasias?
Not telangiectasias, for hemangiomas.
Hemangiomas.
Large vascular lesions.
I think Candela do not promote it for hemangiomas anyway. Hemangiomas, for treating hemangioma, you don't need a laser anyway. Your propranolol or timolol acts very well. Actually.
Okay. Thank you very much, Dr. Swapnil. Let's move on. No, we don't have time now. Please. Okay. Can we have Dr. Anurag Tiwari? Can you connect, please?
So before we connect to sir, we have the launch of bi-axis by prime lace lasers. So let us congratulate prime lace lasers for the launch of the new device. So we want Mr. Arjun to be on the stage and help us with the cake cutting ceremony. Can we please play the teaser?
So we are going to have this technology only now, after this. Dr. Sahil, come.
Can we set the audio? We'll replay the teaser. Please replay.
Aye, Dr. Chiranjeev. Come, Dr. Govind.
We have all the laser faculty on the stage for the cake cutting ceremony.
Okay, congratulations. Please go ahead. Sahil ji. The depth. Okay. Congratulations. Okay, let's go to Dr. Anurag now. He is going to demonstrate this laser only. Dr. Anurag, can you hear us?
Dr. Anurag?
Can you hear us?
Mr. Jatin, we want audio from workstation 3. Mr. Jatin, audio from workstation 3.
Anurag. Dr. Anurag. तब तक कोई केक खाना चाहता है तो आ सकता है.
Hello. Can we stop the timer? We'll start it. Hello. Can we stop the timer? Hello.
Dr. Anurag, we can hear you. Can you hear us?
Yeah, I can hear you now. both ways. Yes.
But your volume is a little low.
We're on. Okay, fine. Hi, good evening.
Your volume is low, Dr. Nag.
वॉल्यूम बढ़ाइए उस माइक का, कॉलर माइक का वॉल्यूम, कॉलर माइक का वॉल्यूम बढ़ाइए प्लीज.
Now is it okay?
Yes, it's okay.
All right,
Please
fantastic.
go ahead.
Very good evening to all, and it's a pleasure to demonstrate this machine along with Madhuri. Madhuri, come. We'll open this. Yes, and this is the bi-axis laser, a Q-switch laser, which I'm going to tell you about.
Can
And
we
this
turn the machine towards the camera, please?
Yeah, and this is being marketed in India by Prime Lays Meditech, who are based out of Pondicherry and Chandigarh both. So it's home team. So this is a Q-switch, one of the most popular things in all our skin clinics after the laser hair reduction happened. So this particular device is totally a German made. And Dr. Anil, if I may ask you, you also use a Q-switch laser, and Dr. Anuj is also using a Q-switch laser. How many shots do your machines promise? Maximum number of shots?
I am not very sure about my machine.
Well, this machine promises you 6 crore shots. It's like 6 crore, it's huge. This is the biggest, possibly the biggest in the industry, which they are giving right now. So apart from being a sturdy German technology, Anuj, please keep your ears closed. I'm sure you're not very good with Germans right now, but then this German machine is doing good, and this German machine is going to possibly put everything on fire. So, sorry for the pun. So this has got a handpiece, and you have a 1064, you have a 532. So this is the continuous mode. Then you have an additional, the fractionated handpiece. So you can convert this 1064 into a simple fractionated device. If you can show this. So I just use this particular handpiece, and that's it. This converts into a fractionated Q-switch device. So the fractional part is usually used sometimes in more of skin rejuvenation and melasma, etc. This handpiece, you can change the spot size. So I'm changing it here. So it goes up to 10 millimeters, right from 2 millimeters to up to 10 millimeters. So this is about the hand pieces. Then I'm showing you the machine proper. So as you can see, these are the parameters on which we can play around. So you have the 1064, you have the 532, you have the fractional, and plus you have the quasi long pulse width here. So these are all the parameters which can be used in this particular machine. So I'm just showing you the 1064, right? And of course, you can change your fluence and reset it. Then one more thing here is that you have certain preset parameters in this machine. So if you don't want to go in if you just want to store these things, you can go directly. So if I have to do, let's say a capillary macule, I just do this, select it. I'm going to change the spot size to 4 millimeters. That's what my machine wants, and it's ready to shoot. So it switches from 1064 to 532 in case I want to just do that. And this particular light is switched on. That means the machine is ready to shoot. So I'm going back to the conventional 1064 right now. And this is ready. I want to. All right. So you can change the hertz. You can go up to 10 hertz, or you can go down. So a good machine, a sturdy machine, which promises a lot of shots for you. Most commonly used, it can be used for, of course, laser toning, for which we use very often. Then, of course, you can use it for nevus of aorta. You can use it for your tattoo removals, and a lot of freckles, capillary macules, all the pigmented, the epidermal or the dermal pigmentation. The epidermal pigmentation or the dermal pigmentation can be hit by this particular machine like any other Q-switch lasers.
Okay, Dr. Anurag, what is the peak hour power output at 1064?
1600.
1600, okay.
1600. Yeah.
So friends, it is important to know that the Q-switch lasers should have a high power output. The smaller tabletop machines did not have enough power output, so that's why they were not as good. So any other handpieces?
Yeah, Anil, we have, like I showed you, the fractionated handpieces there. And one more important part of this machine is that it gets ready very fast. Now, our other Q-switch lasers take a little time to boot up and then start. Now, this hardly takes a few seconds and it's on. It's got an auto calibration also. So before it switches on and you start shooting, the auto calibration happens. The machine shoots within itself at least 3 shots. And then according to the power and other parameters, the self-calibration helps. So your power, if it goes down, what happens in other machines is, as the power goes down, the efficacy reduces. So because it's an auto-calibrated machine, there is very, very less chances for such a thing happening. And you get a uniform 1064 or a 532 machine, the laser. So we did have some people here for demonstration. Okay, so I'll see, these are the parameters which we usually use for the laser toning. So I'm using a 10 hertz, I'm using 8 millimeter spot size and 1.2 joules. We have a patient here who has been told about it. She also has melasma, but I'm just going to demonstrate a small little area and how quickly and you can do this.
We don't have much time, Dr. Anurag.
Yes, we're just going to shoot a few of those and that's about it. I'm just going to show how quickly it works. So it's very, very important that the patient knows what you're going to do. The patient will have a mild stinging or a mild prick kind of a sensation, and you take it along the entire face, cover it up, and
so this is basically laser toning.
Yeah, we're just using the laser toning.
What is the indication?
She wanted it for the PIH and general improvement of the skin. She also has melasma, but we are not hitting the melasma right now because melasma we know is a troublesome thing to hit with the mode. But some people try it. Swapnil showed very good results with this.
So quickly the advantages of this machine over the rest of the machines.
See, the biggest advantage is the number of shots, the auto calibration. It gets on spot on very quick. It's got a fractionated handpiece, and the fractional handpiece also can have multiple spot sizes. So you can modify those spot sizes quickly. And plus, it's got a German technology, a huge backup service, and a strong service team, which is available from both North and the South India both.
Does it have gold toning and?
No, it does not have that particular handpiece. It does have a quasi long, but not a gold toning handpiece.
Okay. Thank you very much.
1 minute.
Thank you very much.
Dr. Anurag, 1 minute, please stay here. Look at me. Dr. Anurag.
Yeah.
Here. Why this machine is so compact and small?
Sorry?
Why this machine is so compact and small as compared to other NDEX?
Well, you're looking at the compactness because possibly it's a German engineering technology.
Yeah. No, like it's really like I was very curious to know that.
Yes. And what I will tell you is that we were just discussing that one particular disadvantage, of course, I have to talk about it. So one particular disadvantage of having a short handpiece is that you need to move the machine a little bit closer to the patient while you're operating it every time. So that is the only thing. Otherwise, it's a beautiful, handy machine, and it's a very space-saving machine. So people who have smaller clinics don't require a lot of space, and it can be easily manageable inside those particular areas also.
Maximum spot size was 10, you said, right? 10. Okay.
10.
And the other thing, very interesting thing you talked about for the audience view. Yeah. So that was, like auto calibration.
Yeah.
And most of the machines, they don't have it and they carry, like that meter with them.
Yes.
The NDI, tend to lose energy with time. So you have to, keep on rechecking with them.
Right.
So it's a very interesting point. Thank you very much, Dr. Anurag.
Thank you so much, Dr. Anuj and Dr. Anil. Pleasure.
Okay, thanks, Dr. Anurag. We are moving on to the next station. Dr. Prashant Agarwal talks about luminous light share, one of the oldest and the best hair removal systems that we have had. Dr. Prashant, are you hearing us?
Yes, sir.
Yeah, please go ahead.
So, am I audible?
Yes, please.
Yeah. Hi, everyone. I'm Dr. Prashant Agrawal, and I'm practicing dermatologist in Udaipur, Rajasthan, and I'm practicing there for past more than 15 years now. So today I'm here to demonstrate about one of the most famous name in Indian laser scenario, and we all know about it. That is light shear diode laser. And light shear diode, as I said, doesn't require actually any introduction because it's there in the market for past many years. In India, they have started direct marketing some 15 years back. It's basically an Israeli company, and it is manufactured both in Israeli plant and in American plant. And they have now this particular machine is being imported in India through Israel only, and they have the head office in Gurgaon, and they have the the good service network and everything. Even the all the service part. I mean, that's not a problem. I've been using this machine, not this particular machine. I've been using the ET model, the old basic model of light shear, for past 10 years now, and I must say that for me, I mean, it's one of my favorite machines. I have all the machines. I'm in the maximum of them. But light shear diode is something which is very close to my heart. And I always call it as Bahubali machine because this has tremendous power. So let's talk about this machine. Operating of this machine is not very difficult, and hair removal as such is not a very rocket science. We just need to play with two parameters because the wavelength is fixed. The other two parameters are the fluence and the pulse width. So the ET model, which I'm using for past 10 years, is having the pulse width options of 30 milliseconds to 100 milliseconds and 400 milliseconds. And the fluence ranges from 10 millijoules to 10 joules to 100 joules. It's a huge difference. And usually, I mean, for the beginners, I can say, yes, for the thicker hair and the coarser hair and the black hairs, we use the higher pulse width of around 100 milliseconds because the TRT is higher in them. And we can set the parameters of fluence somewhere around 18 to 20, ranging from 18 to 20 to 28 to 30 in Indian thing, depending upon the color of the skin and the requirement. And for the finer hair, we can use the smaller wavelength, smaller pulse width of 30 milliseconds. And the higher fluence can be used somewhere around 30, but depending upon the color of the skin, whether we can use it or not. So that's a basic thing. Now here, what we are looking at, light shear, this is not an ET model, it is Desire model, which is again for quite few years in the market, 5 to 6 years in the market, though I'm not having this. What are the advantages of this particular machine over ET model? This comes with two hand pieces. First of all, this one, which is having a spot size of 12 mm into 12 mm. My ET machine is having 9 into 9. So this is 12 into 12, which is definitely a bigger spot size, having more efficacy and delivery. And the power, this is having a more power as well. My ET machine handpiece was having somewhere around 1600 watt. This is 1900 watt. So this is definitely more powerful than the earlier one. The most advantageous thing is this comes with another handpiece, this one, which is, they call it as HS handpiece, high speed handpiece, which is having this bigger spot size, 25 into 32 millimeters. So definitely it is something which is very much useful while you're doing the whole body. And I've not done it, but then I've been told that this particular handpiece, with this particular handpiece, we can do the full body in just 1 to 1.5 hours because of many advantages. Other advantages like we do not need to use the gel in this. In my model, ET model, we used to use the gel before. So there's, I mean, we can save a lot of time into that and we can directly use it. So here I would, because we are having not much of time, I'll just demonstrate on the patient that how it can be used and how easy to use it. Even the changing of handpiece is also very easy. You can just open it from here, the lid, and you can just unscrew the one handpiece and screw the another one. This is very easy to use. You can just demonstrate. Yeah. Here you can see, it's just, you need to unscrew the old one and that's you can screw the new one. Yeah. So here we can see, this is the number of pulses, hertz. This is the vacuum level. the advantage of this handpiece is it actually sucks in the skin when you're doing the patient, and the skin comes more closer to the handpiece, and it diverts the energy more efficiently. So it's a huge advantage with this, and because of this thing and the larger spot size, we do not need to use the higher fluences as well, and that is the reason here we are having a range of just 12 joules. That is the highest. Where in ET model we used to use, I mean, we do not use it, but then this is having a range of 100 joules, and we can go up to 30, 32. But here we don't require much because we are having a bigger spot size, and we do not use that much of fluence. So here we can set the vacuum level low, medium, and high. In chubby patients, we do not need to keep it on the higher. We can just use it on the low. And in the thinny, bony, skinny patients, we can use the vacuum level on the higher side. So this is the vacuum thing, and the pulse width according to the type of hair we are dealing with, we can set the pulse width and the fluence. Usually in the body hair removal, we can just use it around 5 to 6 joules.
Sorry, Dr. Prashant, we have only 2 minutes now.
Okay, sir, I'll just demonstrate it. The machine is ready now, and here we are just making it ready from here, and it is so simple. I'm just putting it here, done, done, done. So you can see it is so fast and patient is so comfortable. In fact, I just used it on my hand itself, and I didn't feel it is very much comfortable. So it is, though it is not labeled as the painless laser, but yes, definitely I myself has just used it and it is not much painful. So I would say this is a good machine, and yeah, speed. Because we use the SHR, we do not use the SHR mode in this. The stamping mode is used. So theoretically, it looks like it must be a slow machine, but it is actually not. We can actually, because we do not need to go over that area again and again, we can just go with a single pass and we are done. And that is the reason while covering the whole body, it takes hardly 1 to 1.5 hours.
Okay, okay. All right, just quick one, Dr. Prashant. What's the peak power of this machine?
The peak 40.
I understand you have ET, but peak power of this machine?
So 1900 watt is
1900, okay.
That is for the 12 by 12 handpiece, and for this one is 2100 watt.
All right, thank you. Yeah. And the other one is that which is the minimum pulse width in this machine? Minimum.
So 5 millisecond is the pulse width, which is minimum, but usually, I mean, it is the presets are there 30, 100, 400.
So it doesn't go beyond lower than 30?
No, sir.
So how about the finer and the thinner hair where we need the,
yes.
pulse width, down to 10 and 15 in those cases?
We can, actually that's a big problem because 30 millisecond, but I think with the 30 millisecond pulse width also, we can do the fine hair with a higher fluence.
Finer hair and, higher fluence. So would it increase the chance of PA, burns and all?
Yes, it definitely does. But in my personal experience, if we are along with this machine comes with an automatic chilling thing. But then I always prefer to, keep the pre and post cooling.
Just for the audience, because the youngsters are there, given you a choice, diode versus triple wavelength, dual wavelength. Your cards on?
That's $1 million question. I would rather ask you to you and Ganju sir, because I've not I'm not using.
No, just tell us your heart out.
I'm a die-hard fan of diode.
Diode.
Yeah.
So it's like, the very sound and clear that diode is something which is like his choice. And I'm sure like everyone, we vote for that, vouch for that. Thank you very much, Dr. Prashant. Thank you so very much. Yeah, thank you.
Hello,
Dr. Swapnil.
Sir, I think there is no videographer. I'll just.
No, I can see you. We can just have a glimpse of you.
Great.
Can you move to your little left side? Oh yeah, here you are. Yeah. Perfect.
Right.
Perfect.
So coming back to the next.
So you are our star batsman today.
Yeah, star batsman out of form, it seems.
Please continue.
Yeah. So this is a microneedling RF device, YVC. distributed in India by Skin Aesthetics. It is an FDA-cleared microneedling device. This machine is a lot different than the standard microneedling devices which is available to us. Basically, it's the machine has a very high peak energy, a power of 70 watt. The machine is a 70 watt machine, which is divided into 10 levels. So you can choose it between 1 to 10 levels, the 10th being 70 watt. I think there is not a linear acceleration. That does not mean that one level corresponds to 7 watt, but that was told to me. The needle depth is range from 0.5 mm to almost 3.5 mm with an increment of 0.1 mm in each setting. So if you can see, you can go easily up to 3.5 mm with this. And the pulse duration, the RF duration is between 100 milliseconds to 800 milliseconds. So 70 watt up to 3.5 mm and up to 800 millisecond is the pulse duration available with this machine. Now, the interesting part about this machine, it has two cartridges, the blue one and the one red one. The advantage is they work in two different frequencies. The blue one is it uses an insulated needle and it works with 1 megahertz unit, which has 36 needles in it. And the red one is basically a non-insulated needle, which works with 2 megahertz frequency. And it also has a 36 needle. Another good thing about this needle, the machine does not have a shot counter. So you can use this needle for as long as you want in one single patient, maybe after proper sterilization. So they promote 1 megahertz insulated needle for rejuvenation purposes like skin tightening, superficial wrinkling, or deep wrinkling, and the non-insulated needle for scars, especially the acne scars. Another good thing about this machine is it has an inbuilt LEDs, which you there are two LEDs available. One is red LED and another is a blue LED. When you choose it and once you fire it, the LEDs fires along with this. So the red LED is basically used for when you are using a rejuvenating handpiece for wrinkles and skin tightening, and the blue LEDs are used when you are treating acne scars with some little acne. So this will prevent the exacerbation of acne also while treating it. The procedure is extremely simple. You just have to put the cap on the needle and fix it, and here you are ready to go. So what I'll do is, for demonstration purpose, I'll choose the highest level, which is generally we treat around 6th to 7th level. And if I'm choosing 3.5 millisecond and almost 100 millisecond as a pulse duration. Now, once I put it ready and I have chosen the red LED, the frequency is automatically going. Okay, so the frequency is 1 hertz and I'll choose the needle depth again. And 800 millisecond again. And can you see it? So a typical acne scar where we use non-insulated needle, generally the procedure is done under topical anesthesia. You apply topical anesthesia. It is very important to clean the skin because if you don't clean it, the anesthetic can go in. Then the handpiece always has to be perpendicular to the skin all the time, because if you do like this or like this, if there is no proper contact, you can burn the epidermis, and that should not be done. So the handpiece should always be in perpendicular to the skin. Generally, the parameters are preset. You can set these parameters whatever you want to choose it on, depending on the 4 programs which has been there. The machine can be operated by foot switch and hand finger switch both. I think that's about the machine.
Okay, Dr. Swapnil, what is the ideal depth For a usual acne scar, you showed 3.5 millimeters. Is that what you use generally?
So there are two schools of thought. Like people say that you should actually reach the base of the scar. Now, if you have a deep box scars or rolling scars, the depth is somewhere between mid-dermis. That is around 1.5 to 2 mm. And you have to go beyond that. So generally what we do is, if the scars are deep, we choose between 2.5 to 2 to 2.5. Now, if you are using an insulated needles, you have to give it 3 passes in layers. The deepest being the first. So if you are using an insulated needle, I'll choose 2.5, 2 and 1.5. If you are using a non-insulated needle, generally 1 pass or maybe an additional second pass is what is required. So it depends on system to system, but generally for acne scar, I personally feel 2 to 2.5 mm is what you should target at.
Do you think the insulated needles have a huge advantage over non-insulated needles?
No,
What
sir.
do you prefer?
No, sir. Initially, the debate was very strong between the insulated needles and non-insulated needles. Insulated needle is, of course, has a technological advantage on the non-insulated needles, because the chances to epidermal damage is absolutely negligible if you are using an insulated needle. Having said that, the theory put forward the non-insulated needle is that the needle as an electrode is active all throughout from the epidermis to the tip of the dermis. In reality, 80% of the energy will travel the path of least resistance, and 80% of this energy is going to be released only at the tip. So what remains is the 20% of the selected energy, which is active between the two needles, which is insignificant in regeneration. So insulated needle and non-insulated needle both works, both are equally safe. There is a wonderful paper published in Nature which compares insulated needles and non-insulated needle. And the conclusion of that paper is, by selecting a correct pulse width and energy, non-insulated needle can be as safe and as effective as insulated needle.
Okay, one last question on pulse width. When and how much to
Yes.
select?
So that paper also explains the propagation of RF current through and skin, and it clearly says that increasing the RF energy desiccates the tissue. Increasing the RF depth increases the zone of volumization or neocollagenesis, and increasing the pulse duration also has a positive effect on neocollagenesis. So if you want to be aggressive, it is better to increase the pulse width rather than increasing the energy. Because if you increase the energy and if there is a desiccation of the tissue, RF is going to cause burns in the dermis. That is going to cause additional fibrosis.
Okay. Okay, thank you very much. I think increasing the pulse width also increases the lateral coagulation, which is good for tightening effect. So I think the looser the skin, more should be the pulse width.
Yeah. Thank you, Dr. Swapnil. Just clarifying insulated and non-insulated debate, like as we usually do. About infraorbital region, just in 1 second. Infraorbital area, your selection of needle depth.
Yeah, infraorbital, I generally select around 1 mm. With my machine, I am not a user of this machine, so I can tell you about my machine. I generally use 1 mm. I used around 80 millisecond as a pulse duration, and level 4, which is approximately 10 watt. I used an insulated needle machine, and that's what I do.
You have used both lasers and MNRF?
No.
Your favorite?
The best thing for infraorbital is, I think, FSR, the superficial fractional mode, which is available with no needle RF. That you just, that's the best thing, because using lasers infraorbitally is again a problem. You have to have a corneal eye shields, and it is little bit risky. There are reports of even with corneal eye shield, you can cause uveitis or retinal damage. So using it frequently for infraorbital regeneration is a little bit of problem. So my way to go about infraorbital regeneration is an FSR mode of any RF device.
But last one, have you ever treated submental fat with MNRF?
No, sir.
No.
I never.
Okay, thank you very much.
Thank you so very much, Dr. Swapnil. Thank you.
Okay, Dr. Neeraj Pandey, are you ready? Dr. Neeraj? Dr. Neeraj, please come in. Can you hear us? Your camera feed, please. Your video feed.
Can you please switch on the video?
Yes, we can see you.
Okay, sir. So today I'm demonstrating this HIFU machine of Ironic, which is double O gold. So HIFU, we all are aware that as a technology, this emits ultrasonic waves, and there are different, it's a heat-wise as compared to any other energy-based devices, be it RF or be it other lasers. The penetration is the maximum in terms of the length. We say 4.5 mm is what the maximum that their 4 mm transducer does. And the if you ask, the temperature is the key. What I understand with this, it's 56 to 60 degrees centigrade, which is no other machine in the HIFU also creating this. And that's why the main target of this is the supraaproneurotic system. It is a layer which we say somewhat below mid-dermis and around patty layer. So they have the three transducers, the S7, M7 and D4. D4 is the most widely used, which reaches till 4.5 mm. Then there is there M7, which reaches till 3 mm. And there is one for skin rejuvenation, which reaches till 1.5 mm. This is S7. When we are the widely used is this D4. D4, whatever the transducer or the cartridge we say, the maximum number of shots which we can deliver is 22,000 shots. And suppose if we are doing full face with D4, it will be
Dr. Neeraj, please show the transducer also. Please hold it in your hand.
Yes. Yeah, I'll just tell you, and then I'll switch on, and then I'll show you whatever the transducers are available. Let me tell you about the machine, then I'll go on to the transducer one by one, and then I'll tell you how to place it and what exactly in the terms of number of shots. So I was saying that whatever the transducer, there are three transducers of the phase, but currently at this place they are having two. One is 3 mm and one is 4.5 mm. They say D4 and M7. S7 is not there, that is 1.5 mm. See, whatever the transducer, it can give you maximum shot is 22,000 shot. And one treatment, if you're doing full face, it's around 500 to 600 shot. And if we are doing only the ZOL or the lower jawline, it's around 300 to maximum you can go 350 to 400 shots, also depending on how bulky the face is. So if you calculate as per the ROI, what I normally do, the one treatment cost is something around 4,800 to 5,200. If you go with one handpiece, we can do around 44 treatments. So this is a practical aspect of this machine. So this one transducer costs around 2 lakh rupees, if I'm not wrong, but this is what the consumable is involved. Whatever machine, when we are buying a HIFU, this is also a point to be discussed. How much money are we investing on that machine or specifically the handpiece? Then the widely used, there are three. I have not taken their 1.5 mm, and I didn't find any significance to buy it. To do just skin rejuvenation, investing this much because we are having so many machines. So mainly we are working with their two transducers. One is which goes till 3 mm, and the other one is 4.5 mm. 3 mm, you don't have to be very cautious. You can do all over face, but when you are using 4 mm, there are some no-go zone, which we all have to understand. Now coming on to this, as Dr. Anuj was asking, I'll just take this transducer and then show you if it is. You have to just take it out. And then now you can see the machine will say that you have to put this cartridge or the transducer to start the machine. Otherwise, you can see the face of the machine. It is telling everything when you are using it. It's a very basic, simple machine. Once you put into this, it will start giving you the command. Now coming on to this. Just hold on. I am also new to this machine. So now you lock the machine. And then you can see the parameters here. There are 8 memory places there. Either of any of this you can select. Doesn't hold much of significance with 8. Then you see the 3 parameters. Can you just come on to this camera? Power is for fluence. Maximum with D4. This what transducer which I have installed is we can go up till 1.5 to 1.8 power fluence. And then the second one is spacing. Spacing is space between one shot to the other. The maximum you can do is 1.3 to 1.5, which we have already done. And the third one is the length of the shot. As we all know that HIFU works in a linear way as a line. So this maximum line is up to 25 mm. And whatever the transducer you are using, this 25 mm is ideally remains the same. Where we have to play is the part and the spacing of the shots. So these are the two parameters which has to be looked on. So this is what we have D4, and the other one is they're having one more that is 3 mm. This exactly it looks the same, and once you install this you will get the same parameters. With D4, normally we select a patient something like this. If it's a very bulky patient, D4 is the ideal and their maximum used transducer. Then the second one is 3 mm. 3 mm you can do for other facial lines also, and all over face. And the third one is 1.5 mm, which is, I don't have any experience of that. That's for skin rejuvenation. So I'll just demonstrate the machine. I'll give a few shots and then which area has to be skipped. Give me the gel, please.
How painful is the treatment, Dr. Neeraj?
See, this is the USP of this machine. There is a mild discomfort, but this gentleman is not, no amla has been applied. And I'm going with the, so if you need the...
Please take care of the gel, it is flowing down.
Gel. And when you are doing this jaw, one thing we have to see, it's not very painful, sir. But I have not taken it, as the gentleman says that this is not very painful. And he is lying here without any amla, without any local anesthesia. So this is his confidence on this machine, and I'm going by his confidence. So this is what if you say this, we have never to go on to bone. Because if we are going on the bone, the pain sensation is more, and then chances of, after that edema is there, and there can be, the discomfort is more. So we have to avoid this bone. We have to just stretch the skin. And when we are doing this, we have to just go downwards to upward. To just gel, you have to hold it like this. You have to see that there is no bone. And then something like this. Then this. There can be 25% overlap on this. So this is what we can do. And we can give 2 passes at one area. Then the other one is this. And one treatment takes something around 45 minutes if we go both sides. Because we have to go, I'm treating this area will take something around 2 to 3 passes. And then if we go down, we have to there is one thing which I have marked. This is if no area is D4. But if you're using 3 mm as per them, we can do on the milder part on this area also, but mostly it's better to avoid.
Quickly tell us, quickly show us the area which is to be avoided, the tracheal area.
So this is one area, the trachea. Then
Camera, please go down.
Yeah, please.
Yes, okay.
So this is the area where I have marked. If we have any red pen or something.
Understand.
We all know this is this.
Okay.
This is one area because the gentleman is having beard, so we have marked that area also. And this is one area which, seeing the vascular area, the mandibular nerve, we should not go there. Similarly, if we are going up, we have to change the transducer. We have to take 3 mm. And if we are using 3 mm, this area which need to be used with 3 mm, you can do it, but you to be used with caution.
So on the cheeks,
if you are doing forehead, 3 mm can be done with the lower part, and 1.5 mm can be done. Normally, it's a good practice not to do 4 mm over this upper face.
Okay, so what is the total number of shots that you would do all over the face?
Something around 500 to 600 shots all over face if we are doing.
Okay, and quickly the instructions after the procedure is done.
See, otherwise it's a very, very safe procedure, sir. What we say, normally at this and the other, there should not be any vigorous massaging for next 4 to 5 days. It can be painful. There can be numbness after the procedure for 2 to 3 days. This is normal if we are using this 4 mm, and then there can be pain post procedure. If needed, sometimes we can give analgesic. Most of the time, it's not required, sir.
Dr. Neeraj, do you think HIFU is a standalone device as anti-aging is concerned?
Again, it depends, Dr. Anu. Selection of client is selection of patient is very, very important. But see, as I said, if you have been through my presentation, HIFU gives the best result if used in combination. Suppose how I am using it, I do the first session of HIFU, then 4 sessions of Axialis elite, I'll take the name that is monopolar RF. And that after that, if needed, one more HIFU if we are not going for injectables.
So it means
the combination is the key to the success.
Okay.
But it's believed that we can, if the bulky phase is there and the number of sessions are calculated rightly and the right power is given, we can do only with HIFU also.
So message is clear that HIFU for lifting, monopolar RF for tightening, and laser for the superficial.
So
Yeah,
do
yeah.
all of them.
Agree.
Okay.
And
Okay.
the combination
How about like Dr. Ganjopachi?
Okay.
Yeah. You said about consumables. So
Yeah.
each cartridge gives 22,000 shots, if I heard it right.
Yes.
22,000 each cartridge.
22,000 each cartridge.
Because like no other companies, they have got so many shots. And the cost of the cartridges?
Cost of the cartridges 2 lakh rupees.
All
It
right.
depends on your relationship.
Okay, thank you so very much.
Okay, Neeraj.
Thank you, Neeraj.
Thank you, Neeraj. We have to close. We are short of time. Okay.
Thank you.
Can we go to Dr. Govind? Dr. Govind Mittal, please.
Thank you, sir.
Who is going to talk about reveal dual technology for LHR 810 755 diode. Dr. Govind, are you ready? Dr. Govind, can you hear us? Your mic is not on. Any questions from the audience while he's preparing the patient? Govind, could you speak into the mic, please? Where is that? Acha, missing. AV. AV, please pass on the caller mic to Dr. Govind, please. अभी तो थी, वो कहाँ गई?
So, sir, a question from my side. So we are talking about a dual wavelength machine now. So a single solid state laser, a dual wavelength and a triple wavelength. So you're the most senior person to explain that how does a semiconductor device produces the wavelengths and how does it comes like with 3 different probes. So that they can understand that if they are buying a machine, if some Chinese company saying it is like triple wavelength and they are selling it for the fine years and everything. So please, can you explain in detail for the audience so that they can understand that how you have to buy a machine?
Okay, quickly, the earlier when we started with LHR systems, we used to have solid state lasers and we used to have a crystal that would produce one wavelength. Like we had Nd:YAG, it would use the neodymium yttrium aluminum garnet crystal as a medium, and through that the light would pass and a wavelength, single wavelength of 1064 would come out. Similarly, we had the alexandrite. Similarly, we had the ruby. But now we have the diode laser. Diode laser is not a crystal. It is a semiconductor laser where we use a different kind of material, gallium arsenide. Gallium arsenate is the main material that is used for making that semiconductor. And to that semiconductor, several impurities are added, which is known as doping. And depending upon the concentration and the mixture of these impurities, different wavelengths can be produced from this semiconductor material. So if you have one semiconductor, you can produce one wavelength. And in these multiple wavelength machines, we have several semiconductor bars placed in the machine. And then these bars produce different wavelengths, and all these wavelengths are brought into one handpiece and shot at the same time.
Wow, what an answer. And this is what the audience and all the new guys should understand, that if it's just, they are saying like it is a triple wavelength, you should understand laser physics first. So unless or until you understand the laser physics, you can never proceed ahead good with the results. Dr. Govind?
Yes.
Yeah, please, go ahead.
Thank you for such a wonderful explanation, Dr. In fact, I just want to add to that. Yes, there are a lot of technologies coming in, claiming triple wavelength, but we actually need to see the power of the 1064 that is being provided in the triple wavelength machines. So here I am to demonstrate, to talk about Reveal 2D technology, which was first launched in 2019. Now this
Caller mic का volume बढ़ाइए, please. Console.
Am I clear?
Great. Am I audible, Dr. Ganju?
Not very clear. यार कॉलर माइक का जरा
Can
वॉल्यूम
you shift the collar mic?
Yeah. Am I audible now? Am I audible now?
Govind, can you adjust? No, it is
Holding it to my mouth. Check. Am I audible?
Yes, that's better. Please go ahead.
Okay, great. So, as a young dermatologist, before we invest in any laser machine, we are always thinking which is the right machine for our practice. So, the first laser machine that any young dermatologist ends up buying in their practice is obviously a laser hair removal machine. Why? Because of the demand, and that's what's going to add to the moolah of your clinic, right? So after having researched or tried different machines for almost last 7 years, I ended up with Reveal 2D technology. Now this combines 755 semiconductor diode and 810 nanometer semiconductor diode. So it's a 2 wavelength combination technology produced by Israel. So this is technology that you can trust. And the beauty about this machine is that the TEC cooling that they provide and almost virtually painless. So many of the demos that I took, which involved 3 wavelengths, a common problem was the pain complaint and the problem about 1064 not being as powerful to tackle the real thick hair. So now 2D or the dual wavelength combination works on the principle of extended theory of selective photothermolysis. Now, what is this theory? We know that the bulge area, the stem cells, need to be destroyed if we are looking for permanent hair reduction or removal. So, and we also know that these stem cells are colorblind. They do not have melanin. So, looking at the principle of extended theory of selective photothermolysis, the TDT to TDR ratio, that is thermal destruction time to thermal relaxation time ratio, is very good when these 2 wavelengths are combined so as to tackle both the coarse hair as well as the fine hair. The beauty about this machine is we are able to treat fine hair as well comprehensively. So that's something that I really like. And also the difference that I have seen in patients where I have done the previous technologies to this is the the speed with which
Dr.
I can
Govind,
do the
could you move
procedure.
a little so that the machine is also visible? Yeah.
Sorry.
Thank you. Yeah.
Sorry. Yeah. So that is what I was talking about. So this machine, if I can quickly just show you the machine. So this machine is quite classy looking, sturdy, good, and which has both the stamping mode and the smooth mode. So most often when we have technicians in our clinics and we want them to do the laser treatment, we want them to do the smooth mode. So in the smooth mode, based on the grid size of the area that you have chosen, you can adjust the various grid sizes and the frequency of the machine, the frequency of the shots can be adjusted. The power fluence, of course, can be adjusted. So can we just apply the gel? So I'll quickly demonstrate.
While you are demonstrating, could you tell us what this 2D technology is that the Vega guys have?
So 2D is combining 755 nanometer wavelength produced from a semiconductor source with 810 nanometer semiconductor source. So both these wavelengths are combined, and this combination really helps in creating a high average cumulative power to destroy the hair bulb as well as the stem cells. So this combination has a good penetration, especially to the level of the stem cell area as well. So as I explained initially, it really works well in destroying the hair bulb as well as the stem cell area. So
what is the percentage of 755 and 810 in it?
They are equal, sir.
50-50?
40 to 60, 40, 60.
So 40 is Alex and 60 is 810,
Yeah,
right?
yeah,
Okay.
yeah. I wouldn't call it Alex. Yeah, 750, 755, 40, and 60% is 810.
Okay. Okay.
Please go ahead.
So it comes with only one handpiece, right?
Yes, it comes with a single handpiece,
And it doesn't come with 754 810 alone.
no.
Only combination.
Only combination, which is shot simultaneously. And the spot size is ideally designed, especially when nowadays more and more people are asking for body hair reduction. So it has a 2:1, that is 20 mm into 10 mm handpiece, spot size. Sorry. And a pretty light, handpiece, I would say, just about 350 grams, and pretty light handpiece.
20 into 10.
Yes, 20 into 10 millimeter spot size. Footpiece thing. So how comfortable are you? Do you feel any hot massage, a warm massage?
One question comes in mind, 755 and 810 together, chances of burns in Indian patients.
Sir, I feel it is reasonably, I have not had any burns in the last 6 months, to be precise. I think any machine can give you burns if you're not using the parameters properly, but I really have not found burns a problem.
Okay, Alex goes up to 1.8 and diode 2.0 millimeters, like near the bulge area.
Yes, sir.
How would you address the deeper hair, in the body?
So deeper hair is also, I wouldn't say that this may be the best technology if you have all patients with pilonidal sinus kind of a depth hair, but for body hair and for facial hair, this works reasonably well.
Given you a choice, diode alone, diode with Alex, or triple wavelength.
I have already made my choice. I had the same
question. We're talking about science here.
Science,
I agree.
yes.
Yeah.
So science, I would look beyond just diode alone. The reason being that it is helping me, the combination of 755 and 810 is helping me tackle the fine hair as well. And the reason that I did not combine 1064 is one, it adds to the pain element, and the current combinations with 1064 are not doing justice to the 1064 power that is required. So all the 1064 are semiconductor source, whereas an actual powerful, 1064 requires a solid state source. So that is the
Okay,
reason
Dr.
I
Govind,
settled
thank
for
you
a
very
2D.
much.
Thank you so much. Thank you so much.
Thanks a lot. You have really explained it well. Can we go to the next technology, please? Dr. Roma Pandhi.
Thank you. So anyone who wants to try out or have a look at the
They can go to the stall and try it out.
Thank you.
Okay, Dr. Roma Pandhi, can you hear us? Dr. Roma Pandhi is going to demonstrate.
Am I audible?
Yes, please. Can you switch on the video?
Give us a minute.
Yes, we can see you. Please go ahead.
Okay. So good evening, everyone. I'm Dr. Roma Pandhi. I'm a practicing consultant dermatologist and cosmetologist from this very beautiful city itself, Chandigarh, and I welcome you all to this city. So today I'm going to be doing a demonstration of the Resurfax laser being marketed by the Luminous company. And so my experience with this laser has been fairly good, and the results have been also fairly decent. And so this is a fractional erbium glass laser, which is non-ablative in nature, and it functions on a 1560 wavelength. So the advantage this machine has, we will discuss later, but I would like to explain you the parameters and about the machine first. It's very easy to use. So that's the home button. That's when you turn it on. The moment you turn it on, the screen comes on right on front, and it gives you options of choosing. So you have an option of, cancel, sorry. So you can select the screen that gives you options as to you want to treat what kind of scars you're looking for treatment. So that's the preset parameters it gives you for the different types of scars. And suppose you're going to click on an acne scar. So again, in acne scars, you can click on this button, the clinician button, and gives you the options of the different types of acne scars that you can treat, the rolling, the box scars, and the ice pick scars. So that is as far as the acne scars is concerned. And then you can choose the skin type, what type of skin you're trying to treat, along with picking up what kind of scar you're trying to treat. So suppose I pick up type skin 3, and then there's a box scar option, followed by whether the scars are very severe or deep in intensity, or if they're just moderately intensive. Suppose you pick up medium, it gives you a preset parameter of the intensity as well as the energy levels. You can initially be very safe in using the particularly fed up intensity levels, and then gradually, as you get confident in using the machine and you have understood what parameters work for which kind of lasers, you can play around with the energy levels as well as the density of the laser. So then going back, suppose I decide to pick up striae, which is also one of my favorite treatment options with the resurfax. So when we pick up the striae, it also gives us what kind of striae we are trying to treat, the rubra or the alba, that is the red stretch marks or the white ones. And then again, depending upon the skin type, you can select the skin type, select the kind of stretch mark, select the intensity and severity of the stretch mark, and then just press OK. It gives you again a preset parameters. So the advantage with this machine, of course, is that in addition to having the scars getting remodeled, the skin also gets remodeled along with it, because the water, which is the chromophore, it is absorbed initially at the deeper dermis, whereas the superficial epidermis also gets remodeled. So there's a new collagenesis which is taking place whenever we are using this particular wavelength. So now, so going back to the preset parameters again, so there's an option of skin treatment here as well. So when I was talking about the skin remodeling or the skin resurfacing, it takes place through this particular option. And then in the skin resurfacing, we can choose areas, whether it's generally the whole face or any particular part, whether it's the neck or the hands, or we have areas, the softer, the gentler areas like the eye areas, the periorbital or the periorbital area or the perioral area. So suppose I am going to select the skin resurfacing, which could be for any part of the body, depending upon, again, the skin type. And then I pick up whether the intensity of the wrinkles or the sagging of the skin is very high. I pick up a severe option, and then again, it gives me a preset parameters, which I can go ahead and use on the patient. So the one of the best features of this machine, of course, is that it gives you, it has already 600 feed-in parameters, in which we have options of selecting the different shapes and sizes. So there are different shape options we have, right from a single line to a hexagon to a circle, and the size of the scar or the shape can also be decided. It varies from 5, and it can go up to 18 or 17 depending upon which kind of shape you're selecting. So for convenience sake, so whenever, which I have not seen in any of the lasers till now, is for linear scars. So there's an option of linear scars. So when we're treating stretch marks particularly, we can select the linear scar, the square shape or the linear scar option. And along with that, we can select the size so that we're not unnecessarily damaging the surrounding skin and tissue, and we're only treating the targeted area, which is the big benefit, because we don't want to traumatize the already healthy skin. We want neocollagenesis to take place, but we want it only in the skin which is already scarred. So, of course, we have the energy denser. This particular feature is for the selecting the microbeams per meter. So this.
Sorry, Dr. Roma, we have 2 minutes left.
Okay, so yeah, this gives us, once you are well versed with using the laser and you don't want to use the preset parameters anymore, you can also vary your microbeam. So this is the number of microbeams given per shot. And they can be increased or decreased depending upon the depth of the laser you want to give. And also this is for the energy levels, which start from 10 and go up to 70 joules. And this is an option that we select for repeat mode or a single mode. So if we just want to give a single shot, then we don't have an option. We can just give a single shot. But if you want to do a repeat pulse and vary the gap between the pulses and shots, then that also can be selected. Yeah, so I can just do a small demo here.
Yeah, quickly. Then I'll ask you a question or two and then we'll move on, please. So friends, this is a, yeah, please.
So it has a cool scanner already in it. So it makes the procedure very, very less patient tolerable. So I'm giving a shot right now. And I could have increased the size and so that it would have been done in one shot itself.
How painful is the procedure?
So it's very comfortable because it has a cool tip technology and it has a window through which you can see that you're giving the shot in exactly the area that you want to deliver the energies.
Please show us the immediate post-op, changes on the skin.
Yeah, can you please focus the camera here? So there could be a little surface redness, but that's also barely visible or minimal. And so the downtime is very, very less. The patient can go home without having a swollen face or a erythematous face.
Quickly, Dr. Roma, have you done MNRF? Are you into MNRF also?
No, sir, I did decide on using MNRF also, but then MNRF had its downsides in terms for stretch marks and striae. I thought that having a limited area used compared to a wide one, which we need, MNRF uses a wider area versus the resurface laser, which has a particular area which I need to target, like the linear area, that actually saves on a lot of tissue remodeling.
Okay, just for
Consumables.
your information, Dr. Roma, like MNRF does really work very well in stretch marks, my personal experience. Now, a little about resurface, like I have used it in the past and I found really very effective. And it's a 1565 nanometer, but it goes up to only 800 microns to 1 mm. So do you find any difficulty in treating lesions that are deeper beyond that? Deeper scars, I mean to say.
Do you find what, sir?
Any difficulty in treating the scars that are deeper?
Yes, sir. A deeper
They stop
scars,
responding at one point of time.
agree with you, sir. Deeper scars at one point definitely do start not responding. So then I like to combine procedures. Maybe I would do a derma roller with a deeper
So
tip.
yeah, thank you for your information. So input is that you have to combine it something that goes deeper in the skin.
Yes.
And there are now these days, markets equipments are available which combines both fractional non-ablative and MNF together in one system.
Yes.
So you can use them alternatively. Thank you so very much, Dr. Bandi. Thank you so much. Yeah.
Thanks, Dr. Roma. We move on to the next technology. Dr. Swapnil, can you hear us? Dr. Swapnil? Dr. Swapnil talks about core CO2 laser. Yes, please.
Yeah. Am I audible, sir?
But the video is not on.
Yeah, just.
Yes, please.
So
you have to come in the center again.
The video is visible now?
Yes.
Okay. So I'll be demonstrating core CO2 RE from Candela laser distributed in India by Spectra Medical. So this is a state-of-art CO2, very different from the other fractional CO2s which are available in the market. This is a 60 watt RF excited. It has a 60 watt RF excited tube with a smart pulse technology. Now, what is smart pulse is basically it is very similar to the ultra pulse. Maybe because of the patented name of ultra pulse, they are not using it ultra pulse. But it is a digitally smart pulse machine where the extended wing of the pulse is been cut off, and it is just like an ultra pulse with a quick in and quick out system. Now, this is a home screen of the system. It has 3 indications. The aesthetics, that means it's a fractional device with full face resurfacing option, which is through a scanner. Then it's an intima, which is basically used for vaginal rejuvenation. They have a separate handpiece where you have an internal, and external means the external rejuvenation. And then core surgical, which is basically a surgical handpiece of 150 or 120 micrometer in size. So coming to the aesthetic, the best part of this machine and what I liked when I saw it first is, if you see, this is the handpiece of the machine. So there is no scanner, external scanner in this machine. The scanner is on the board. It is inside the machine. So this same handpiece can be used for full face resurfacing, scanner resurfacing, or a fractional resurfacing. You don't need, and it's not bulky, it's extremely lightweight and extremely maneuverable. Like you can move it as long as it is possible. Now it also comes with an optional 120. This is with a standard spot of 150 micron. This can, you just have to replace this with 120 micron for a surgical handpiece. And this is a surgical handpiece made up of very lightweight aluminum, which can be used to make an incision. And the incision made by these machines are extremely precise without a lateral damage. Coming to the aesthetics, the fractionated beam is, as I said, the scanner is inside the machine, not on the outside the machine. Now it has a totally different types of scanner beam patterns which has been produces, and this is the only machine which produces ring pattern of scanner. None other. We know that it is dots, but this machine has different mode: the light, the mid, the dip, and the fusion mode. Now once you choose a light mode, basically, it asks you to confirm whether you are using the same handpiece. And once you confirm, now if you see, this is the pattern of ablation what you get. So the pattern size can be adjusted. It is from 8.5 mm to whatever the size you want to adjust. The coverage starts from 30% because it's a light, very superficial peel, and it goes to up to 50%, I think. So 30 to 50% is the coverage available with fractional coverage with a superficial mode. The ring size can be adjusted. The ring size means the diameter of the ring, the thickness of the ring can be adjusted from 1 to 5, 1 to 3, and the ring per ring energy, like the per ring energy can also be adjusted. Now I have used around 30% coverage, 18.5 mm of energy on my hand. Can you focus it on here? Is it visible, sir?
To some extent.
So
Could you
if
go?
you see-
Could you
if you
zoom in
see-
it? Zoom in a little more.
So by ring, you mean it is the dark part which is coagulation? And
Yes,
center and surrounding
the
is normal.
center is clear, and there is a zone of
Got
faint
it, got
erythema of ring. So this is a ring pattern. And why this is important? Because even if you are covering 30% of the area, only this thin part of the ring is going to be ablated. The rest is, center is almost, there is no heat, no ablation. And that adds to the recovery, faster recovery and superficial depth of the machine. Now this is once then they have a mid size where the fractional coverage start with 20% to 50%, and deeper is you actually go deep. These are the various scans patterns available: circle, hexagon, rectangle, triangle, and a ring. So you have a lot to choose between. Again, the same energy, the same parameters can be applied. Fractional coverage ranges from 20 to 50 or 40% of the fractional coverage. The deep mode is what we use for acne scar, and the fractional coverage is from 1 to 5%. And it's a very, very aggressive mode. You can go up to 4 mm very easily with this mode. And there is a little bit of collateral damage. If you can see, it's a quick in and quick out. The pattern size, again, you can choose depending on what you are treating, from individual scar to 7.8 to 7 by 7.8 mm. And the best part of this machine is, which is very, very unique to this machine, is a fusion mode, by which when you choose a fusion mode, you are actually centrally going deep, and peripherally you are somewhere in the mid dermis, the mid zone. So at the same time, you are treating the scars and you are actually treating the superficial wrinkles, superficial ablations, or pigmentary dyschromias, whatever the patient has it in. So there's no need to give an additional pass. So I'll explain this on demonstrating on tomato, what exactly I mean by this. Now, apart from this, this machine has a full face scanner based ablative properties where you can actually ablate the skin as with a standard. So when I choose a light mode and say around 36% or 36% energy with somewhere between 30 joules, 30 millijoules. So it gives you a fluence of 6.7 joules per square centimeter. Now, once I put it in a ready mode and see how beautifully it is ablating. So can you see this, sir?
Please focus closely on the spot.
So this is the pattern it has generated.
Okay.
The center is clear, and there are rings at the margin. So actually, you are just treating, even though it says it is, you are choosing 30%. This is very, very patient friendly with absolutely no or very little downtime with this. There will be a faint erythema lasting for 24 hours and maybe a bronzing for another 2 to 3 days. So when you choose mid level and a percentage coverage of around 25% and the same energy, and you make the machine ready and you fire it.
40 seconds left.
So again, the beam pattern is totally different.
You can see that, please? The fusion one.
Focus, please.
Can you see this, sir?
Zoom in.
Little zoom out, please. Zoom out.
And I'll show you the fusion mode. The fusion mode is again, it's very, very interesting mode where you can have a mid and deep rejuvenation at the same time. So this is a mid, if you see care, I'm not very sure whether you be able to see it or not, but this is a zoom fusion mode where you have a central deep penetration and a peripheral zone of superficial ablation or a mid-level ablation. So this is what actually this machine does. You have a full liberty to tailor-made your system, and this is generally, as against all the CO2s, the energies are delivered in one single pulse without stacking and anything. And now if I go to the ablation mode, the full face resurfacing classic mode, it is again with the same handpiece and very, very easy and effective thing. So this can be used as an ablation for various laser procedures. So if you see, it produces a fractional based ablation, which is especially helpful for dermatosurgery and resurfacing. So
Okay, thank you very much, Dr. Swapnil. Quickly, 3 points which make this machine to stand.
Yeah, so the 3 points which make the machine has an immensely powerful system of 60 watt of RF excited tube, which will give you a digitally controlled super pulse, which is as same as an ultra pulse system. It is not like the ultra pulse which is available with Korean machines where you have a power of 5 joules or 5 watt or 6 watt, which is available at that mode. This machine has a 60 watt power always available to you at whatever mode. Secondly, it has a very different fractional pattern, the ring fractional, which is very, very safe and effective. And thirdly, the fusion mode, which is actually you are treating the different level in one single shot. So you have a deep ablation as well as mid or superficial ablation in one single shot. So additional passes, additional treatments are not required when you are using this. The scanner is inside the machine. That there will not be any fatigue, operator fatigue while using this.
We move on to the next technology, Milesman diode, being demonstrated by Dr. Karthik Raja. Thank you so much. Dr. Karthik, yes, please. Yes, please go ahead. Yeah, please.
Yes, okay. Right. I'm Dr. Karthik from Chennai. I'm here to demonstrate, I would rather say, defend my choice of buying this machine. I bought this machine about 1.5 years back, and it has been in workhorse, and it has been making me moolah for this past 1.5 years. So that's all the introduction. Let me go about the technology. The technology is the first and the only 4 wavelength FDA approved machine in the world, I guess. It's from Spain. The four wavelengths are 755, 810, and 960 and 1064. All four wavelengths are available, which can target the hair in from top to bottom in all the lengths. So finer hairs can also be targeted. The normal regular hairs can also be targeted. The bulge can also be targeted, and the deeper and thicker hairs, even for the pilonidal sinus, can also be targeted with the same machine. So one machine targets hair. For any dermatologist, the first laser machine to buy is hair removal laser, because that is the one thing which we cannot give any other option. We have to go with the laser diode. So this is my choice, because I have tried other machines, and this has all four wavelength, and the tip is giving a cooling of -9 degrees Celsius. I have personally tested the temperature also. A -9 degrees Celsius is not achievable in any other machines. So this -9 degrees Celsius is making the patient very comfortable, and it is making it very painless. My sister has underwent laser removal with 1064 in other places with NDX. She was feeling very painful, and she was reluctant to go back again. And she is the first patient with whom I was tried this laser, and she was very happy with it. And she was like, "Oh no, no pain." So that is the one of the main reason that why I bought this machine. I think the spot size is 1:1. That is one giveaway, because it is very small size. So we have to do it for a longer duration in if the area is longer. If you want to go for full body hair removal, it's take about 1.5 hours. That is the thing that is happening. And the other thing, what I will say, the drawback is you don't have very small spot size to probe that attachment that you get, for the hair in the ear, or eyebrow correction. Those things we are not able to do with this machine. These are the two drawbacks I will say. Apart from that, for any other indication in hair removal, we can use it. And I have noticed one thing for a axillary hair removal, the patient having axillary pigmentation, while doing the hair removal, the pigmentation is also going away. I think it's because of 1064. I think that is happening. That's all about the technology. I'll just show a quick demo about
quickly to the machine.
Yeah, the machine, it has very simple settings. The advanced will have, you can set around your parameters. The preset have, you have to switch about you can choose the skin color, Fitzpatrick skin type 1, 2, 3, 4, 5, 6. You choose a skin type and choose the hair color, and it will give a preset. And the hair coarseness, you will have a preset settings. You can play around even with the preset settings, 1 or 2 joules up and down, and a little bit milliseconds and still as heads, and you can start firing away right away. And you can see the tip, -9 degrees Celsius is, you can literally see it. It's frozen right now. Okay, and literally if I demo, no, even without shaving the hair, I have tried. I will not recommend anyone to do that. But even if without the gel, even without the shaving, if you do, much pain will not be there, but it may burn. The pain will not be there, because the heat is already delivered, but the pain won't be there. But the skin will burn if you do it without shaving or without the gel, because of the cooling. See, there is hair. We didn't remove the hair. I can do it. You can see that he won't even be able to know what hit him. Okay, so that is one thing. And the maximum energy is, we can go up to 30 joules. 30 joules, and the power wattage is 20 wattage.
And minimum pulse width?
Minimum pulse width we can go to 8 pulse width.
8?
Yes, 8 milliseconds in the lower fluence. If the fluence is getting more, then definitely the pulse width is about 40. I think in 30 joules, the pulse width is 40. The minimum pulse width is 40.
So the probe you're using, it has got 4 wavelengths together to best of our understanding.
Yes, all.
And what is the percentage?
All equally distributed, 25% each.
25% each. So there is no diode higher than the others.
No, nothing is higher than the others.
So is this platform available with other handpieces also alone?
No, one single handpiece, one single machine. It's very simple.
Is it come with other handpieces also?
No.
810? No.
No.
It only comes with 4.
Yes, there is single wavelength machine available with them. They have 810 hand wavelength machine, separate machine available, and 1064 machine separately available.
But not with this platform. Not with this platform. Okay. So given you a choice among 4 and 1.
Yes, sir.
Which is your favorite?
Definitely 4, sir.
Which one?
4 wavelength. Definitely 4 wavelength.
Definitely 4-1. Why so?
Sir, we have to think about the future, and we need to market the machine also.
Okay.
Patients are very, they are Google savvy. They are going to search. They will come and ask us 3 wavelength, 4 wavelength. Do you have the latest machine? What is the technology? How am I going to, why should I come to you? Those questions they will definitely ask. So that way we can definitely say it is 4 wavelength, and it targets the fine hairs also in the same session. So And unlike in single wavelength machines, if you do one session with the 810 and then after, if they come for fine hair, then we have to go for the 755 session and another session separately. But this machine, at any single session, it is going to target all different types of hair follicles in the single session. So that way, the number of sessions comes down. Instead of going for 10 or 12 sessions, 8 sessions or 6 sessions will be enough.
So we have invested on 2 dual and triple, and now 4 are there.
Yes, sir.
So would you think it makes sense for youngsters to go for 4 lasers together, or they should go for one standard diode first?
Sir, iPhone 10 or iPhone 13.
iPhone
10 or iPhone 13.
Okay.
Simple as that. Latest machine. It will, another 4 or 5 years, it will be still latest.
All right.
If I go for the single machine, and one more thing I can tell is, it is easily portable. I carry it to my.
So this was my next question. Actually, you answered it very well.
Yeah, it's easily portable. So easily
Karthik, could you explain once again why did you do it without shaving the hair? Because we believe that shaving is extremely important.
Yes, sir. It is very, very important. Even if without shaving, if he won't feel the pain, but the burns will be there. It will burn, but the pain won't be there. Just to demonstrate, the pain will not be there. They did it for the volunteer. Otherwise, we have to shave. The burn marks will be there if you don't shave.
Okay, so you said it is FDA approved. I heard it right.
Yes, sir. Yes, sir.
I heard it right. Yeah?
Yes, sir. Yes,
okay.
sir.
Interesting.
Thank you.
The first and the only machine with 4 wavelength and the FDA approval.
All right.
Okay. Any questions from the audience?
There's one more question, Dr.
Yes,
Karthik. It is about recovery of reflection light. This is what is they are patronizing. So
Yes,
what
sir.
exactly is that?
Yes, sir. They have 2 technologies in it. The VC cell technology. What happens is, when the laser comes through the machine, it reflects in the sides and they will crisscross each other and it will have a tack effect. Which means in other machines, the central part of the laser delivered area will have more energy than the lateral part of the area. In this machine, the energy goes straight. It will not, crisscross in the skin level. So that is one another advantage with this machine. And when the laser light goes in, attacks the skin, and if it reflects back, the tip is having a mirror kind of effect. So it will just reflect it back inside, rather than receiving it and putting it in the cross in the sides.
So instead of 85%, it's 100% delivery.
Yes, 100% is delivered inside the skin.
Okay, thank
Dr.
you.
Ganju, over to you.
Yeah, we'll pass on. Thank you very much, Dr. Karthik, for that wonderful presentation. We'll go to Dr. Madhuri, who talks about Selena MNRF. Dr. Madhuri, can you come in, please? Yeah.
Can you hear me, sir?
Yes, please. Please go ahead.
Hi, Dr. Madhuri.
Hi, Dr. Anuj. Thank you so much for having me, Dr. Sahil and Primelace. So I will be talking about Selena PR, a 6 workstation machine. I recently got it few months ago. So why I got into this is it has 6 applications. You have your conventional microneedling, then you have your conventional, sublative RF. So what's new? Why would I want to go for this machine is it has an intradermal radio frequency or subsession radio frequency, which is what I've been following for few years. And I wanted to look into this technology. And what I understand, maybe I'm wrong, this is the only machine in India which has this application.
Agreed.
Then it has an RF.
Hello. We can see you, Dr. Madhuri. Can you hear us? Yes, we can hear you.
So intradermal radio frequency, basically this was just to announce the machine, we had this power off, so everybody goes with that. And then we have the RF pen, which is again a useful tool in our practice, and obviously the all favorite vaginal rejuvenation. So while we all have heard with a lot of speakers talking about microneedling RF, about sublative RF, I'm going to be talking about intradermal RF a little bit because that's my favorite and I've been using it, in a lot of my patients with gratifying results. So what are the indications of intradermal RF? Or first, what is intradermal RF or intradermal radio frequency? So I'm going to show you in the machine. As you can see, this is the older model. In the new model, you have all the 6 applications at a go. And this is the intradermal radio frequency RF1. Now, what you mean by intradermal radio frequency? We as dermatologists in our medical school have been doing the conventional subcision always. So we are very expert at it. But there are times we struggle, and there's always this complication of hematoma, pain, discomfort to the patient, the healing time, and also the rejuvenation is not great. And sometimes you need multiple sessions. So with this, we are combining 2 things which we love: your subcision and your radio frequency. When both come together, you have a workhorse. So you can smoothly go in the deepest and ugliest of scars, and definitely subside it very smoothly. And then also you get a wonderful rejuvenation in terms of textural improvement. So in 3 sessions, which are done once a month apart, we see a phenomenal result. In fact, after the first sessions, I have patients coming back and wanting to do this. So I'm going to show, I have marked this patient. Since I'm short on time, we have the primary stall, so you can come back to them or me for more details. So we have cannulas in this. You have the 21 gauge cannula, the 23 gauge cannula, and this is the 19 gauge cannula. This is for the body, for stretch marks and other indications if you want to do. So commonly these are used for the face, the 21 gauge and the 23. 21 is mainly used for bigger areas like your cheeks, your jawline, your neck area lines which are marked. And 23 is mainly used for your smaller areas like your nasolabial, your marionette lines. I've done them, and also your under eye area, the bags under the eye. So forehead also is recommended, but I like doing my sublative RF, which is again part of this machine. I find it more comfortable, and the patients are more, they love it better. So what we do in the subcision RF is we first obviously, mark. I measure the length of the cannula, which is 21 gauge. Sorry. Okay. Before I go into that, I forgot to tell you, it is a monopolar RF. So it has an earthing plate connected to the patient out here, as you can see. And then I take my cannula and then I mark. So I generally try to pick a point which is easy for me to rotate in several directions. So if you can see, I've marked this point because from this I can go all across to here, posteriorly, medially, anteriorly. So I get a full 360 degree at one point with less discomfort to the patient. So before I get into the procedure, obviously, I also need to apply anesthetic cream because patient is anxious. And the other beauty about this machine is this cannula has a point out here wherein you can fit in your 5 ml or 2 ml syringe containing your anesthesia, which is your lidocaine with adrenaline. So you make an entry point with 18 number and then just push your needle in and start infiltrating the anesthesia. The patient immediately gets numb, and then just keep on subsiding with your radio frequency. So you get a very clear experience as a physician because it's very easy for you to do. You can use multiple techniques with this. You can do tunneling. You can just do linear threading if you're doing nasolabial. You can also do superficial and deep dermal areas very easily and comfortably. Obviously, there would be some downtime because you've infiltrated the area. So there would be some swelling, there would be an edema, there would be some soreness, which is there for barely 5-7 days. I have patients who have great pain tolerance whom I know. I put very little anesthesia and that helps with recovery of the downtime. The machine per se does not have a downtime. The infiltration has a downtime. So this is a little bit about intradermal RF. The other point is this machine has the benefit of both bipolar RF as well as your monopolar RF, which I don't think again many machines have that advantage. And the RF pen is the other device which I use, which you can use for spider veins, because I get a lot of these patients coming with the neck veins at after a certain age. The leg veins, I get a lot of girls. I'm in Mumbai, so I get a lot of girls, models, and even older ladies with these breakout. Then this becomes a wonderful tool because in 1 or 2 sessions, you can really ablate, with this fine tip. We just touch the area and it actually vanishes. So I was thinking of sclerotherapy, but I find this a better tool for my patients. So this is a little bit about the machine. This is the RF pen where you attach your,
1 minute left, Dr. Mathri, sorry.
Yeah. And quickly, the conventional microneedling RF, which is again bipolar. And then you have your sublative RF, which is again bipolar. So I use a combination of both when I'm doing intradermal radio frequency, or even if I'm doing the conventional microneedling, I do this along with my sublative. And again, when you have intensity levels here, so when you're at a lower intensity level, like 3 or 4, you're doing more of rejuvenation. When you go higher, you start ablating. So this is how I utilize my machine in various ways.
Quick one, insulated needles or non-insulated needles?
Both. It has both.
It has both insulated and non-insulated.
Yes, it has both.
So the like other things were very interesting, that vaginal tightening probe, and that a single electrode. Have you ever used an active acne? Single electrode, active acne.
Active acne, I have used this one. You can just use a 33 gauge.
Okay.
Go and pierce the needle and quickly deliver the RF.
Okay.
You can do multiple active acne. You can do a single active acne very easily.
So it's the same which you can use for the thread veins, also facial veins.
Yes.
And subcision also for the individual scars. No, individual scar subcision.
No. So for scar subcision, so the cannular lengths are different.
Dr. Mathuri, when the scars are like very few in number, this like single electrode is very handy. You go underneath the scar, just press and come back. It's insulated most likely there.
Yes. And one more question previous speaker had about fat double chin treatment
Yeah,
and microneedling. I think you'd asked. I do a lot of microneedling for jawline contouring, and it is really gratifying. Only thing is you have to step up your intensity and energy levels.
Depth,
obviously.
So which depth you choose for the submental fat?
Submental is generally 3 because that is what you need. If I or 2.5, I don't go less than that because
But 2.5 you will stay in dermis only. Don't you think it should be beyond 3 mm?
So 2.5 is for patients who are very thin skinned.
Okay.
And little thicker skin 3 because this has 3 mm is the maximum it can go to.
Okay.
So one more thing before I go, the vaginal probe, we recently started using it as a rejuvenation for the face.
Oh.
Non-ablative. That is giving beautiful results. You should try this out also.
That's interesting.
Yes.
That's interesting.
Yes.
Last one only, have you ever tried your single electrode on the infraorbital fat?
Yes, absolutely. I have tried. Done.
So it's something like which is always challenging for the dermatologist to treat. So we have to refer to the blepharoplasty.
So 23 gauge is what I tried. If you can see, I mark both infra and supraorbital areas.
Okay.
So it gives a little bit of lid tightening if you do it. And also the infraorbital, it obviously cannot make your fat disappear, but it gives a nice tightening effect.
So it's a very good take home for the audience. Yeah. Thank you very much, Dr. Mathuri. Thank you so very much. Yeah. So we move to Dr. Ganju sir now. Dr. Ganju, are you around?
Am I audible?
You are audible but not visible right now, sir.
Yes, camera on karo ji.
Okay, please go ahead, sir. So some power failure.
यार यहाँ मशीन ही उड़ जाएगी क्या है चंडीगढ़ का बड़ा बुरा हाल है।
So you are visible but not audible right now.
Okay, I'll be just audible.
Yes, please go ahead, sir.
Okay, friends, good evening. So I've talked about the diode lasers for LHR, and I'm going to demonstrate now this machine from Alma, which is a triple wavelength. So the Alma has been a pioneer in LHR systems. They have evolved from the single 810 nanometer stamping mode to in-motion technology. In fact, in-motion was the first time brought in by Alma. And then they evolved into multiple wavelengths. And this is a triple wavelength called platinum. This is a very useful machine. I already told you using multiple wavelengths has several advantages, as we have seen in earlier machines also. One advantage is penetrating to different depths. So you can treat hairs of at all depths, hairs of different, thicknesses and different pigments can be treated at the same time. And also the combination takes care of, not only the targeting the melanin as a chromophore, but also targeting the water around the hair follicle. And this produces diffuse heating. And this leads to a better, volumetric heating of the area and better treatment of the hair. And then the in-motion technology that we have in this makes things easier for the patient, less pain, and better for the physician, because you can go faster and cover large areas at the same time. Also, this machine has a large spot size of 20 square centimeters. That also gives you an advantage of treating large areas all over the body at a very small period of time or in a short period of time. This machine also provides you with specialized spots like this one. This is a very specialized spot which helps you treat very small areas like the eyebrows or sensitive areas, or within the ears if you want to do laser hair removal. So this is a huge advantage also. So friends, let's go to the machine. The machine, as I told you, is a triple wavelength, and it has a stamping mode, which is shown here, the HR mode. So if you go to the stamping mode, you'll directly get 2 or 3 parameters. One is the total fluence that you would use. Usually we start at around 18 to 20 joules, and if the patient is comfortable, we can go up to about 30, 32 joules also, depending upon the tolerability and the response of the patient. So we give a few shots of the laser and then see whether perifollicular edema or the erythema develops, and the pain also. Patient's tolerability is also important. And then we decide what we have to give. And then we have the frequency 1. This is the frequency 1, 2, or 3 shots per second you can shoot. So you also have an option of selecting a light or a dark skin. So if you select light skin, you will have milder parameters, more aggressive parameters. And in darker skin, you will have lighter, milder parameters. So in addition to this, we have the other mode, which is the SHR mode, or the in-motion technology, which is the one which is superior in this, or which was brought in first by the ALMA. It's a very useful technology where you can use large areas at the same time. When you go to the SHR mode, you have you can select the area which you have to do. For example, in this patient, we are doing the arm. And once you go to, you have selected that arm, then it will give you preset parameters of using a 300 square centimeter grid, delivering about 8 kilojoules at this fluence. Fluence means number of shots per second. So you can increase the fluence or decrease the fluence, and that will increase or decrease the time taken to deliver the total energy. But if it is very painful, then you have to give a lesser fluence. Normally, we divide the area, the treating area, into grids. So they have given us these stencils to mark out the grids. For example, if you have to do large areas, there's a 150 square centimeter grid which you can mark over the body. For a smaller area like we are doing on the arm here, so we have marked a smaller grid. This is 100 square centimeters, but this is smaller than that. So the company recommends delivering about 8 kilojoules for a 100 square centimeter area and about 12 kilojoules for a 150 square centimeter area. So once you have delivered that much of energy, you do that continuously as you move. And once you have delivered, the machine stops on its own. Important also is that this has a sapphire cooling tip, which brings down the temperature to -4. That makes the procedure quite comfortable and without any side effects. So I'll quickly demonstrate the procedure. As I told you, we are going to deliver about 8 kilojoules. We have about 100 square centimeters, and this is going to take 57 seconds to deliver. So my machine is ready. You can see that the sign here is showing in a blue star, which means that the cooling tip is working properly. So as with other in-motion technologies, you pre-cool the area. You pass on this the tip over the area to be treated for some time, and that cools down the area. That's very important. So pre-cooling is important. That makes the process or procedure easier for the patient and comfortable for the patient, and then you start shooting. So you have to, is it painful? Are you feeling the heat? So you have to ask the patient whether the patient is feeling the heat. If the patient is not feeling heat at all, you can increase the fluence. And you go on as you keep on delivering the energy. When you have delivered the total energy of 8 kilojoules in the area pre-decided grid,
the machine will automatically stop and you would have delivered the energy by then. अभी कैसा है? गर्म तो नहीं लग रहा? थोड़ा सा. You can be honest, don't worry. If it is very painful, please raise your hand. We are about to finish, about 10 more seconds to go. Okay, we are done. Can you focus on this?
So it's a to and fro motion. You also prefer giving circular motion also, sir?
Pardon?
You gave to and fro, so you also prefer giving circular motions.
I don't think it makes a difference. The idea is spreading the energy evenly all over the area and not skipping areas. So this doesn't typically produce a perifollicular edema in most of the instances. It may if the hair are very thick, but you can see diffuse erythema developing if you can make out.
So percentage of wavelengths in this device?
This is equal percentages of 3 wavelengths.
Is it 33, 33 or 50, 25, 25?
No, 33, 33, 33.
Okay. And maximum power of this device?
And it's important also.
Can we see you also, sir?
It's also, yeah, mere pe focus kare. It is also important to know that this is a very high energy output machine. It delivers 2400 watts. It has 12 bars of these semiconductors, 3 bars of each for each wavelength. Sorry, 4 bars for each wavelength. So 4 bars for 755, 4 bars for 810, 4 bars for 1064. So this is one of the strongest output that we get out of a diode laser.
Okay. So another question coming to you. Triple wavelength versus dual versus 4 versus 1. Your choice.
Okay. This is a common question for all these LHR machines that are being demonstrated. You are asking.
Yeah.
You see, I am working with a single wavelength as on now. I plan to graduate to a triple wavelength because I see that most of the people who are using triple wavelengths are happy with them. Some of the patients who are not doing well with single wavelengths have started responding to triple wavelengths. And there's a definite science that goes into it, which says that if you use a triple wavelength, you have definite advantages. So I would prefer this. I would want to graduate to this.
I think my personal viewpoint, I have got diode also, Alex in triple also. So what I believe that diode is diode, it is gold standard, should be gold standard for Indian skin. And most of these devices, the limitation is that they come with only triple, only dual, or only 4. They come up with the probes. You can have a choice of individual wavelength and combination wavelength also, so that we need not to buy 2-3 devices for the same purpose.
I understand that when you are highly professional, then this is more of a syndromic approach.
Yeah.
This is more of a syndromic approach. So you have one device for all kinds of hairs. But yes, if you have standalone wavelengths, then you have the luxury of playing around with each wavelength. As a professional, you would definitely give better results with each wavelength separately in a different patient.
Yeah, because most of the individuals, they are, most of the youngsters here, they're confused whether they should go for the individual wavelength or the, combination wavelength. That's a question which every youngster asks me.
You see, I think to be on the safer side and to get a good outcome out of all the wavelengths, giving them together would be a good choice, particularly for people who are not into highly specialized laser training like you are, or people who have been into lasers for many years. So as they graduate, understand physics, etc., then they may go to individual wavelengths. But this is a good option to start with because you're going to get better results with.
Thank you very much, sir. And give a smile. I will take your picture now. Excellent. Thank you so very much. Now we move to Dr. Malvika.
So we have a very new device, first time in India, a very new technology, that is Mira Peel. Can we have the teaser, please?
Now we have Sahil with the cake again.
So I would request Dr. Anuj Paul and Dr. Anurag Tiwari, and I'll invite Mr. Bharat on stage for the cake cutting.
Sahil, you come here, please. You cut this cake again. Thank you. Thank you. Thank you. Can we go to the workstation now?
Now, can we go to the
Switch.
workstation?
Hello, Dr. Malvika, how are you? Yeah, we can't hear you. We can't hear you, ma'am.
You need
Just
to pull the
adjust your
mic
mic,
up.
please, ma'am.
You need to pull the mic up a little bit. उसका sound बढ़ा दो. Nope.
Still.
Nope. Nope.
Switch on the mic for workstation 1.
No, nothing now.
Audio from workstation 1, Mr. Jatin, please check.
Is that good? Is this good?
Yes, ma'am. Ma'am, please speak up.
Is this good now? Can you hear me?
Yeah, we can hear you, ma'am.
Yes, ma'am.
Okay, wonderful. Thank you, Dr. Anil Ganju and Dr. Anuj, for this opportunity to, with great pleasure, to introduce Mira Peel to the aesthetic world.
Can we have a huge round of applause?
This has been brought to us by Leader Health Medical Systems, and this is what the machine looks like. I think we had some great introductory music. It almost got me dancing, but so will this machine. It's a very interesting machine, and while a lot of the other machines that we have, which have infusions and exfoliation work on skin health, Mira Peel, which is a German technology and was waiting to be launched, but because of COVID couldn't be, is now incorporating more of a whole medical line of facials that spans all age groups. It also spans a lot of indications, men and women alike, and it sort of bridges a gap between skin health and actual medical conditions. So it has a good span. What does really the Mira Peel do? It works through, as you can see over here on this LED screen, it has a LED mode, a hydra abrasion mode, a microcurrent mode, a cupping mode, and the diamond or lymphatic drainage mode. But really the four that one uses mostly are the first four. Now, what does it really do? When you talk about cupping, it has a lymphatic drainage, which is done by this probe over here. So it's got a set of probes. This is the front of it, and this is the side of it where all the probes are attached. And this is for lymphatic drainage. It can be done for body. It can be done for face as well. And for the face, you have smaller probes. And then you also have the tiny probe for perioral and periorbital lymphatic drainage. So that's really nice because lymphatic drainage is really trending now. And a lot of patients ask for it. And it's also very nice to decongest the face, take away edema, And especially before an event, a party, or in general, patients also with congested skin like rosacea also really enjoy these kind of lymphatic drainages. So this is the cupping, which helps. This is the cupping mode, and it has different levels. You have P2, you have P3. It can be pretty strong in the kind of suction it would have. And here's a little, this is the technique with which you use the cupping mode, and you can increase the intensity of the vacuum. You can also have, so there are different modalities by which you can adjust the degree of lymphatic drainage you wish to have. And then you have the second, which is exfoliation. That is done by the hydra abrasion mode, and that is this handle over electrode over here, this holder. And what's very interesting is that it's got this very interesting tip out here. Now the center of the tip has got actually an abrasive surface, and it has these little channels over here where you fill certain serums inside, and then you adjust. So we go to the, and you start it. You have certain settings over here. If you start it, you can adjust the power, and you can therefore adjust the flow of the serum and the movement. It's got a slight hissing sound. Hissing sound is the delivery of the serums through a suction mode again. So there's abrasion and suction, and during that time, the serums are infusing. So this is really how the world today is moving to, exfoliate deeper as well as hydrate at the same time. And so this is a single use for a single patient. It has an inbuilt cost into it, and the whole consumable cost for one treatment has been planned and calculated. But there are some additional costs which I'll tell you. But this all comes within the cost of the treatment. Now, this would be the hydroabrasion mode. And then comes the next one, which is the micro-channeling. Again, a very interesting mode. And the micro-challenging is here. And here you have another roller. This is a roller with tiny needles from 2.5 mm, 5 mm, 7.5 mm, and 1. So these are the various, there's a roller, and you can adjust the, goes back here. Again, you can adjust what you want depending on the thickness of the skin and the indication. So if you have scars, you may go up to 1, but if you want to rejuvenate the perioral and periorbital area, you can even use the tinier needles. And while you're using them, once again, you're infusing, you remove this, and you have to attach this to it. Again, single use for the patient. And then you have to start the machine. And once again, you'll be rolling, and the serums which are filled over here will pass through. We'll talk about the serums and what they do. So this is the third one. And what's unique about it is that you have, for the first time, a Mira roller, as they call it, in a medifacial machine. And then you come to the next one, which is the microcurrents. Again, very unique is the microcurrent because, and this is the probe. It has to be placed over muscles. A very long time ago, early in my practice, maybe even up to 18, 20 years ago, I used to have a microcurrent machine. And what it does is it stimulates the muscles, facial muscles. So it helps in the muscles to get recall. And because the muscles get recall, it will help in firming and tightening. It will help also in static lines. It will also help in softening out wear and tear in areas of high movement, like facial areas around the perioral area, etc. So this also can be adjusted according to different modes, different energy levels. All that, there's a standard chart that can be followed. So this is what is different in this machine, is this microcurrent. And I can tell you patients love it. You know how patients love face yoga? And what are they doing? They're stimulating their muscles. So this is a machine which, after all these steps, if you also stimulate the muscles, gives a very nice tight, firm look. So to the skin. And usually the prototype is to do these treatments once every month, especially in patients above the age of 40, 45, going into 50. Really like it, and they love to come back. Now we have another mode, which is the LED light. And with the LED light, you have 3 types of lights: red, green, and blue. So if you have the red light, started very strong. So you have the red light, then you have the green light. So the red light is for collagen stimulation. So the blue light here is for week. We do it twice a week in our patients. I have an LED light in the clinic, or you can do it once a week as part of your acne treatment protocol. The green light is there for stimulation and rejuvenation, and the red light is for collagen stimulation. Again, you can increase the intensity, you can decrease the intensity. There are certain modes. All of these are planned, and sometimes change between all these light modes. So that is another interesting feature inbuilt into it. Patients love all these lights, and the overall effect is that the skin feels very, very firm, plumped up, tightened, refreshed. Let's talk about, we've talked about all the hand pieces. Let's talk about the serums out here. So there are 4 serums. Each comes in a 125 ml bottle. And per treatment, you will use about 40 ml of any one serum. Oops. 40 ml of any one serum will be used during a treatment. Now you have to customize, mix and match. So the first serum out here is the Gentle Restoring Exfoliator, which has salicylic acid in it. So it's good during the exfoliative process, which is a hydrodermabrasion process. You fill up the handpiece with the serum, and then it's delivered through the earlier probe that I showed you, which was this probe. Okay, so it comes out through this. Now, if you wish to rejuvenate the skin, then is the active regenerating detoxifier, and this one has got vitamin C antioxidants, as well as has some botanical extracts, and is great also. You can use it through the same handpiece, but you can also use it when you want to rejuvenate the skin. And then you have third one, which is a deep skin clear up moisturizer nourisher. So got a brightening complex of kojic acid, arbutin, and encapsulated vitamin C and E. And this one we really should be using for brightening the skin and improves the tone, the texture, some tan, as well as a little bit of early photo damage. And this one is the vitamin complex moisturizer, which is really for dehydrated skin, which has hyaluronic acid and panthenol. So you can either do only one of the serums, or you can do one followed by the other. Depends on the indication that the patient comes for, whether it's for pigmentation, fine lines and wrinkles, or whether it's a younger patient coming for an exfoliation. Then you can do the exfoliation, you can do the lights, and that will help to deactivate. If you have somebody who's coming for a hypertrophic, puffy face with a lot of sagging, then you can do all the modalities which I just enumerated in the sequence that we talked about, which was first cupping, that's lymphatic, then comes the hydrodermabrasion, then comes the micro channeling, and then comes the microcurrent, and then comes the LED last.
Okay,
These are the steps.
Dr. Malvika.
So this is it. Yes, I'm done.
Yeah, please.
And so something new to add to our armamentarium. And thank you very much. We already have these infusion and dermafrac and silk peel and so many of these machines. So this incorporates all of them in one. And with that, I sign off. Thank you.
Yeah, thank you very much. Only one question, ma'am. Estimated consumable per treatment, ma'am.
Yeah, I did ask them, and it is 1,800.
1,800
is the cost of a treatment without adding this probe. If you add this probe, this is 1,800 also. So then your treatment will be 3,600 if you add this probe, otherwise 1,800 to the doctor.
This probe is like we can't use on other patients, a single use probe?
No, it's
It's a single-use probe for a patient.
Okay.
All right. Okay. Thank you so
very
much,
much,
ma'am.
Dr. Malvika. We move on to the next. We have a wonderful presentation coming up with Dr. Swapnil Shah. Dr. Swapnil, the Pico revolution in Chandigarh and India.
So
Can we have
first
it?
time in Chandigarh, we have the Pico machine. It is first time in Tri-City. I congratulate Mr. Miswani for bringing in Pico machine to Chandigarh.
Hello.
Okay, Dr. Swapnil.
Yes, sir.
Please.
Welcome back.
Over
Welcome
to
back.
you, please.
Thank you.
This is your 5th now.
No, sir.
After that, you can take rest.
Okay.
Please carry on.
So I'll be demonstrating a Pico
care system from Wantech, Korea, and distributed in India by Akar Medical. So as we are evolving in laser technologies, Pico is the latest kid in the block. It's a very, very interesting system and very, very gentle and effective. So this is a Pico Care. Basically, it has a 1064 and 532 nanometer handpiece. This is a handpiece of Pico Care, which is an auto recognition handpiece. That means it's a zoom auto recognition handpiece with a spot size of 2 to 10 mm. And once you select 10 mm, the machine itself again select the 10 mm handpiece on the screen. So it's an auto recognition of handpiece. This is a zoom handpiece, which is used predominantly for Pico toning or the standard pigmentary conditions. Now it has another handpiece, which is what makes the Pico different from Q-switched laser, apart from the pulse width, is this is our MLA handpiece or diffractive, basically micro lens array or diffractive lens array, which is used for entirely different indication. So this is used for, this is basically a handpiece of 6, 8 and 10 mm, which is used for regeneration, the superficial pigmentation, and a little bit of fine wrinkling. And then they have another handpiece, which is basically 3 to 5 mm handpiece, MLA handpiece, which is used for acne scars. And believe me, I tried this machine in 2 to 3 months, and the results of acne scar are excellent. I mean, these are unbelievable results with acne scars with this MLA handpiece, basically because of the newer technologies of LIOBs, the laser-induced optical breakdowns, where the high energy of Pico is converted into the plasma inside the skin, and it breaks down the collagen to create intradermal or intraepidermal vacuoles, which heals by neocollagenosis. So without ablating the epidermis, you can get dermal restructuring with ablative dermal restructuring and a non-ablative regeneration of the epidermis. So this is very, very interesting, and this is an interesting future of non-ablative regeneration of skin. Coming to the machine per se, the machine has, the zoom handpiece has from 2 to 10 mm. The pulse duration is around 350 picoseconds. The peak power of this machine is 1.3 gigawatt, which is way ahead than a peak power of Q-switched Nd:YAG laser, which is generally in megawatts. So you have 1,000 times more peak power available to this machine. Now the machine has few presets. You have to choose whether you want to do an epidermal, dermal lesions or laser toning. Once you select the epidermal, these are the indications like H-spot, cafe au lait, freckles, lentiginous, seborrheic keratosis. Freckles can be treated with 532 and 1064. Once you choose 1064 and select the parameters, the machine wants you to choose the correct spot size, and the fluence is from 0.7 to 3.1 joules. So if you see, as against Q-switch laser view, where we required a lot of energy or fluence to treat these lesions, Pico, you required a very, very less fluence, less than almost 50% of what you required for Q-switched, because the pulse width is very less. And that increases the patient comfort and safety also, because you are using less fluence, so there are less chances of burns. Apart from these 3 handpieces, it also has 2 die handpieces with 595 and die handpiece with a fixed spots of 5 mm and 660 die handpiece, which is something similar to the RUI. You can use it for non-ablative regeneration vascular lesions, or you can use it for multicolored tattoos. The best part of this machine is it has also a collimated handpiece at 7 mm, which can be used in a paintbrush pattern for regeneration. So I never use this because this is a good indication. Coming to the other indications, where you can hang over here. So coming to the other indications where you can use it, this is the best device, undoubtedly the best device to treat tattoos. The number of sessions and the frequency of session is definitely reduced by almost 50%. You can treat it for treatment of OTA, tattoos, nail fungus, everything, and the laser toning where you can...
there's a reflection of the handpiece on the screen.
That is the problem, sir.
Can you move the handpiece away a little?
No, it's basically a fixed. We tried here, but this rod, the central rod is fixed and it is giving the
Okay.
reflection on screen because of the
Yes,
size.
that's making it a little, okay. Please go ahead.
Yes, sir. Yes, now it may be
Yes, yes. This is-
better.
No,
So-
now that is visible. Remove it.
Yes, sir. So the laser toning, you can use it either a pico toning with simple zoom handpieces, or you can use the MLA handpiece. MLA is micro lens array where the pico beam is split into various lenses, which is similar to a fractional laser. Now you can use MLA toning for pigment. MLA
Please
for
remove that paper sheet.
remove that. MLA for scars, bleaching, melasma, and so many things. So I demonstrate in short about toning on this patient. Choose an MLA toning. So if you see MLA, the fluence used is only 0.3 for 0.3 joules per square centimeter, 7 mm spot. So 7. So in a quick thing, this is a disconnector. You just have to disconnect the handpiece from the system and reconnect it with the MLA handpiece. MLA stands for micro lens array. Other name is for diffractive lens array, which is totally a new concept and a new skin reaction with this system. So I'm using, you just have to press OK. The goggles are must. So frequency is 8 mm and I have chose 0.3 joules, and I'll demonstrate. You have to, the machine will ask you to correct the spot size 7 mm, and as I move on, foot switch. In this patient, so yeah, so you can just do it in a simpler way. So it's very, very gentle, but it is extremely effective. There is no endpoint. You should not achieve any endpoints with these systems because this is subcellular selective photothermolysis. 3 passes perpendicular to each other.
20 seconds.
Yeah, that's what. I'll show you on the screen what exactly happened with an MLA handpiece. So if you can see, it is the beam pattern is exactly similar to the fractional handpiece. But point to remember is, since the machine has a very, very high peak power, the energy or endpoint achieved is very, very significant. And these LIOBs, laser-induced optical breakdown, is a new tissue reaction, which they found it extremely helpful in treatment of scars and wrinkles. Thank you, sir.
Okay, thank you very much.
One question, Dr. Swapnil.
Yeah,
Sir.
yeah, please.
Okay, like I mean, we are very much convinced with the Pico and like its advantages and all. So many youngsters are listening to you.
Sir.
Your call, like comparing Pico second as far as cost is concerned with Q switch and DIAG lasers, the standard Joe.
Yes, sir. This is a question often asked in practice. Now, let's say compare a Q switch with a Pico. For if you have a good tattoo practice, Pico wins hands down. There is no question about efficacy and safety of Pico in tattoos. You have a multicolored tattoo, single colored tattoo, professional tattoo. Pico is way to go for tattoos. There is no two things about it. If you come to the standard indications of Q switch like OTA, ITO, abnorms, I personally feel in my small experience, Pico has a similar efficacy as an Q switched NDR, but it is much less painful as compared to a Q switched NDR. So you can treat children very well with Pico because the pain factor is minimal in Pico. Now coming to the cost, definitely Pico is expensive than Q switched, but as I mentioned earlier, the MLA handpiece, which is a non-ablative fractional handpiece with an entirely new tissue reaction, which is very, very effective for management of scars and wrinkles. Now, if you compare the cost of Pico, and you have to remember that you are actually getting 2 lasers where you can treat the pigmentary condition, also the scars. So the cost of non-ablative fractional and Q switch is equal to Pico. So the cost is justified because it's a new technology and it is definitely an effective technology. We may not be ready for this, but sooner or later, everybody is going to go for Pico.
You're absolutely right, Dr. Swapnil, but just to add on that, Q switch has got that quasi long pulse mode also, the 300 microseconds.
Yes, sir.
So which gives good rejuvenation effect and even the pores and all.
Yes,
So,
sir. No. I am not talking about pores and everything. I am talking
rejuvenation.
about proper acne scars.
Proper acne scars.
Yes.
That's it. There is an advantage from
Yes,
this
sir.
signal.
Yes,
Okay.
sir. Proper scars.
Okay.
I'm talking about.
But it's very like good to hear that this machine can be used to treat acne scars also.
Yes, sir. And
Which is
I was a non-believer as so
me
many
too,
of
me
us.
too, me too, me too.
But I treated it and I found it is very effective. And the best part, you don't even need a topical anesthesia to treat acne scars.
Okay,
That makes it
that
very
is that is quite an interesting observation because you are a huge supporter of MNRF, Swapnil,
Yes, sir.
and
Yes,
you
sir.
saying that you are very happy with this.
Definitely,
That means
I have few photographs in next conference. I'll share that.
Wonderful.
But it definitely works good for
okay.
acne scars.
Thank you, Dr.
Thanks,
Swapnil.
thanks,
Thank you.
Dr. Swapnil. We come to the last demonstration of this session.
Thank you.
Dr. Malvika and Dr. Sudhavani tells us about the Hydra facial. Dr. Malvika and Dr. Sudha, are you there? Can you hear us, Dr. Malvika?
Yeah, I can hear you.
No, you are hearing me through the door.
I know. You can hear me too. You can't hear me?
We can hear you through the door, but I think
Can you hear me now?
yes. Please,
Now can you hear me?
we can hear you. Yes,
Okay,
we
great.
can see you, but
So-
not the Snickers.
Yeah, so I'm now back with all of you. As I was describing the other machine, I'm back with the other end of the spectrum, which is a machine called the Hydra Jet Facial Machine, and it's called the Hydrofacial Machine, and it is distributed by Spectra Medical Systems. And this is a machine that I have in my clinic. It's been a great add-on for skin health. So it again spans patients of all kinds, from younger to even older, only because it's very relaxing, it's non-invasive, non-intrusive, and it helps in also a lot of events and functions, and also in general to deliver good things to the skin. And so let's go through what all it does. So here is the screen, as you can see. And this is basically this is the top end model, which has its own inbuilt products. Okay, and it does to body work. It does the face. It has an LED light therapy, which is over here. Okay, so actually first step is to exfoliate, and this is the basic handpiece over here, and this does mechanical lymphatic. There's a lymphatic drainage also. Equipment, and this is the one which holds the patented vortex jet technology. And so this is the first tip which he attached, and that's the blue tip, and that does exfoliation. Then you have the next tip, which is the green tip, and the green tip is the one that will the teal tip, actually it's teal in color, and that is the one that does extractions. And then you have the last tip, which is the clear tip, and the clear tip is the one that helps with the infusion of the products. So you have exfoliation, you have infusion, okay? So and extraction. So what the patients really, that's really one of its important points. And these are the LED lights out here. And these LED lights, when you lift one up, these LED lights, again, there's a blue light and a red light. Blue light to deactivate bacteria. So very useful in patients of acne, rosacea in general, clarifies the skin, and the red light really helps in giving the skin a more tightening effect. So the open pores, etc., look better for even up to a week after the treatment. So patients are very happy with that. These are the inbuilt products. Okay, so the product is over here, is Active 4. And these are what I really like about them, and they're integrated into the machine. So once again, there's a no-touch, no-touch technique of using the products straight delivered into the jet. So that again really works well for patients, especially a certain class of patients who want a higher end facial or a skin health, medifacial or a skin health treatment. Again, they can come once a month for well, the actual protocol is once in 2 weeks for 3 turns, and then once a month for maintenance, or once in 2 months. The patient is younger for maintenance. They can come even once a month. Now, the Active 4 is for cleansing. The Beta HD main ingredient is salicylic acid. And then you've got the next product, which is glycol. And glycol is over here. There are 3 color-coded vials over here. Glycol is 7.5% glycolic acid and 7.5% salicylic acid. Very good for the extraction and process. And then there's a brightenol, which has arbutin, vitamin C, and berry extracts. Great for lightening any tan and dullness of the skin, dehydration. And Derma Builder has got peptides and hyaluronic acid, which can be used in the static lines as well as in wherever there is a bit of extra dryness of the skin. So these are the 3 modes we use. The glycol does produce a bit of erythema, so we may skip it in patients with sensitive skin. But these 2 products, the brightenol and Derma Builder, work very well in patients with sensitive skin. Everything is integrated on this platform. So, it really looks very neat and nice. And the last product, which is really nice, is the Antiox, and it contains antioxidants like green tea, arnica, red algae extract, hyaluronic acid. That's the finishing step. So after you do the 3 tips, you do the LED light, and then you end with the Antiox, and then you put the sunscreen, which also comes. There's a lovely green tea and sunscreen SPF 50 product that you finish. And then you tell the patient not to wash their face for about 4 hours because you've infused all the goodness into the skin. And then the patient can continue with their skincare products as before. There's no downtime, no problem with going out in the sun, and they continue with their own lifestyle. It's also great just before an event. So even say a day or 2 before any special event, this Hydrate Facial works very well in giving a quick pick-me-up. It's a great go-to medifacial in the clinic and fills in the plug for those patients who want a higher end treatment to their skins. So this is how we use it in our clinic. And we also combine, we sometimes alternate a peel or a laser treatment. 2 weeks will be at 2-week intervals with a hydrofacial. And so we do a peel or a laser, like a Q-switch. 2 weeks later, the hydrofacial. Then again, 2 weeks later, we can do the peel or laser or a microneedling. So it works very well also in, combining it with the more heavy duty laser and device treatments, and helps the skin in rejuvenating and recovering faster too. So all in all, it's the platinum hydrofacial protocol, and we have actually kept it in our clinic as Hydra Detox, Hydra Glow, and Hydra Glam. This is what we have done in our clinics. Detox is just the salicylic acid and the lights, and the Hydra Glow has the products because every product has a price to it. And so we use the Derma Builder and we use the brightenol. And if you have the LED lights, it becomes a Hydra Glam. So that's how we can give a little bit of price differential also and give the patient options. So the inbuilt cost, since you asked me last time also, to one treatment would be 1,000 rupees. And the tips are 100 rupees each. So again, a one-time use per patient. Every time the patient comes, you have to take a fresh tip. These all are disposable. So with that, I'd like to say that this is how we, machines like this, devices like this, which have this combined technology, fill in the spectrum. They complete the spectrum of not only the devices and injectables that you have, peels that we have, but also finishes the spectrum to cover even the feel-good factor that a lot of our patients come to us, apart from just the cosmeceutical products and the skincare that we give them. So I think
Okay.
I've said what I have to say. Is there any question?
Any questions from the audience? Okay, so consumables, you said just 1,000 rupees per patient plus the tip. What's the cost of the tip?
100 rupees.
100 rupees. Okay.
100 rupees per tip.
So
Okay, so since we have a little time, what is coming futuristically with this machine is an infusion treatment for the scalp. It's called Kera Wave, and it has peptides. And there we will have to use, and first you use the simple blue tip, okay? The blue tip for exfoliation. You attach it to the same handpiece, and you use it over the scalp to exfoliate. And then you can use the orange tip, which is an aggressive exfoliator, and you attach that to this, and you will then be able to deliver the peptides to the scalp but tiny micro pinpoint bleeding points will come up. So it'll save you of using a derma pen. And this is one of the treatments you can do it every week or every 2 weeks. And this would be a good add-on in your hair regrowth, hair loss practice for improving texture, for regrowth, and maybe patients who are scared of doing PRP. And you don't need to do any topical anesthesia before doing the Kera wave unless the patient is extremely sensitive.
How would
That
this
is
be
what is coming
different?
futuristically.
How would this be different from microneedling?
It would be different from
Scan.
microneedling because there is no needling.
There's no?
There are no needles over here.
Okay.
This vortex technology has a very strong suction and a very strong vacuum, which forces through the vortex technology. So it has a certain way in which it pushes the product into the skin or scalp. So when it's aggressive, the force is more. So it's like, how we had those mesotherapy guns versus the needleless mesotherapy back in the day, where it, through pressure, forces the product into the skin or scalp.
Okay.
So
thank you very much,
It will
Dr.
save you of needles and also help in needle phobic patients. And still you can deliver peptides for, your hair, your cohort of hair loss and hair rejuvenation patients.
Thank you very much, Dr.
Thank you, ma'am.
Malvika.
Thank you, Dr. Malvika.
I
Thank
thank the entire faculty for this session. It's been a really extensive session, learned so many things. Back to organizers, and thank you very much for giving us this opportunity.
Thank you, everyone. Thank you.
Thank you so much, Dr. Anil Ganju and Dr. Anuj Paul, for such an interactive session. Now we move on to peels and PRP, what's new and what's true. So I call upon the chairpersons, Dr. P.S. Valia, Dr. Vivek Malhotra, and Dr. Sumir Kumar.
Good evening, everyone. So after extensive session of this electric appliances, now come on to equally evolving and advancing techniques, that is chemical peel and PRP. Now I would like to invite Dr. Padmavati to speak on demystifying cocktail peel for pigmentation and acne.
Good evening, everyone. I want to thank the organizers first for giving me this opportunity and inviting me. After a very extensive and enlightening lecture on EBDs, now let us come to a very lightning and then very easy to start for the starters, the chemical peels. And in the market, we can see a lot of chemical peels coming up. The gel-based peels, liquid peels, and mono peels, combination peels, and all. So you may have a doubt like what to select and how to do in which indication and all. I want to introduce you one set of peels. This is a sponsored session by Spectra. So whenever you have a doubt like how to clear it, like on dot, so you will have a result. Means these two peels you can sell it. They're expensive, I can say, but you can see a definite result with these peels. If you are facing a difficulty in using any other modalities to clear acne or pigmentation. I'm talking about the mesoaesthetic peels. I'll cover two peels, acnelan peels and a cosmelan peel. Acnelan is meant for acne and cosmelan is for pigmentation. So because we have very less time, 10 minutes time to cover both, I'm not going to cover anything regarding the skin condition or the pathology or whatever. I'll just quickly go through the peels, the ingredients of the peels, and then how they act, and then the results. Coming to the acne, it's a high prevalence disease between 12 to 18 years. It can be familial or because of androgen excess, sequence of various triggers characterized by different type of lesions. It have a psychological and social impact on the quality of life. As we know the pathology, it is the testosterone, dihydrotestosterone and excess androgen, and then the blockage of the pores, and then acne formation and hyperkeratinization. These all we know. So classification, grade 1, grade 2 is grade 1 is comedones, grade 2 is papillopustular acne, and grade 3 is pustulonodular, grade 5 is nodulocystic. So we can give topical treatment till grade 2 and systemic treatment thereafter. And when it leaves a sequelae like acne scarring, we go with the surgical treatments. So these are different comedonal acne. These are grade 2 and grade 3 acne. So our therapy goal is medical patients, and what is the patient priority? If you see most of the patients, they come and they'll ask like, doctor, please give me only topicals or simple treatments. I don't want to go with the lasers. I don't want to go with the procedures. So our treatment goal should be to clear the acne and then avoid lesions and acne consequences, increase the patient's self-esteem, and recommendations are multifocal approach to the acne. Consistency in the treatment is what we require, because we know acne is not a single treatment. It goes on and on from teens to middle age. So that is one thing we have to insist on patients and start early so that we can prevent the sequelae. So acne patients' favorite treatment priorities: topicals, physical treatments, light treatments, isotonic and antibiotics. But I think 60 to 70% of the patients, they come and ask they want to try only with the topicals or a simple procedure. Okay, so when we give a topicals, it should be easy, it should be safe, it should be effective, affordable. Action should be rapid and without any pain. So coming to the acnelan solution. What is it? Acnelan is the most complete topical treatment for efficient, comfortable, quick, and affordable control of acne, manifestations, and also consequences. A cross-cutting approach to address the numerous factors that trigger the disease. This is a unique combination of active substances which can act on all stages of acne pathology. So the main component is a salicylic acid. As we know, salicylic acid is a keratolytic. It unclogs and cleanses the pores. It's anti-inflammatory, bacteriostatic, and it has a synergistic action, increases the degree of penetration of other comedolytic agents. Other important ingredient of this cocktail pill is the sodium lipargillate, which have an action on inhibition of 5-alpha reductase. It's bacteriostatic and anti-keratinizing activity. And we know mandelic acid, it's antiseptic, exfoliating action and bacteriostatic, and it's also a depigmenting agent. So efficacy and safety of mesoaesthetic acne complexes. It contains a complex, a unique innovative complex. In the ingredients are synergetic action like salicylic acid, mandelic, sodium lipargillate, and shikimic acid. In vitro study to evaluate the active properties of the ingredients in reducing blushing and tumefaction damage, in addition to the depigmenting effect. I don't want to go through the studies because we don't have that much time. Let me just go through this and then I'll demonstrate the peels. So the professional, it have a pack. I'll show you what are the ingredients. We have to do 3 sessions, once in 15 to 21 days interval. We can treat on face, chest, and back depending on the indication. So this pack contains these 3. One is the acnemelon multifactorial mask. It is a complex which contains all the ingredients that I already told you. Then it have a post-pill neutralizer, which is a sodium bicarbonate and aloe vera. And another tube, which is a pore sealing shield, which contains a zinc, aloe vera, and copper, which regulates the activity of the sebaceous glands. And aloe vera is for a soothing effect, and copper reduces the blushing and irritation and hyperpigmentation of the skin. So they have an home care treatment, this also, but it doesn't come with the pack. But you can ask them to supply the home care if you want to continue their own home care, or you can tailor your own home care ingredients. Home care, they have a purifying moisture. It is a cleanser. It contains urea and chlorhexidine. It cleanses and eliminates the impurities of the skin. And acne one is one pack. It contains bexaretinol complex, retinoid and cream exfoliant, and ceronia repens. It inhibits 5-alpha reductase. It is a cream exfoliant action, antibacterial, and reduces sebum. It is a daily use cream for maintenance. And the other one is a pure renewal mask. Again, this can be used weekly once for maintenance. And the home care treatment imperfection control is one more daily use cream. It contains the same complex, bexaretinol complex and enoxaline. So the contraindications are pregnancy, hypersensitivity. If the patient's skin is very dry because of oral isotretinoin, you have to avoid autoimmune diseases, radiotherapy, and recent dermatological surgeries, history of keloids, facial herpes, open wounds, acne with open wounds and infection, areas with micropigmentation, patients with an unstable psychological profile. Precautions before the treatment: at least 3 weeks prior to the treatment, do not perform any other professional peels. During the 5 days before the treatment, the patient must not use any abrasive or irritant substances. Like the patient is on retinols and all, ask them to stop. What to avoid after the treatment: swimming pool and sauna. Post treatment with retinoids, according to depending on the patient, how the skin is peeling, and after the skin calms down, only have to start using the retinoids. Depilation, wax, and any electricity treatment should be avoided for at least 15 days later. The treatment protocol is clean massage with purifying moss, and then the sensitive area, seal it with the Vaseline or mesolip protector. You have a jar like this Acnelan, if you can that jar. So you can stir it. It's in a 10 ml jar. 3 ml you have to apply in one session. Apply and keep it for 3 minutes, and then you can wash it off after 3 minutes. Once the exposure time is up, do a pseudo frosting because it has salicylic acid, and then use the post-peel neutralizing spray. Dry with an absorbent towel. Phase 3, you have to, that is the tube, which is the pore shielding, sealing shield. That again, you can use for 3 sessions. You can use 1/3 of it and seal the pores, and then you can apply a sun protection gel, and then you can send them home. So these are a few results. These are from the company. And the side effects, maximum time of exposure should not be more than 3 minutes. Monitoring possible side effects such as extensive irritation that can result in frosting process and post-inflammatory hyperpigmentation. Pay special attention to acne in inflammatory phase. These are the results before and 30 days after the treatment. This, I think, protocol we have already done. These are a few results. Let me just fast go through the Cosmelan peel also. I don't want to waste time on their studies and all. See, this is a Cosmelan peel. This is the treatment for pigmentation. This again, we know what are the types of pigmentation causes. I have only 4 seconds, so just let me show you. This is the Cosmelan pack. So it have like a cleanser, Cosmelan 1, which is the active peel. Cosmelan 2 is the home peel, home use cream, and then one moisturizer and a sun protection. So coming to the protocol, you have to cleanse it. This is a cleanser, and the ingredients, facial high concentration of active ingredients, focuses on renewal, skin renewal, eliminate the melanin. These are the studies. So what happens is it have a cleanser. You can see the blue bottle. You have to cleanse it properly. Then the Cosmelan one is the peel. Whatever peel you have in that, you have to apply layer by layer the total amount onto the skin, and ask the patient to keep it for 6 hours at least minimum or overnight, and then ask the patient to cleanse after going home. And then you can give this melanin recovery cream, which they apply morning and evening along with their skin protection. And then exfoliation will be a good 4 to 5 days, and there will be a good clearance of pigmentation. Then this Cosmelan too, they have to start using from after a week every night, or if they can apply morning and evening along with their sunscreen. Thank you.
Thank you, Dr. Padmavati. In fact, we are running quite late in our sessions, and it's a suggestion that the practical aspects they can be discussed during the hands-on training, hands-on sessions we have after the talks. And it will be great if the speakers can stick to their time, because we have to move on to the hands-on afterwards. And all the questions also, I'm sure they will be better answered during the hands-on sessions, and the faculty will be in a better position to take up those questions. Now I invite Dr. Neena Madnani. She will be speaking on peels for anti-aging and rejuvenation.
Thank you, chairpersons. Thank you, organizers, Dr. Sahil, Dr. Madhuri, for inviting me. And it's always a pleasure coming to Chandigarh. So when I got this talk, I assumed that all of y'all are doing peels. Are you all doing peels? Yes? Hands up who are doing peels? Oh, quite a small, only 5%. Okay, so I'm going to quickly run through what are anti-aging and rejuvenating peels, and Dr. Padmavati has made life very simple for me because she's also delved on certain aspects. I have no conflict of interest. We know that aging is a continuous process, and only 13% of it is due to the intrinsic effects. It's more the extraneous which causes our rapid aging, which is the pollution, your antioxidants, your lifestyles, etc. So why does an aging skin require help? Because over the years you develop pronunciation wrong, wrinkles, dyschromias, loss of vascular support, there's flushing of the skin, there's sebaceous hyperplasia, the skin looks yellow, patient develops seborrheic warts, DPNs, and eventually the Favre-Rapproché syndrome. So this is like one of the patients, so you can see the aging, you can see the yellowish skin, you can see the senile lentigens, and basically what you see is that the skin has become very dull, there's dyspigmentation, and there's blotchiness. This is another patient, again, you can see here, thick skin, yellowish skin, rough, there's no reflectivity of light, and skin looks terrible. So the current skin aging approaches are, we have to combine everything. So you have to do your topical therapies, you can do your chemical peels, you can do your invasive procedures, systemic agents. So it's like a cocktail, how you make an interesting dish. So we will be talking about chemical peels, but remember, it doesn't stand alone. You have to combine it with topical medicines, and you can also have to explain to them the lifestyles to get you optimum results. So chemical peels are actually a chemo exfoliation. They're very cost effective. They are done in every and should be done in every clinic. They have predictable levels of exfoliation, and they stimulate a cascade of cytokines and growth factors and skin remodeling. So we have various types of chemical peels, superficial, which go up to the epidermis, medium depth and deep. But in our skin types 4 to 6, which is the Indian type, we tend to stick to superficial peels and be experienced in that before you go on to the medium peels. This is a depth of chemical peels, and you have to protect certain delicate areas when you're doing the chemical peels. That is the angles of the eye and the angles of the nose, the angles of the mouth. These are important things where you put Vaseline. So the caveat is that all peels give rejuvenation. So whether you're doing a glycolic, salicylic, mandelic, whatever you do, it gives rejuvenation. And these are the chemical peels which are safe in our darker skins. And we tend to stick to 30 to 50% of glycolic acid And Dr. Padmavati has talked about how salicylic acid works. You can do a light TCA peel. Lactic acids give hydration. Retinols give you rejuvenation. You have so many peels which you can choose from. There are a lot of studies on glycolic acid, and these were the first peels which were produced. And there are a lot of studies. You can go back to the literature and see that they cause a lot of rejuvenation. They thicken the epidermis and the dermis, and they smoothen the skin. And there's a lot of connective tissue support. It's very important that we prime the people before you do peels, or you're going to burn them. Priming gives you a chance to know if a patient can tolerate your peel. They have to start using sunscreens. If you're doing a retinol peel, it's good to give them topical retinoids to use. If you're doing a glycolic acid peel, you can do mild glycolic acid. Now you get 3 to 5% applications. And you must give them protection against pigmentation. So they have to be on their pigmentation treatments. And you give them a home care regime. So if you see, as I said, any peel gives you rejuvenation. You can see after a couple of peels how the skin gets a nice glow and shine. So the anti-aging peels, which is my topic. So I'll cover up only a few peels, the vitamin C peels, retinol peels, ferulic, and the dermamelon, which Dr. Padmavati already covered. Vitamin C peels give you a very nice rejuvenation. And besides, so these are all cocktail peels. And finally, you wonder that what is the agent which is actually giving you the result? Because there'll be some vitamin C, there'll be some lactic acid, there'll be so many things. So we are really not sure what is giving you the peel, but this gives you a very nice rejuvenation. It's very mild, no burning happens. There is a delivery serum. So you mix a powder with the delivery serum, apply it on the skin, leave it on for 15 minutes to half an hour, and then rinse it off with water. Retinol peels are one of my favorite peels. They have a combination of things. They have retinol, lactic acid, salicylic acid. Then they have the ones which act as tyrosinase inhibitors, and there are botanicals which act as antioxidants. Ferulic acid peels are the other peels which are used as anti-aging because they have antioxidant effects. And they also have vitamin C, and these can be done every 15 days. And ferulic acid acts together with other antioxidants to make them more powerful, which is particularly effective against sun damage and UV light. This was an interesting article which talked about the use of azelaic and mandelic acid in older patients, and it caused an increase in hydration of the U area of the face. So this was a very interesting article. So all these combination peels which have kojic acid and arbutin tend to change color, and this looks dark when you put it on the patient. Dermalan peel is one of my favorite peels, and like Dr. Padmavati said, that it will give you guaranteed sort of results. I don't get any commission from them, but you can see how beautifully it works on the skin quality, the skin texture, and the reduction in the pigmentation. It does cause brisk peeling, and you have to have a home care. We were trained in a thing called herbal peels, where there are certain plant derivatives, and these are rubbed into the skin, and it's quite a discomfort when you're rubbing in because it feels almost like thorns are being rubbed into your skin. And after, you're supposed to leave it on and wash it off the next day, and then it causes a bit of exfoliation, and you can see the lovely rejuvenation which has happened in the fourth. Complications of peels. Whenever you're doing peels, please don't jump into it. Know your patient, look at the skin type, ask them what is their concern, evaluate the patient properly, ask them for a history of herpes because you can reactivate your herpes. If they are atopic and they have any dry areas, please do not peel on those areas because they'll get burnt. This was a patient who did threading on her face or waxing on her upper lip, and you can see how she's burnt on her upper lip. And then your salicylic acid peel sometimes on an atopic skin can give you this very brisk redness, and you have to warn the patient. If you see frosting, don't panic, just warn the patient. And my trick is I tell the patient that the peel, it goes to the bad areas of your skin and turns brown. So then they feel very happy. Oh, okay, so those bad areas will flake off. So that's a little take-home tip you can do so that the patients don't panic. Otherwise, they're all ready to sue. The advantages of newer peels is they are more skin-friendly, they are more patient-friendly, And the newer chemical peel formulations have evolved into skin-friendly blends that include biocompatible lactic acid, citric acids, buffering agents, licorice extract, all these for covering up all aspects of photo aging. And these with topical antioxidants to infuse the skin with restorative nutrients. So the end result depends on a holistic skin care. You cannot use chemical peels in isolation. You have to combine them with your priming, your skin care. If it's acne, you have to do your anti-acne, because we have patients who come to us and say, Doc, I've done acne treatment. I say, what have you done? And they say 4 chemical peels, but no acne treatment. So this is not chemical peels you use together. They complement your treatment. So you have to, that a single peel will not give you a dramatic effect. It has to be a series of peels. And the best part about peels is you can combine them with other modalities like lasers, Botox, fillers. You can mix and match, as the previous speakers have told you. So the take-home message is align treatment endpoints with realistic timelines, maximize the efficacy of the procedure by supporting priming and tailor skincare. Be master of a few peels. This is very important. Know your peels well. Pick up 2 or 3. Be master of them, because you can use them in so many applications. Recognize that every peel does not suit every individual. You have a potent weapon. Use it wisely. It's important to have a twinkle in your wrinkle, and the best way is a chemical peel. Thank you very much.
Hello. Thank you, Dr. Neena, for a beautiful talk. Now, Dr. Sukesh will throw light on principal types and preparation of PR.
Good evening to one and all present over here. So I'm here to speak on the most trending topic, PRP. Since we are running short of time, I'll be to the point. I'll end the talk with a small video demo. Now, before I start, no conflict of interest, and I declare no financial disclosure here. So this is what we want to discuss. Introduction, principles, types, classification, and how we prepare. Now, introduction. As we all know, PRP is a volume of autologous plasma that has a platelet concentration above the baseline. And it's used in various subspecialties of dermatology, trichology, and aesthetics because of its autologous nature, minimal invasiveness, absence of major side effects, and affordable cost. Now, what exactly is PRP? Now, we all know that the normal platelet count is around 1.5 to 3.5 lakh per ml of blood. The autologous PRP is a blood derivative containing the patient's own platelets concentrated from 2 to 7 times in a small volume of plasma. So how many platelets are enough will be the next question. Now, there are a couple of research articles which have thrown some light on it. Marx proposed that a platelet count of 10 lakh per ml of PRP as a working definition based on his scientific proof of bone and soft tissue healing enhancement. So, and there was also a study by Rogetti et al. Where they checked the concentration of platelets in platelet gel and its functional changes with respect to its activity on human endothelial cells. Now, what they did conclude, it's claimed that the proliferation of endothelial cells and its migration and invasion of endothelial cells occurs in a bell-shaped manner. Matlab, it's going to increase till one point, and after that, it's going to come down. It will not add into any further effect. Now, what exactly is this concentration? Now, when they compared it with endothelial cell proliferation in a dose-dependent manner, they had a maximum effect at around 12.5 lakhs. And with respect for test to angiogenesis, maximum stimulation happened at around 15 lakh per ml of PRP. So we can probably assume that a platelet concentration of around 10 lakhs per ml in a small volume of plasma can be taken as a working definition. Lesser concentrations probably might not be relied upon to enhance wound healing, but greater concentrations have not yet been shown to have any further enhanced effect. Now, mode of action, we are all aware, they contain more than 30 bioactive proteins. There are a lot of protein growth factors and also other cell adhesion molecules like fibrin, fibronectin, vitronectin, which have its stimulatory effect on angiogenesis, mitogenesis, cell growth, proliferation, and differentiation. Now, principles. See, we need to understand centrifugation over here because PRP is prepared by a concept called differential centrifugation. We all are aware that if we just keep a blood, anticoagulated blood, it's going to sediment based on various layers, based on its specific gravity. Plasma has the least specific gravity, it stays on top, then comes the platelets, then the WBCs, and at the lower end is the RBC with a higher specific gravity. Now you can ask, then why do we require a centrifugation? If we can just keep an anticoagulated blood, it will sediment, right? But here the issue is the length of the time for the separation to happen is a disadvantage. Second, there might be potential degradation of biological compounds, what we want in it to act. Hence, we have to know the concept of differential centrifugation. This is basically like increasing the centrifugal force. You put in a bit of more gravitational force to it so that it sediments quickly, and it's called as RCF. It is used in multiplication or multiples of Earth's gravitational field, that is G. So if we use a word called 600 G, we actually mean 600 times the gravitational force. The other abbreviations, what we usually come across is RPM, that is revolutions per minute. It is dependent on the centrifuge machine, what we use. The G force, the time is a centrifugal force which is used in a centrifuge machine to separate the constituents. Now, if we want to calculate what is the G, this is a very simple formula where if we know the radius of the rotor and the G which we have to use our centrifuge machine, we get to know the RPM. So you need to understand that the RCF and RPM is different for all the centrifuge machines. I often end up with questions, doctor, what's the G? What's the RPM I need to use? It differs. It depends on your radius of rotor in your centrifuge machine and the RPM. So what are the types and classifications? This is accepted classification by Ernfrest et al. Where PRP can be divided into four major classifications. One is pure platelet-rich plasma. When we use the word pure, we do not involve any leukocytes in it, and it does not have a dense fibrin network. The other component is leukocyte-rich. In this, along with after the first spin, I'm going to demonstrate, after the first spin, if you include buffy coat and a bit of WBCs, they become leukocyte-rich PRP. The latest one is platelet-rich fibrin. In platelet-rich fibrin, if we are talking about a pure platelet-rich fibrin, it has no leukocytes, but it is made up of a high-density fibrin network. So what we usually do is we make injectable PRFs. Before the fibrin network forms, we inject it onto the skin or face for rejuvenation. The last one is leukocyte and platelet-rich PRF. So how do we prepare? We all know that there are only two ways in which we can do, either a manual in-house method or commercial kits. Both require a centrifuge. For PRP preparation, the standard technique what we use is called cytopheresis method, where the first spin is soft spin, the second one is a hard spin. We going to draw the blood. This is how the whole blood is initially collected. For the first spin or the soft spin, we put it into a centrifuge. This is how the layers get segregated. The upper layer consists of platelets, WBC, the middle one, the buffy coat, and the lower one, the RBCs. We take only the superficial part. I usually take, the upper part along with the white blood cells and also a bit of RBCs. You transfer, you do a second spin, and you end up with a platelet plug. You homogenize it before you inject. Now, there are a lot of platelet activators, but honestly speaking, in my practice, I don't use an activator now because collagen itself, which is present in the skin, is known to be an activator of platelets for its degranulation. Now, with respect to commercially available kits, there are numerous kits which have come into the market now. They were initially divided as a lower or a higher PRP device based on the amount of platelets which is derived from the baseline concentration. But this is just a simple table for us to understand the advantages and disadvantages of each. The double spin method which I use is actually open method, but in PRP kits it's closed. It's a bit more sterile. Double spin method requires a bit of expertise to do, but PRP kits, it's pretty easy. You have to probably do a single spin. That's why the yield is less. Double spin is always cost effective. The in-house and PRP kits can be a bit of more cost. I would like everyone to read our research paper on principles and methods of preparation of PRP. I'll end it with a small video demonstration. Can we have the video, please? Kolu? Okay, so here is how I do it in my practice. We put a small tourniquet. You can draw the blood either by a vacutainer or by a butterfly. I prefer a butterfly one. I draw around 36 ml of PRP with 220 ml syringes. I always have my assistant who helps me out with the procedure. So these are 2 syringes which we used to draw around 35 to 36 ml. And this is then transferred into the test tubes. This is a ACDA test tube, which has around 1.5 ml of anticoagulate substance, and we put in around 8.5 ml of the blood in it. So it's collected in 4 tubes, and we're going to gently, of course, this is in a fast forward motion. So we gently make sure that it is mixed properly. We keep it in such a way where it is, equally distributed on the opposite corners. In my practice, I use around 3,600, 3,000 RPM for around 10 minutes for my first spin. And after the first spin, this is how the layers get separated. So now with this, I usually use a sterile pipette and also a sterile plastic tube to collect the upper part. I usually take a bit of buffy coat also and a bit of RBCs, because I feel that platelets are always present a bit even in the upper RBC layer. So it's never like that, straw colored or that liquid gold, what a lot of dermatologists post on social media. It's actually a bit reddish when you, if you want to get a bit of more platelets in it. So this is how we put it into the second spin. In my practice, I use around 3,600 RPM for around 6 minutes. And we need to keep on checking our platelet values. That's how we are sure that we are hitting minimum around 10 lakh per ml of platelets. I'm almost done. Just give me a minute. So now you can see that platelet erythrocyte plug, which is pretty evident. We discard the upper 2/3 from the tube. That is basically PPP, which we do not want. We need a good concentration of platelets. So we draw almost more than 2/3 of it from each tube. So you can make out that hardly around 2.5 ml is what is left at the end. And then we homogenize this pellet into the plasma, and so this is how it looks. Hardly around 2.5, 2.5. You get around 5 ml from a draw of around 36 to 40 ml. So this is how we homogenize. So most of the PRPs, what I prepare are bloody PRPs. Okay, it's not that straw colored what is being promoted. I take it in a 1 ml syringe with a 18 gauge needle. Then I use this 31 gauge needle on that 1 ml syringe, and I'll just show you a bit of injection technique over here. So we need a spirit better than spirit. I don't believe in any topical anesthesias. I give a sort of a ring block. Most of the hair transplant surgeons would agree with me that there is nothing better than injecting. So I don't inject more than 2.5 to 3 ml for the anterior area. And I use a combination of lignocaine with adrenaline. It increases the effect of the anesthesia. I don't have the volume over here, but it's not as painful at all because we do it very slowly. And you can see I also do it with a vibrator. You need to clean the area with spirit, better than spirit, separate it nicely. And with a distance of around 1 centimeter, we try to inject around 2 to 3 units, so that with 5 ml, we're going to cover the major part of the front end on the top. So, yeah, not taking much of your time. Most of them are aware with the injection technique. So give good space, at least around 0.5 to 1 centimeter. You need to see that bleb. So thank you so much. All your doubts probably will be addressed during the live demo session. Thank you.
Thank you, Dr. Sukesh, and we understand it was a topic worth, much more time, and you tried to cover it up so nicely in the given time. Now I invite Dr. Suruchi Garg. She will be talking on another topic, which is like can be discussed for the full day, but let's see how she sums it up in 10 minutes. It's on partial efficacy, inadequacy, and complications of PRP therapy. Dr. Suruchi.
Good evening, everyone. Thank you, Dr. Sahil, Dr. Madhuri, for making me a part of this wonderful esteemed faculty. This is the last topic of the session, and I hope you have the energy to be here with me. So I'm going to talk about partial efficacy, inadequacy, and complications of PRP therapy. Regenerative medicine is one of the fastest growing branches in intervention dermatology and trichology, and PRP as a cell therapy has established its firm footing in various difficult to treat disorders. In my opinion, no amount of external medications can ever match the infinite potential of body's own healing substances, and PRP is one such elixir. So I would call PRP along with its new generations as the futuristic elixir because it has been used in multiple indications in various dermatology settings. In our clinic, we're using it for FUE hair transplant with PRP therapy as monotherapy for various types of alopecias. And we have innovated our own vitiligo surgery called LAPIS, which stands for laser ablation of recipient area with PRP enriched epidermal suspension transplant. We're using it for facial rejuvenation as a vampire facelift, along with the combination of MNRF and Erbium laser. And also the same combination is used for post-acne scars, post-traumatic scars, burn scars, and stretch marks. And of course, PRP is also being used for non-healing ulcers. Now, there's also indication in pigmentary disorders like melasma, lichenoid disorders, and post-inflammatory hyperpigmentation. Now, this is the system that I'm using. This is called centrifuge, Remicold centrifuge, and I'm using Renewcell kit. And you can see the buffy coat here quite clear in the picture, in the just above the RBC layer. And on top of that, you have the PRP in the bottleneck area. We use 3200 RPM for 4 minutes, and this is a single spin method. And RCF is 1350. Now, first of all, let's take up the inadequacy of PRP. We all know that there's no standardized protocol for the PRP preparation, and there is single spin method, double spin method, and also there's a lot of confusion regarding the platelet concentration. So this systematic review says that the current reporting of PRP preparation methodology and the final composition is inconsistent and insufficient to enable the comparison between the studies. So we don't have a consensus that what is the right preparation, the single spin or the double spin. Like the current literature is not sufficient enough as of today. Second inadequacy is the controversy over magic number, as Dr. Sukesh rightly pointed out, 10 lakh to 15 lakh per ml. So whether this magic number is actually the truth or the hype, I would like to point out here that there are various new generations like IPRF, APRF, and PR, FMR, even the newly launched GFC, the growth factor concentrate, are less concentrated than PRP, and the molecular studies versus clinical studies need to be performed to see the actual difference in the clinical outcome, whether the magic number is really required to hit that kind of clinical efficacy, or we can do with lesser platelet concentration also. So here I'm sharing with you my randomized controlled trial, which is published in Journal of Cutaneous and Aesthetic Surgery. This is randomized controlled trial comparing the efficacy of PRP during FUE hair transplant with placebo, which was normal saline. And these are the pictures. So first is the placebo group and the second is the PRP group. And you can clearly see the difference in the density at 1 month and 6 months duration with the PRP group, which is definitely doing better than the placebo group. Now coming on to the partial adequacy. So we had injected PRP during the surgery, and you can clearly see that the grafted area, which is like the frontal and the vertex area, is doing well at 1 year of transplant. But in the native hair, we can see the thinning. So we all know that the effect of PRP starts waning off after 1 year of injections as monotherapy or in hair transplant. So this is a type of partial adequacy because, the effect weans off and you need the top-up procedures. But in the grafted area where we've done the transplant, the results are good and they're maintained at 1 year. This is a very difficult case of frontal fibrosing alopecia, and we've done a few hair transplants with PRP therapy. Well, I was really happy with the results, but the patient was not. So this is, I'll say, work in progress, because in such scarring alopecias, you need subsequent session with maybe the fat transplant and subcutaneous and PRP therapy, and then you can do another hair transplant to increase the density. This is another case of scarring alopecia, post-cleft lip surgery scar, where we've done the FA hair transplant with PRP therapy. So you can see that the overall, the results are there, but the density is not as good. Of course, the scarring is there, so the take-up of the graft is not as good as is there in the normal skin. But definitely the PRP thing helps in neovascularization and take-up of the transplanted graft over the scarred area. But we need more density and more work here. Now, I'm sharing these two papers, which were published sometime back as a PRP as a monotherapy in different types of alopecia. And this is the first one where we've said this is an elixir, and we've shared our personal experience on 117 patients with review of literature. And we also proposed this golden anchorage model and molecular locking of ectodermal and mesenchymal components for hair follicle integrity and survival. Now, this model also shows you how PRP works at various areas around the hair follicle. You can see that it is working around the neurovascular bundle. It is working at the dermal papilla and the arrector pili muscle, and also the golden anchorage, which comprises of the basement membrane, the bulge portion of arrector pili muscle, and the stem cell region. So practically for every cell and tissue around the hair follicle, PRP has a growth factor to work upon, and no doubt it is working so well in hair therapy. These are the results in endogenetic alopecia, and you can clearly see the effect of increase in the diameter, density, and overall skin texture. Now, here is the partial adequacy. This is a case of female pattern hair loss, and you can see clearly new growing hair follicles after 6 weeks of PRP therapy. Well, I was happy with the results, but the patient was not. I would say in such cases, the hair transplant is a better modality if we really want to attain a good patient satisfaction. Now, I'm sharing this. I still have that. Now, I'm sharing this LAPIS surgery. This is a triple combination of pixel erbium YAG laser, PRP gel, and trypsinized epidermis. And we're using it for vitiligo surgeries. Here we have the results after 6 weeks of surgery, and you can see very fast repigmentation with the triple combination. And this is the partial adequacy again. So we all know that acral areas are relatively resistant to treatment, but there are signs of repigmentation, but not as good as over the face and other areas. So we need more work here. Now, this is a case of crush injury over the heel area, and this patient was given a pedicle graft. The patient came to me with repeated trophic ulcers, and we did a triple combination: erbium YAG laser, PRP therapy, and fat grafting. The patient started having his sensations back at 4 months interval, and there were no trophic ulcers. 3 years later, he sent me this photograph, and he had only partial area of anesthesia. So overall, I would like to draw your attention towards improving texture of the skin, but still he had a small anesthesia, and I think he needs more work. This is rewarding, but of course, there is partial adequacy. This is a case of post-burn scars. You can see improvement. Again, quite rewarding, but yes, not 100%. Now, these are the results in facial rejuvenation, the crow's feet improvement, but you can still see the scars. Again, the post-traumatic scars, you can see improvement in 6 scars, but 2 scars are still there. This is a case of lichenoid disorder, pixel erbium YAG with PRP therapy, and you can still see the pigmentation, but there is a lot of improvement. Now, coming on to the side effects and the complications. So during the preparation, you can have bruising or ecchymosis at the phlebotomy site. There could be clotting of the blood sample, as is visible in the second photograph, and there can be complication due to the actuator, due to the bovine serum or calcium chloride. During procedure, the maximum allergic reactions are caused by mismatched samples. The pain can be taken care with the topical anesthesia, cream spray, or nerve block or field block. The burning sensation usually lasts from 30 seconds to 2 minutes, and ice packs help. And even this is a sign of activation of platelets. I would say that, contrary to what Dr. Sukesh said, RBCs on the face, try to avoid injecting RBCs because they can be painful because of potassium release, and they can lead to post-inflammatory hyperpigmentation later. But it is completely fine to have it on the scalp. So after the procedure, there can be local complications like folliculitis, swelling, ecchymosis, more so around the eyes. There are neurological complications like headache, insomnia, excessive sleep, and there is ocular complication, which is blindness and very scary. So these are some of my patients. I can show you the swelling around the forehead. This was after the ring block. These PG-like lesions I've seen after FE hair transplant and PRP therapy, and like I've seen them in LAPI surgery also. They spontaneously subside after 2 to 3 weeks, but bother me sometimes. And this is the complication I'm talking about, the blindness after PRP therapy. So this case was reported in 2017, and there was injection of PRP probably mixed with filler or fat, and it led to the occlusion of middle cerebral artery and ischemia of frontal and parietal lobe. Here we have the histopathological picture, and it shows the foreign body granulomas. Just few slides, please. And most likely this was a foreign substance, so maybe filler. And of late, I would like to draw your attention towards more case reports which came in 2020. And this case report tells about 4 cases of blindness in mid-facial area. The PRP injections given around glabella, nasolabial fold, and in the periorbital area, and it led to blindness. Now, we need to be aware that we are in COVID times. Patients can have hypercoagulable state, and in certain vaccines, they have this complication called thrombotic thrombocytopenic syndrome, where you can have multiple clots in your blood vessels. So we need to be very, very careful while injecting around the periorbital area and glabellar and nasolabial area. So the carry home message is that platelet-rich plasma is a futuristic elixir which can be used as a monotherapy or in cocktails. And if used judiciously, it can help us to improve the overall environment of hostile area, and it takes care of various ailments, permanent scars, secondary to burnt out diseases. I would like to call it as our own dragon soldier with fire, because we're injecting very high concentration of live cells, growth factors, whose long-term endocrine, paracrine, and enzymatic effects are yet to be deciphered, and we need many more years of experience to decipher that. Thank you.
Thanks, Dr. Suchi, for clearing most of the doubts, and the rest will be taken care in the hands-on session.
Thank you, chairpersons. I request the delegates who have registered for the PRP and PEELS workshop to move to the workstations. The faculty are waiting for you, as we are to finish by 7:30, so the gala dinner on time.
Hello? Hello, am I audible? Hello, can I get a confirmation? Am I audible?
Hello.
Yes, sir. Yes.
Audio आ रहा है ना?
Yes, all right.
Okay. Okay. Good evening, everyone. Now we are at the workstation number 1, where we'll demonstrate PRP. Today we are demonstrating PRP commercial kits from T Lab. T stands for Turkey. They have their own centrifuge machine and they have their own kit. Can you zoom in a bit? What I say? So here, like we discussed, it's a commercial kit for PRP preparation. It comes with the entire test tubes, the vacutainer, the needles. And also with the same system, you can inject. Now, what does it basically contain? It contains 2 tubes for the initial blood draw, which has around 1 ml of sodium citrate, 3.2%. We need to draw around 9 ml of blood, which will come up to 18 ml in total. Now, this will be kept for centrifuge. We have already done the centrifuge over here. Now, once that is done, we're going to use the other tube to take around 2 ml, the lower part of 2 ml, which will be shifted to a single tube. So we end up with around 4 ml of PRP with this preparation. It's going to be homogenized. Once it is homogenized, we have a syringe to take that 4 ml of PRP out using a huge needle, and it is then injected with 26 gauge needle for the injection. So it comes with a complete sterile pack. We have drawn the blood. We have used vacutainer concept over here. If you can zoom in a bit, it comes with a small vacutainer needle and a vacutainer adapter. So using this, we have actually drawn 4 test tubes of blood, which accounts to almost around 36 ml. It has been centrifuged. I know the parameters. Okay, it has been centrifuged for 8 minutes with 830 RPM RCF. With RCF, can you open it? We're going to show you how after the first spin, the segregation happens. So this is a plastic tube. So we used 4 tubes. And from here, we're going to take only the lower 2 ml from each tube, which has PRP concentrate. Can you show them how you take out? Yes, we'll demonstrate that. So we're going to show how that 2 ml is being drawn out. You can show it to the camera. So this comes with the kit. That's the cannula. Yeah. So that's a 18G spinal needle. Okay. So they are releasing the vacuum by using a 22 gauge needle here, and then you can do it. You can show it. Can I hold it? So yes, is this visible? So we are trying to extract the PRP, which is the lower 2 ml. Most of the PPP, platelet poor plasma, will be on the upper part. So we just go above the RBC layer and harvest around 2 ml from each tube. Now we do the same for the next 3 tubes, and then it is homogenized. Using the same syringe, we're going to just change the needle and we go ahead with the injection. Now for the patient, like I showed during my video demonstration, we're going to do a bit of ring block anesthesia. So we're going to catch up with you again once the ring anesthesia is done for the injection techniques. Over to the next workstation. Thank you.
Am I audible? Hello, everyone. Am I audible? I think so, right? Okay. Okay, so I'm just
It
going
was
to
audible.
demonstrate
Whatever.
that how we do the ring block. And I'm going to anesthetize the whole area, the whole cap area. And just a second, I'm just here after the talk, so some preparation time is needed. So basically, the most important thing while you're injecting PRP is that the procedure should be painless to the patient, right? Otherwise, the patient is not going to come back to you for the second procedure. For him, the results are later, it comes after 3 weeks or 6 weeks or so on. But what is really important is that the procedure should be painless. So the first thing is very important, that how you calm down the patient. Always talk, interact, and tell him what is the procedure which is going to be done on him. So we've done the cleaning here. Cleaning of the scalp is already done. Just clean the scalp, please. So I have a volunteer here who's cleaning the scalp. Ring block, yeah. Yeah, okay. All right. Yeah, the whole area. We need to clean the whole scalp area very thoroughly, right? Yeah, one more. Can I have the gauze? Gauze. Gauze. So अभी जब मैं एनेस्थीसिया लगाऊंगी, आपके यहाँ पे हम लोग इंजेक्शंस देंगे और ये पीछे तक सारा कवर करेंगे. जब आपके इंजेक्शंस चल रहे होंगे, तो आपको ब्रीदिंग पे फोकस करना है, ठीक है? और ये आपको टैपिंग करेंगे, उसके ऊपर ध्यान देना है. So we can either tap the forehead or we can use a vibrator. एक और स्वाब दे दीजिए. ठीक है. ये आप करवाइए. ये वाला करवा दीजिए. वो उनको ब्लड दे दीजिए. All right, so we're starting with the ring block now. आप आराम से पीछे से लगा लीजिए और डीप ब्रीदिंग पे ध्यान देना. आप टैपिंग यहाँ पे करेंगे, ठीक है? So here is the first injection. Relax, keep yourself relaxed, ठीक है? लंबा सांस लीजिए. हाँ, अपना ब्रीदिंग पे ध्यान देना आपको, ओके? रिलैक्स, जितना रिलैक्स रखेंगे उतना आसान रहेगा. टैपिंग पे ध्यान दीजिए और ब्रीदिंग पे ध्यान दीजिए, ठीक है? Okay, so you need to keep on pressing the previous areas so that there's no bleeding. Are you fine? Should I give you some rest? You okay? Okay. So go very slow, very gradual, and take some time. There's no hurry here. The patient should be relaxed. Focus on breathing. In case he's not feeling good, just take a little rest. Okay? Better? So the only rule is to go very slow. This side. Chico? Focus on your breathing and tapping, please. So we have done the front line. Sorry. Ideally, I like to do the back area also the same way. All right. So we'll be covering the whole area the same way. Over to the next station, please. Okay.
That's the black peel. Comes in a small bottle of 10 ml. So that's a black peel. It comes in a bottle of 10 ml. And usually if you're doing the whole face, you need about say 1 ml. Or you could just work on the concern areas. So in that case, you need about 0.5 ml to maybe a little lesser. So for her, she has acne all over. I'll probably still take about 0.5 ml. It's usually good enough to just apply a light layer all over. You also have to remember that if you've done a comedone extraction, the skin is bound to be a little sensitive. So a thin layer is usually all that's needed. What do you expect after you've applied the peel? Now, generally, you keep it on for about 2 to 3 minutes or till you start seeing frosting. So post that, you can neutralize it with water. And then after that, you apply your sunscreen or your moisturizer, depending on the time of the day, right?
So the frosting we'll get is a pseudo frost because of the salicylic acid.
Better if possible to do the comedone extraction a day before or like a couple of days before.
Yeah.
Have that option. You can do that. It all depends on what are you seeing on that day. Like in her case, probably yes, a comedone extraction, no, she does have. In fact, it would work pretty well. If you don't want to take that chance of causing a lot of inflammation and then applying a peel, in that case, you can do your comedone extraction a week before and probably then apply the peel. The advantage when you do it on the same day is that you are helping also penetration of the peel into those areas and works a little better on those areas. Right?
So again, you are evaluating the patient. Now with her, she has such a sensitive skin. I would just apply the peel because the salicylic acid anyway will get absorbed by the sebaceous glands. So she is anyway going to get a good effect. So now a very thin layer is being applied.
Using a brush which is thinner than this is better because in that way you don't take up too much of the peel. Now, once you've dipped your brush into it, remove the excess peel, make sure that there's no dripping which happens.
So I'm going to ask you a question which these people may ask you is, what happens is if you layer it? Yeah. That's
You can do multiple layers as well.
the only issue is that with salicylic acid, when you do a single layer, you'll get frosting. So then to reapply on a frosted area doesn't make sense.
And trust me, even a single layer works pretty well.
And the first time you're doing it, be less aggressive.
Slight itching and tingling sensation. On your lips, take your lips.
You feel like scratching your face, no? Is it too bad? Bearable. Yes. So the sensation she describes as a bleach. It's usually, you leave it on for about 3 minutes. Not really. When we talk of time, the application is done in how much time? It was hardly 20 seconds. 20 seconds is not going to make such a major. It's not like, oh, the alarm has to go. It's not like that.
You can do a little bit of spot neutralization in certain areas where there is more frosting.
So you can see a very good frosting here. On the where the comedones are, you can see a very good frosting.
which is a quicker way of neutralizing. If you don't have a spray bottle, you can just dip yours in water.
See, you can already see her skin is getting a nice shine. Can you see the change? That's the beauty of salicylic acid. It gives you this lovely sheen. The only thing is when you spray with the bottle, please be careful because if it drips into the eye. So, yeah, and then spray. See, immediate rejuvenation. Your skin immediately is looking good.
Frosting is to be expected, and you could have frost. So mostly the frosting happens in the on the active acne, but you could also have frosting in certain sensitive areas, especially where people have seborrhea or maybe a little bit of rosacea component. Or can atopic. Yeah, true.
Especially if you see a patient with pityriasis alba. Be very careful. So let your antenna come up that be careful. Because atopic individuals tend to hyperreact. Whatever you do, they'll hyperreact. Skin is looking very nice. And if you notice, her nose has the shine. Why does her nose have the best shine? Why does her nose have the best shine? I'm asking them. Huh? Why does the nose have the best shine? Come on, folks. Yeah. Because the maximum sebaceous glands are there and the salicylic acid has concentrated there. So you'll find the nose getting the beautiful shine and smoothness. So if somebody comes to you and says, my nose is so rough, it has so many comedones, do a salicylic acid. Any burning now? Okay, she's done. Frosting, but it disappears. It turns into erythema, and then next day you may have a little scabbing. Yeah, you may have a little scabbing. So if you have the erythema, where just take any mild steroid cream and apply it. Okay, because you don't want the pH. So a lot of times steroids are life-saving in a peel. No, clinic, at the clinic.
Hypotensive steroid at the clinic and send them off. And it's always better that you apply it yourself instead of asking your staff to, because you don't know where all are they going to apply and how much are they going to apply. So when you finish with the whole thing, you also have to make sure that you're removing whatever Vaseline or the occlusive ointment that you've applied, because you don't want that going into the eye. Okay, this all must have gone with me anyways. Okay, open your eyes. All okay? Cool.
Your skin is looking so good. Do we have a mirror?
The redness is already going down, but you will have some amount of redness till probably tomorrow, day after, that you have a little dryness.
Recording stopped.